health, hope and harmony. Today we have a mixed bag CME comprising of topics on nutrition, gynecology, infertility, andrology and cosmetic surgery to provide a multifaceted insight on innovations in these different fields. Any piece of knowledge I acquire today has a value at this moment exactly proportional to my skill to deal with it tomorrow. Today's CME is divided into 3 sessions for convenience, and session 1 comprises of the following topics. Session 1, Fueling Care, Nutrition Tips for Gynecologists by Dietitian Kalyan Ravada. Robotic, there's a small change. We have the second topic as Robotic Gynecology and Uterine Transplant by Dr. Padma Priya Vivek. Energy-based devices in cosmetic gynecology beyond lasers and RF by Dr. Navneet Magon. And to chair this session, I would like to invite Dr. K. Subbaraju sir. He is the former Additional Director of Medical Education. He is a former Professor and Head of the Department of Obstetrics and Gynecology, Andhra Medical College. Retired Civil Surgeon, King George Hospital, Visakhapatnam. He was trained in Advanced Gynecological Endoscopic Surgery, 1993. He is life member of Indian Association of Gynecological and Endoscopics, IAGE. He is life member of Society of Fetal Medicine. He was the president of Obstetrics and Gynecological Society of Visakhapatnam, 2018 to 2019. He has edited and published 2 books in obstetrics and gynecology, a practical handbook on obstetric emergencies in 2011 and a practical handbook on intrapartum care in 2016. Next, I would like to invite Dr. Y.L. Narsingh Rao sir. He was the immediate past President OGS Vishaka 2024 to 25. He was the Secretary of OGS Vishaka 1997 to 99. He is retired Professor of Obstetrics and Gynecology, King George Hospital, Andhra Medical College, Visakhapatnam, and has a teaching experience of over 26 years. I welcome you, sir, on the dais. Next, I would like to invite Dr. M.N.V. Pallavi. She is a Senior Consultant Obstetrician and Gynecologist, Director of Her Clinic, Specialist in High-Risk Pregnancy, Laparoscopic Surgery and Aesthetic Gynecology. She has done her MBBS from Andhra Medical College and MS from Kasturba Medical College, Manipal. She has worked at Bombay Hospital under Dr. Pai Dungar and learnt vaginal reconstructive surgery. She has received advanced training in laparoscopic surgery from Paul's Hospital, Cochin. She was a former consultant obstetrics and gynecology at Manipal Women and Child Hospital, Visakhapatnam. She was also former chief consultant obstetrics and gynecology at Giggles Omni Arche Hospital, Visakhapatnam. Her field of interest is handling high-risk pregnancy and advanced laparoscopic and hysteroscopic procedures. She is currently offering dedicated, holistic women care at her clinic in an effort to offer the best to her patients. She is a fellow in Aesthetic Gynecology, IAVA 2023. She was first in AP to introduce Tesla chair for incontinence treatment and postnatal rehabilitation. She has participated in many conferences and workshops as delegate and faculty. I welcome you, Madam, to chair this session. And now I hand over the proceedings of this session to the chairpersons.
Good morning to all the delegates. So I invite the first speaker, Mr. Kalyan Revada. He is a consultant dietitian and he is Chief Dietitian Medicine Hospitals Research Associate, and he had MSc in Food Science Nutrition, Pondicherry Central University, UGC NET qualified PhD researcher, certified in Psychology of Stress, Health and Well-being, and is worked as an assistant professor of Foods and Nutrition Dietetics. 4 years experience in clinical and therapeutic nutrition and diabetes, thyroid, weight management, women's health, maternal nutrition, PCOS care, hospital menu planning, corporate wellness, customized and personalized patient diet planning and counseling. Now I present to you Kalyan Raveda to deliver his guest lecture.
A very warm morning to one and all. I'm Kalyan, a consultant and bromatologist, means food scientist, and here I will explain you the topic of fueling care, especially for gynecologists and all the doctors and all the dignitaries here. And let's get started. So why the focus of nutrition matters a lot for gynecologists, not only gynecologists, to all the doctors and to all the dignitaries here. So because these days all are leading the mechanical life, and that leads to poor meal patterns, especially skipping the meals. This leads to especially the weight gain, obesity. So as you have the long shifts and high stress, poor meal patterns, so the first step we have to correct the mistake either in professional and personal life, balancing your meals. So because a healthy doctors always ensures a better health care. So is that possible? Yes, it is possible. So let's start from the beginning of our day, where actually the biggest mistake usually happens with breakfast. Because as long working hours at midnights and all, as all the doctors, you may face these all poor meal patterns. So when you are skipping the meals, it disrupts your energy regulation, as it leads to low downs your metabolism, and it leads to irregular blood sugar levels, and finally leads to changes in your weight. So when your early fuel gets decreasing, your concentration also will slow down, and it reduces cognitive performance. It finally leads to increasing the hunger and overeating, and finally it leads to overweight or obese class 1. And so we have to fix this mistake. So as dietitian, to all of you here, I suggest to replace your refined flour with all the oats flour. Why I prefer this oats? So because the oats are rich with avenanthramides, flavonoids, and which has the potential benefits in increasing antioxidant properties and anti-inflammatory properties too. So using oats as a base in breakfast, especially either as a smoothies or oats besan chilas, it's like a vegetable omelette. To all the vegans or the vegetarians, oats besan chila helps a lot in increasing the protein along with the fiber. So it leads to reducing the constipation and also maintains heart health. So here I have showing you the three pictures. One is Besan Sheila, where it is rich with the protein and the fiber. So where it helps in a lot to treat all the metabolic conditions. And also the second picture to all the young ones especially helps a lot, which is banana oat smoothie. And the third is oats idli. So usually we make idli, dosa, these type of things in the breakfast, right? So why can't we replace the rava, what we used in the idli or dosa, with the oats flour? That will enhance the fiber intake to our body. So why as dietitian I prefer oats? Because as it is rich with high in fiber and satiety, like beta glucan and peptide fiber and GLP-1, these are the gut hormones which reduces appetite. So when you are in the weight loss program or when you need to weight loss, so including the oats in your breakfast leads to reducing your appetite and feeling full for your stomach. So, and it gives you the steady energy boost and the antioxidant rich like avenanthramides and the soluble fiber, and you can make the quick, versatile and nutritious and innovative recipes to balance your meal. And next, when you went to work after having the breakfast, just take a short break at 11 AM in the mid-morning to have some healthy snacks. Especially, I prefer the seasonal fruits because those won't be repeated throughout the year. So seasonal fruits are most useful. And also sometimes here I want to break one myth. So generally people used to consume green tea with the empty stomach for the weight loss especially. So here the myth is we should not consume any herbal teas. Herbal teas is okay, just green tea which is rich with the catechins and EGCG and epigallocatechin gallate and the catechins and the tannins. These includes when you are including in the meals, especially with the empty stomach, which also increases the acidity in our stomach, leads to stomach irritation, increased acidity, and also reduces iron absorption and variable tolerance. So as dietitian, I suggest you to consume, if you have the habit of consuming green tea, the 11 AM after the breakfast will helpful a lot for you all. Also, it helps in increasing or metabolism. Okay, so consuming with empty stomach is really harmful, especially the reaction with HCl and the tannins leads to stomach irritation. Hope you understand. And the next is after having the mid-morning, and the next is lunch. So eat right at noon, stay active till noon. So why I really want to say this? So just question yourself, are you having a proper balanced meals here? Let me tell you what is a proper balanced meal. So you have to be with carbs of 40% in your meal and 40% of protein in your meal and 10% of fat and 10% of dietary fiber, which means the protein which enhances our muscles, and also when you are balancing your plate, you have to choose all the whole foods, especially not only the millets, we can also have the rice, dal, curries, whatever. But I'm just explaining you to replace some curries with innovative curries like soya keema. Like I'm displaying here the basic picture that we used to have like rice, dal and curries, but the second picture is soy mutton curry. It is not mutton, it is like, it looks like a mutton. So here the rice, dal, curries are okay, fine, but quality and quantity matters a lot. Because in a day we can't cover all the nutrients at a time. So at least in a week, are we covering? So we have to question that, and balancing the meals in a day, we have to schedule accordingly. Like protein plus iron plus some vitamins weekly thrice, and carbs, dietary fiber and fats weekly thrice. So balancing a meal like this will help us a lot. And including the methi. See here I have explained the picture of methi teplas where it is enriched with iron, and especially the women facing with the anemic conditions helps a lot with iron and protein combination, as hemoglobin, heme plus iron, protein plus iron. So combination of protein plus iron consumption will enhances our all metabolism a lot. And next is snack smart, stay sharp, evening time. So we will have some chai, biscuits like that, right? So we have to replace that with some protein options, especially So here I use it to suggest as dietitian as makhna, full makhna, as it is low GI glycemic index and it is rich with flavonoid and also antioxidant called camphorol. So that reduces the risk of all chronic diseases, and high in plant-based protein to vegans and vegetarians, it helps a lot, and also gives the texture of popcorn, so feels good to eat. And it also rich with magnesium and potassium and regulates the blood pressure and supports heart health. And also it does not react with HCl well, so it is alkaline, it is not will be acidic to our stomach, so it won't create any irritation. So any age group, at any age group you can consume this makhna. So here I want to explain one topic that about Nirmala Sitharamanji, our finance minister. She realized that makhna has lots of protein and helps in a lot in our daily life. So she started and she approved a project in Bihar to start the makhna unit. And next, finally, the dinner. So you have to focus here is my motto: light at dinner makes you feel bright, because up to the evening we have to consume all the protein plus mineral content foods, but coming to the night you have to be feel light, because the light foods helps us a lot in sleeping. You should not be heavy, avoid all the heavy and fried foods, and you have to consume before 2 hours of your sleep. If you are sleeping at 9 o'clock, consume by 7 or 7:30. That should be a mandatory to make you feel light for your sleep bright. And hydration and herbals matters a lot during summer especially. So my choice is, as dietitian, I prefer salads at the night or porridges according to the season. Salads are best for weight loss and light digestion, especially in summer, as it hydrates our body, like having the cucumber. So these salads helps us a lot in hydrating. So in summer we can choose a salad, and coming to winter we may have the weak digestion, right? So we can have some porridges like javas, any millet porridges or any cereal porridges, anything. So my choices in best vegetables for salad: cabbage, broccoli, carrots, bell peppers, beetroot, cucumber, tomatoes. Here you may have seen all the vitamins and minerals rich only, because in the lunch I have covered carbs, proteins, fats, dietary fiber. So in the dinner I am covering vitamins and minerals. And coming to warm digestion and easy to digest, porridges are most preferable, and either we can make with the cereals or with the millets, anything is fine. But here you can have all the seeds which are omega rich, omega 3 or omega 6, as especially all are having a hair loss, alopecia majorly. So that could be covered with including flax seeds a lot in our meals, and also having some buttermilk to cool our body at the night before sleep helps us a lot. Thank you. And now the question and answer session begins, because the clarity in nutrition leads to confidence in choices. So please ask if you have any questions. Yes, actually major of my clients are also asked this same question. Flaxseed tastes very bad even when we soak the gel, which is viscous gel, which is releasing, does not able to consumable. So what I do is mixing with the jaggery or the dates. For the kids, jaggery is better. For adults, dates is best, because the sweet, most of the persons are having cravings for sweets, right? So seedless dates can be purchased and making it as a paste, then adding that flax seeds. Not only the flax seeds, you can also add the almonds along with it to get the crispy or crunchy texture. Then you can make it as a ladoos, or you can directly include the flaxseed powders in salads. That won't be that will be nice actually. Any other?
What about pumpkin seeds?
Yes, for especially the infertility conditions, the pumpkin seeds helps a lot. Any seeds and nuts helps a lot, but actually I prefer all the nuts and seeds by soaking process. The soaked nuts and seeds enhances the protein and amino acids in it, so will enhance our metabolism too. But not at the night. It could be consumable with empty stomach.
So peel the almonds. Is it?
Yeah, actually, raw almonds should be peeled as it is having phytochemicals. So the soaked almonds, all the phytochemicals will be released into the water will be thrown off, so then you can consume with the peel. The peel also having some antioxidants which is also helpful.
So here what you mentioned is almost 3 meals and 2 snacks.
Yeah.
But the fad in is the intermittent fasting, only 2 meals or whatever. So they still say intermittent fasting is healthy. So what about that?
Thank you, ma'am. That's a big and challenging question. Generally, in all social media where we see the intermittent fasting like 16:8, 12:12, whether it works, yes, it works. But what I suggest to my clients or to all you, let me tell you how we can adjust that. So finish your dinner by 7 o'clock, start your lunch by 7 o'clock. Breakfast. Start your breakfast by 7 o'clock. So you have the gap of 12 hours. So 12 hours you are doing fasting. So that helps a lot. So 12:12 ratio helps a lot.
5 meals in 12 hours.
Yes. So here the meal is even even cucumber juice is also a meal. As dietitian, I used to take that.
You have talked only about plant protein. You have left out animal protein. It's a personal choice or
It's my personal choice because
not everybody.
yeah.
It's based plant protein. You have not talked
Yeah.
about animal protein.
As protein are also combination with the fats, especially these days most of the persons are facing with the condition obesity. So the reason is all the non-veg, not the fish I am talking about, only the mutton or the chicken or whatever the protein sources are there. So it is just like 9 to 8 grams. But what we used to do for the cooking process, the oil will float in the chicken or the mutton. The non-veg curries will float in the oil. So that oil enhances oil metabolism a lot in our body. So I don't prefer non-veg as a protein source. I will prefer when they are lean and when they want to gain their muscle, not for the obese and all. So for the obese persons or for anemic person, plant-based protein helps a lot as it is rich with flavonoids. But the flavonoids will be absent in animal sources of protein.
It's your personal choice rather than what you're saying.
No, actually I suggest to all my clients to have the plant protein where they get lots of benefits than animal protein. Animal protein is also have the benefits, but plant protein compares it's more than animal protein. So that's why when I suggest, I'm a researcher, so when I have done the research on plant protein and animal protein, especially the sorghum, like we say jonnalu, that protein helps a lot, especially in weight loss or even in weight gain too. So when I have done the research, then I concluded that plant sources are far better than animal sources of protein.
Okay, one question. You said that you have to discard the water when you soak
Almonds.
almonds or dal and all those things. They say no 5 days with each one.
Yeah.
But then we used to see that even in the pre-complex vitamins and all are there in that layer.
So we are only soaking but not boiling. If we have boiled after soaking, that water having the B complex vitamins, but not only in the soaked water. The soaked water only will get the all phytochemicals, which is only the outer layer the outer layer of dals contains that. So that should be reduced because the phytochemicals, because the fertilizers and pesticides what they use, that all sticks to the outer surface of grains. So that could be discarded. So after once boiled, like when we are making the dals or any soups especially, after boiling we should not discard the water. That water has to be stored in a container that can be used for other purposes too. That having that all B complex vitamins.
One last question.
Yes.
Best protein source in legumes and pulses.
So chickpeas. The boiled chickpeas are the best source of protein, but it may create gastritis. So to not create gastric, we can do one a tip here. Soaking overnight of chickpeas helps a lot in that. And discarding that water and boiling that chickpeas enhances the protein intake and absorption too. Yes, eggs are good sources of protein. Per day 2 eggs, especially if you are only consuming the egg white, helps a lot than yolk. Egg whites helps a lot than yolk.
Thank you, Mr. Kalyan.
Thank you all. Thank you for the opportunity. A healthier world begins with you because all your dignitaries are doctors. So you have to be healthy to make all people healthy. Thank you. Thank you, Metsi.
I request the next speaker, Dr. Padmapriya Vivek, to come onto the dais to deliver her lecture. Dr. Padmapriya Vivek is the Director of Obstetrics and Gynecology in Glen Eagles Hospital, Chennai. She will talk on fertility medicine, robotics, gynecology, and uterine transplantation. And her achievements: finished Masters in Obstetrics and Gynecology, Diploma in Reproductive Medicine from Kiel, Germany, has 20 years of experience in the field of obstetrics and gynecology and conducted more than 25,000 deliveries, more than 10,000 gynec surgeries, and more than 10,000 fertility procedures. Leading robotic surgeon in India and a proctor in robotic gynecology. She is the pioneer in the field of uterine transplantation and to get license from uterine transplant in quaternary care in India. Performed 3 uterine transplants. She started a referral unit for high-risk pregnancy and a referral center for endometriosis with the Center of Excellence and Center of Excellence for Mullerian anomaly and uterine transplant. Started a stem cell therapy in Glen Eagles Hospital, Chennai. In 2024 Congress, first faculty representing India for the uterine transplant. Has been a faculty in many robotic and uterine transplant conferences, the state, national and international conferences. She worked in the 2015 floods for 90 hours and delivered 17 babies. Thank you, madam. I request you to deliver the lecture.
Thank you, sir. Thank you. Thank you, everybody. Good morning, and I thank Dr. Sirisha for inviting me here, and I wish her all the best on her new startup and many more to come to you, ma'am. So today, let me go through quickly because I think I've got too many slides. So this is my team, robotic surgery, Da Vinci Xi. This is my experience over 300 cases that we have done. If you see between open lap and Da Vinci system, I mean robotic system. See, in robotic there are many systems, but we use the Da Vinci Xi. So I've worked on others, but then I prefer Da Vinci Xi. So the length of stay, the operative time, the estimated blood loss, blood transfusions, ICU admit, and complications. If you look at the robotic, which is the dark blue one, it's very minimal. We literally discharge the patient within 10 to 12 hours of surgery, however big. We've removed a myoma of around 2.7 kgs, and yet she went home within 18 hours. She flew back to Kuwait as well. So literally no complications. And why is this system more advanced than laparoscopy? So there's always, a debate. Why not lap? We can do it in lap. Why not? I think you'll have to literally sit in the system to realize that and experience it. So why is it better? I'll tell you as we go down. And introduction to robotic gynecology, yes, it was introduced, but more than 1 million surgeries have been done world over. And if you look at that's the open option, then the traditional laparoscopy and the Da Vinci Xi system. Can we play all the 2 videos there, please? Yeah. If you look at it, now there is 2 things that I would tell. The instruments that we use and the camera. We have a 3D HD camera. It starts off with 10x magnification, and trust me, you can magnify it up to 40x with the same clarity. Now take your phone and just zoom. Go 3 times, you'll blur it. You'll blur what you want to see. At 40x magnification, you can see what you can't see with the naked eye. That means less than a drop of blood. So the first time when I was operating, I saw, blood there, and I was going, and then, my trainer, he told me, Dr. Arnold, he told me that is just less than a drop of blood that you're seeing, so zoom out. So you can zoom in and zoom out easily. Compared, even the dexterity of instruments, you have a 540 degrees, like you can do one circle and another half circle. So that you can't do it even with your own hand. And there is 7 degrees of movements, which definitely you can't get in laparoscope. So the degree of freedom, this is confusing, but I'll just tell you in short. This has 7 degrees of movement. That's all that we are trying to tell. So even the tip of the instrument can move completely. So that is not at all possible with laparoscope. So the reason why is when you're doing complex cases like endometriosis, fertility preserving surgeries, big myomas, especially for fertility preserving surgeries, you need to know your plane very well and dissect, and especially when ureters are really stuck and pulled medial, this will definitely help. So in laparoscope, yeah, maximum you can do 4, 5, 6, but with robotic surgeries you can do much more than that per day. So, you know, without feeling tired. See, I understand that when we are young, yeah, we can stand for longer hours, but when you sit and operate, the comfort is at a different level altogether. So your arms are rested, your knees are rested, you're looking into the console, and then you're operating. The console, especially when you take your head out, there are sensors by the side, infrared sensors. So the moment you take your head out, even if you're trying to move your instruments, it's locked. Unless it sees you sitting inside, unless you put your head back inside, it doesn't move. So there's a lot of safety protocols actually in robotic surgery. Let me play this for you. This is the console that we generally operate, and you see the foot sensors right there. Extremely, this is a beating heart, but then I took this video. This is not a gynecological procedure, but I took the video as to how we can operate, and there is a swap pedal. So you have a camera, you have 4 ports, all are in the straight line. You have the camera, then you go on the left side, you can have your bipolar forceps, then your scissors on the 3rd arm, and on the 4th arm you can have like a needle drive to retract. Now the 3rd and the 4th arm you can swap. So you don't need any assistance at all. Now what are the procedures that we can do is hysterectomy, of course, malignant and benign, lymphadenectomy, because we have a technology called Firefly technology, I'll come to it, parametrectomy, salpingectomy, oophorectomy, adnexectomy, cyst removal, myomectomy, endometriosis resection, and sacrocolpopexy. I would tell you later on why these procedures are advanced in robotic very soon. So coming over to the potential value of Da Vinci systems in myomectomy. Now, as I already told, there is a 3D HD vision which allows you to stay oriented in the anatomy. Actually with this camera, there's 30 up and 30 down. So you think you have a posterior myoma. You can actually flip the camera, look down, and you can actually stare at it and operate. That kind where you don't have to keep telling your assistant, come closer, now, you know, look up, now look down, nothing. You just flip the camera. And with that kind of precision, trust me, I was primarily an obstetrician and fertility specialist. Once I got this robotic system, I completely fell in love with it. So because of what I could give the patients and what kind of accuracy I can achieve, which I couldn't achieve in laparoscopy. So coming over, so you can see the tissue planes clearly, you can identify the structures. During myoma removal, we also use a tenaculum. It helps in retraction and levering the myoma around, so it makes life very easy. And there is a wide range of motions to help simplify the port setup and provide greater reach into the patient's anatomy. So you know, in deep endometriosis, especially when it is near the rectum, it's so easy to operate on it with the Da Vinci system and the instruments provided. And it allows control of up to 2 instruments with either hand and the one with the opposite hand. So you use both the hands and then you can swap the instruments like I said. So even the closure of the myoma bed is very clean. We do 2-layer closure always, and then yeah, that's about it. Because of the range of motions, it's much more easier suturing, especially in robotic, because it has a range which even your hand doesn't have. Not like in laparoscopy where you have a wider you need more practice to actually achieve endosuturing. So 4 functions there is this advanced instrument which is called the vessel seal. It seals up to 7 millimeters. So imagine you have such a huge fibroid that I said 2.7 kgs, and I had to retain the fertility. So this seals up to 7 millimeter, and also you can dissect it. And when large vessels are there, this really helps in sealing it very well, and there is no bleed. You just seal it, that's it, once. You need not have to do it. The one thing good about the robotic system instruments they are much more advanced, and the vessel sealing is phenomenal. We've never gone and buzzed 2-3 times. So yeah, endometriotic resection, that is the most important. Now we are seeing lot of challenging cases with endometriosis. Now if you see, there is a fluorescence technology, firefly technology. So what happens is, you can easily, there are lots of nodules. You have a rectal nodule, you'll have a ureteric nodule. See, for endometriosis, if you just do hysterectomy, BSO, or just do cystectomy, it's not enough. You'll have to look at your nodules, because if you do not get rid of those nodules, trust me, it's going to reoccur in a very bad way, and the patient is not at all going to be happy. So the first surgery is the best surgery. So identifying your nodule is very important. In the firefly technology, what you actually do is, you switch it on and you can see the green areas around where you can actually catch hold of your either your in malignancy or sentinel node, or in endometriosis all your nodules. So you give such a complete clearance, your patient will actually, after her first period, will come back and thank you, madam, I do not have pain. So there again, yeah, the ureteric course, which most of us are, there are a lot of modules. When you go into training, this is how it teaches you, you go sit there and there is an instructor with you, and there are these modules that you can learn your ureteric dissection also, and of course during your training you can go to the animal lab as well, which I went to Kochi, Amrita Institute. And advanced Da Vinci technology for gynae surgeons. So what are the instruments which are advantageous is visualization and camera control. As I already told you, how you can even see a drop of blood, you can zoom in really well, and there is no disturbance in clarity or anything. You can flip it, look up and look down. And force bipolar with dual grip, yes. So it has multiple things. It grasps, it dissects, and then it cauterizes as well. And then of course the firefly technology is really good for endometriosis, especially for fertility sparing. And yes, the Da Vinci camera, all the highlights are here. We'll come back to it. These are all how clearly you can look at the structures. And if you look at the tip of the instruments, it's phenomenal, because it actually flips. If you look at the range of movements, your robotic tip, your laparoscopic tip doesn't flip. I'll come over to more surgeries. Enhanced precision and dexterity, 3D visualization, minimal blood loss. So whenever it was less than 10 ml, however big your surgery is, it's definitely a win-win situation. We, in the last 300 cases, in less than 18 months, we have not done any blood transfusion for any patients. So faster recovery, of course, you can send them home. The reason why you send them home more faster, improved patient outcome, is because in your laparoscopy, the port site, and when you're moving your instrument, the port site moves. Here, the robotic arm grabs it and grips it, it's called, and burping. That means it doesn't go inside. You don't have to, port to, put it inside, withdraw it, the port came out. All that problem is not there. It is just seated right there. And even you have these monitors which can monitor your gas. It doesn't fall even when you're pushing the specimen down. So all these things actually add to the advantages. Now if you look at it, this is just to show a normal ureteric course over here, because that is the most common thing that we are scared of. And the clarity is so beautiful. That's what I was trying to demonstrate, which this kind of clarity is, quite difficult to get elsewhere. So coming over to my surgeries right here, I can play it. If you look, I'm just trying, like, even if you see the second one, on that side. It's a very small one. And if you look at it, how finely you can dissect it without injuring your femoral end. So this lady then later on, she conceived no problem. It's that tiny. Like anybody else in laparoscopy, we would have pierced it and, the contents would have come out. Here you can just remove it without even making a hole into that cyst, which is so flimsy. I'm just showing you how flimsy it is. So one, you see the hysterectomy, then you see the myomectomy, and the last one, that is where the robotic tenaculum. You can see how we can release it, rearrange, articulate it around. Look at the tip, you can take it up and then you can dissect it. And if you look at it, the clarity at which we are doing it is phenomenal. And also no blood loss, if you see. So that's the advantage of the robotic surgery. And the myoma bed also can be, sutured very accurately because you can go very close to it. So at the end of the procedure, basically what happens is, you've given a good result to the patient. Patient is happy. That's all. That's why we are we've studied and been in this profession for better. And with your endosuturing, if you look at it, it's so much more easier. And all these surgeries is my first when I've started it, I did it. So I'm not showing the surgeries. It's like me as a beginner surgery. Why I always show my beginner surgery is everybody can relate to it. That's why. And the learning curve also is not that, not like you have to take, if you're you have to take years together. All you have to do is, if you are very good with your open surgeries, it's a cakewalk if you have a robotic system. Or if you have access, and now the access is a lot. Everywhere you have the robotic system, and yeah. So this is how well you can, go ahead and suture. If you look at it, yeah. So that's one thing. The myoma bed as well. When the myoma bed is being sutured, the precision at which it's being sutured is also very important. So this is what I would like to tell you people over here. That is a mesh that we are using for the patient. There are controversial. We are not putting it right. We're not using it for any other purpose. We've done so many mesh plasties and patients are absolutely fine. Okay. Now these are all other surgeries. I can just fast forward this actually just to show you, where see here, the ureter is going. I'll just replay it. Here if you see, the ureter is medial. It is sitting on the uterosacrals. So generally when you do the colpotomy incision, we would have gone and literally cut off the ureter over here. If you look at it, just look at that thing moving right there. Do you have like a laser? Okay, it doesn't matter. So it was very, very, very close to the uterosacrals and you could have definitely injured. So know your anatomy well, of course that's there, but then over here your dissection is more precise because it's not a bloody field. Can you see the ureter moving there? Yeah. So that's what I wanted to show in this. The surgery is done. Even over here, if you look at it, everything is just stuck there. And then we had to go and find out where is the cyst. So, and the whole surgery, now it will get ruptured, but still, the dissection is neat. So, coming over, we've done even ureteric re-implant over here. And this is again ureterolysis, that if you see the ureter is going there, you just pick up that flap of peritoneum just above it, always visualize it, and then go ahead and start your dissection and you can go forward. This was also a very complex cyst, endometriotic cyst. So, this is how we identified a ureteric injury. when they went in for appendectomy, and we had to go in with the urologist to fix it. So if you see, the injury is there. So we went ahead with Bory flap for that. So hysterectomy, basically benign and malignant. Myomectomy, however big, yes, it is faster. But if it's way too big, I would always suggest instead of lap, or it's the convenience of a surgeon. Endometriosis resection, yes, all your nodules get definitely better. Sacrocolpopexy and ovarian cystectomy and other complex procedures. So the clinical outcome, as I've already told, compared to the conventional surgery, far more superior. Reduction in operative time, because you have multiple instruments to operate. Pain, trust me, on a scale of 0 to 10, 2, 3, less than that. 3 is the maximum we've had. So we don't give no opioid use. We've just given paracetamol. We've never used anything other than paracetamol. Faster return to normal activities. The people I've operated in my hospital have joined work immediately, as in 2-3 days, and then decrease risk of infections and adhesions. Then, of course, all these case studies, we can talk about it later. We've done large number of endometriotic resections and robotic hysterectomy for very large fibroid. Tomorrow I have one 34-week. I can even put it up. I can send you the link if you want. You guys can watch live as well. Future of robotic gynecology, advancement robotic technology, AI integration and automation. Yes, AI integration is the most superior. It's not that the robo can never operate on its own. So this is what the patient thinks, and this is what our fear is. It can never ever do that. I don't think in the future as well. And expanding indications for robotic surgery, training and adoption amongst gynecologists. These are all just how the ports are placed, that's the primary port which is placed. Everything is done within 2 to 5 minutes, all the placements. Yeah, if you see, it's not like your laparoscope, it's just a linear one. You just put those 4 ports and then go forward. Okay, this is the robotic arm. It comes from the boom. It has 4 universal arms, and then you attach it. And the sensor systems are fabulous. Once you dock in, and then you can't change the ports. You can't change the position of the patient as well, so there is no damage and there is no pain because your port site is well protected. All right, so these are the things. And coming over, yeah, this is just a 2-minute docking process that we generally do, and it's stopped. So it's very easy. We just instrument. If you just look, the entire thing is only for 2 minutes, but we are done docking. So it's very easy. And of course, we have a training program which is certified. I'm a certified technology trainer. We have everybody in-house. And then the training for people will generally be designed for external gynec surgeons, covers robotic setup, patient positioning, how do you position and how you dock in, and then handling of the instruments. This is how they go for your training. Handling of instruments, and then they go and take over to the animal lab. You can work on the console, and then there are a lot of module certification after that. It's open to all gynecologists. And robotic gynecology offers superior outcomes, benefits of both patients and surgeons. We're doing our next robotics is on uterine transplant. As I said, we've already done 3. For the donor, we're going to use it, not for the recipient yet. Let's not get too ambitious. So we're going to do it for the donors. So thank you everyone for patiently listening. Yeah.
Thank you, madam, for a wonderful lecture. As time is short, question and answers can be had in any robotic surgeons? Well, maybe one question. Dr. Kiran Bhai is our local robotic surgeon.
Oh, hi. Hi.
I got trained with Da Vinci S. Now I'm
That's an old system. Yeah.
2013 way back with
Yeah.
Now I am working with Da Vinci X. So I'm very much loose of Da Vinci and the closed console. Now the newer systems are coming with open console.
Da Vinci is not coming with open console yet. Yeah. No, that is like an advanced laparoscopic system. You mean it's a
More ergonomic, right?
no.
What is your opinion on the open console?
See, I tried. Let me not name three other robotic consoles because we are supposed to train in everything. I told my hospital to go for Da Vinci Xi after getting trained in everything because you don't have that kind of control that you have in Da Vinci. Da Vinci is 20 years ahead of the other three consoles. They are going to take another 10 years to even get where Da Vinci is. Number two, you know a 3D laparoscope, right? That is also like an open console. And then it's like 4 different things getting docked separately. So docking takes time, the precision is not that good. And even that open system, it's just like in closed system, your vision is much better. If you look at the clarity, yeah.
Open console is more ergonomic.
No, it's not at all. It's not at all. If once they try this system, I think they will speak for themselves. But then they will also have to sell their things, so they will talk everything. So yeah, and nothing wrong. All systems, it's affordability and what they can get because this is exactly. Yeah, that's more like an advanced 3D. Yes.
Two cameras, it will be more ergonomic.
Exactly. And this one is very good. The fiber optic cables which are connected are far more superior in its clarity. Yeah. Thank you.
Thank you so much, Dr. Padmapriya.
And we are happy to announce our association with Gleneagles for conducting transplant surgeries, and this collaboration marks a significant step forward, delivering advanced and comprehensive care to our patients.
May I now request Dr. Navneet Megan, Founder, Head, Division of Reconstructive Cosmetic Gynecology, All India Institute of Medical Sciences, Founder, El Sante Center for Reconstructive and Cosmetic Gynecology, Dean, Indian College of Cosmetic Gynecology, Vice President, American College of Cosmetic Gynecology, and he has many national and international publications to his credit. He's Editor-in-Chief, International Journal of Reconstructive and Cosmetic Gynecology, National Corresponding Editor, Journal of Obstetrics and Gynecology of India, National Coordinator, Foxy Urogynecology Committee 2014 to 17, National Coordinator Endoscopy Committee 2015 to 17, past President, Ambala Obstetrics and Gynecological Society. He's the Founder President, the Society of Cosmetic Gynecology India, awarded the Foxy Kamini Rao Oration for the year 2014, and also the Young Gynecologist Award from Asia Oceania Federation of Obstetrics and Gynecology. He is now the Chairman of Urogynecology and Pelvic Association India, member of Asia Oceania Federation of Obstetrics Gynecology Urogynecology Committee, and Congress President Ricogyne. He is very well known for his cosmetic gynecology. He trains students in cosmetic gynecology for the past so many years. Welcome, sir. Please deliver your lecture. He is today going to speak to us on energy-based devices in cosmetic gynecology beyond lasers and radiofrequency.
Thank you very much. Thank you, Dr. Sirisha, for having me over and with this vision to bring the most advanced and the hottest subspecialty of gynecology to Visakhapatnam. Now, when I was hearing, the previous speaker, it was a kind of deja vu. I remember more than a decade back when I got trained and certified by Intuitive and had the privilege of one of the first gynecologists. And, I remember Professor Alka Kriplani at that time was heading the department at All India Institute, and she also was those days traveling for her election campaign to be the president of Foxy. And we were going, to one meeting together. We were flying. And I asked her that, what is your opinion about the robotics? We've just started. Indeed, we got trained back to back on 2 subsequent days. And she said, I'll finish my first 100 cases. Those were the days when it used to take 15 to 20 extra minutes for docking. And I was very pleased to hear that it's just a 2 to 4 minutes job now. I left robotic surgery almost around 8 years back. I left everything in obstetrics and gynecology except reconstructive and cosmetic gynecology. So from big surgeries to small things. But I can't be more happier than this. I bring greetings from my country. A country for which all of us are the part. and the country which is home to today proudly the world's largest chain. When I say world, I mean it. World's largest chain of reconstructive and cosmetic gynecology clinics, Elisante, and Indian College of Cosmetic Gynecology today, which has trained more cosmetic gynecologists globally than any other institution or a training program in the world. I'm going to be talking about two very, very important issues today. One, now, and one in a few hours from now. And we will talk about the future of feminine rejuvenation. Now, I'm sure all of you have heard about vaginal rejuvenation, so on and so forth, and terms which at times confuse between the subspecialty definition itself. How many of you have heard of all these terms? Cosmetic surgery, cosmetic dermatology, and cosmetic gynecology. Excellent. Can anyone tell me a difference between all three of them? One stark difference between all three of them. Anyone? Okay. If you hesitate, I will tell. Out of them, the first two do not exist in the academic world. They're just marketing terms and nothing beyond that. In no medical university in the world, cosmetic surgery or cosmetic dermatology has ever been taught. And this is not approved as a medical subspecialty from the National Medical Commission, which governs and regulates medical practice in this country. So they're just marketing terms, and if you do any such procedures, you are supposed to charge GST from the clients and deposit GST with the government if you do any cosmetic surgery or cosmetic dermatology procedure. Whereas cosmetic gynecology is a medical subspecialty approved by the National Medical Commission, and which I had the proud privilege of establishing and heading a MCH program at All India Institute at its Rishikesh campus last decade, end of last decade. Now, when we talk of cosmetic gynecology, this differentiates itself from the other misnomers and marketing terms which couple of company-based programs or their sponsored people prefer using, like aesthetic gynecology, functional gynecology, regenerative gynecology, so on and so forth. None of them is a medical subspecialty. None of them is approved by the NMC, and none of them is a regulated medical practice. And therefore, cosmetic gynecology is totally independent of any such misnomer or marketing terminology. Now, what are the treatment options when we talk of cosmetic gynecology? Surgery. Surgery remains at the top of it, and the kind of results which you can get with surgery are absolutely unparalleled. A lot of people think that cosmetic gynecology is just about buying a laser, a radio frequency, or any other such energy-based device, holding it in hand, and they claim themselves to be cosmetic gynecologists. Actually, at all such so-called programs, which are normally sponsored by the laser industry, they convert you into laser technicians. So the right nomenclature after any such training where you are trained on using a laser device or any such device would be a technician, and it is a demotion from you being a gynecologist or a doctor. So please understand, holding a handpiece in the hand does not make you a cosmetic gynecologist, because besides the non-surgical part of the subspecialty, which is itself far more than just holding an energy-based device, it constitutes surgery, which stays one of the important pillars of the subspecialty. The scope of our today's discussion would not permit me time to get into any further depths, but then this remains the gold standard for many procedures. Although with the current advancements in cosmetic gynecology, it is almost impossible to have a pure surgical cosmetic gynecology practice, and you cannot have a cosmetic gynecology practice till the time you have the right armamentarium into your practice. It has got high efficacy, cost versatility absolutely depends upon the surgical expertise and how much do you want to charge for your surgical expertise. You may do a surgery free of cost and you may charge 10 lakhs as a surgical fees. It's absolutely your take. And downtime is a big problem there, because after any vaginal surgery, a woman has to have abstinence for at least 6 weeks. So there is downtime. After surgery, there are fillers, threads, and fat graftings. Better marketing things, well listened, speaking from the stages, but then the patients don't accept it. And they have a lot of problems between them. We will again not be able to go into the depth of it, that what is the scope and what are the issues concerned. Then comes energy-based devices. Now, energy-based devices have become very, very popular. The first reason is the learning curve is zero. I can make you a technician in 15 minutes. So, you don't need any learning curve. So, second, there has been an industry push for right and wrong devices both. It is always medicine and pharmaceutical industry or equipment industry are correlated for good and bad reasons. We cannot exist independent of them, definitely. But we need to know how to separate wheat from the chaff and how to differentiate between chalk and cheese. But the kind of efficacy with the current devices is reaching at amazing heights. There is no downtime with the right device. There is no risk, and the versatility is again amazing. We are using energy-based devices before surgery, with surgery, after surgery, and without surgery. So it is very important that you have the correct armamentarium when you are using any such things, and that is why the energy-based devices have been a clear favorite. But still, cosmetic gynecology market, despite cosmetic gynecology now being an approved subspecialty, has not grown like cosmetic dermatology, aesthetic medicine, and even cosmetic surgery. What is the reason? The reasons are because gynecologists are never unemployed. Gynecologists are generally busy, and they're busy with physiology, because women will get pregnant, they will come to a gynecologist. If they don't become pregnant, even then they come to a gynecologist. If the women will have periods earlier, they will come to a gynecologist. If they got it delayed, they will come to a gynecologist. If there is more bleeding, they have to come to a gynecologist. And if there is less bleeding, even then they are worried and they come to a gynecologist. So right from the cradle to the last breath, women need gynecologists. And in a country of 1.4 billion people with just less than 50,000 trained gynecologists, no gynecologist is devoid of work. And probably that was the reason why many gynecologists thought that since we're working, deliveries हो रही हैं, MTPs हो रही हैं, AUB हो रहा है, hysterectomy हो रही है, ART हो रहा है, IVF हो रहा है, so why bother yourself? And then there are a lot of misconceptions surrounded by it, because what I will show you, when we walk this talk further, that there has been no subspecialty of gynecology, including endoscopy, including ART, which has risen so exponentially and so fast as cosmetic gynecology today. But the markets globally have yet not grown. There are two important reasons which I have tried to squeeze in. Number one, I told you gynecologists are not unemployed. Unlike if you go back to dermatology 3 decades back, दाद खाज खुजली के doctor. When I was an MBBS student, people would hardly think of taking dermatology, because what would you do? Patients would never get cured. You will keep giving them steroids and antibiotic creams, and that is the end of it, and patients never leave you. You don't cure. But they realized that they can get into beautification. They can start being wellness practitioners, and that is what changed the game. And today, dermatology is one of the first choices of any undergraduate while he or she opts for a postgraduate program. So it is not dermatology, it is actually the aesthetics or the cosmetic dermatology part of it, because what they learn in their MD program, they don't come and practice outside, and what they practice outside is still not taught in medical universities, unfortunately. Second, gynecologists, as I said, the busy and successful clinicians. We talk about robotic surgery. We find the thrill of decision making in obstetrics. We find, again, a thrill of playing with the blood. We are into bloody business. Let it be obstetrics, let it be gynecology. We have got our, surgical thrills out of the surgeries we perform, and then we have never been trained on energy-based devices. And it would take, a generation that once every postgraduate students get trained into this, probably that is when they would realize what is the opportunity ahead. And third, many gynecologists, and I would say most of gynecologists today have multiple practices. They have their clinics, they go to 4 hospitals, they have attachments. So if they have to have a heavy initial cost of establishing a practice, it becomes a deterrent. And they feel, oh my God, who's going to invest further? Chal raha hai. Pregnancies will happen. Some of them will come for abortion, some of them will come for deliveries, and if they will not, get pregnant, even then they will come for getting pregnant. Life is good. So, that is the reason why the markets did not grow. Now, we thought that it needs a two-pronged approach, and that has to be the way forward. First, good training into non-deceptive practice of cosmetic gynecology, because the kind of industry-pushed training programs which have happened in last 5 years have actually done more harm than good. And when people use the wrong devices, they end up using devices, we will talk about chromophores. Many people are using lasers where the chromophore is hemoglobin and trying to burn vaginas. Actually burning vaginas without knowing that they're burning vaginas, because some gynecologist with eminence who was hired by a laser company stands up on stage and says, oh, this is a great device, you use it, without getting into the science of it. So it has done more harm than good. And in the end, when people do not get results, they feel, oh, it doesn't work, it's useless, it's all bull crap. So that is one problem. So that is why it's very important to give a non-deceptive, give a complete hands-on training on all various devices, getting into the science of all of them before you take a decision that what you would like to use, and have a non-deceptive practice where you don't put deceptive claims to make designer vaginas and Barbie labias and start degrading and humiliating womankind for whom you are healthcare practitioners. You cannot do more damage to medicine than claim that you will make some designer vaginas and Barbie labias. That is not medical science. That may be a beauty parlor business. We were not trained for that. That is for what we didn't take our oath. Second, probably a portable solution to deliver feminine healthcare and cater for multiple issues which today make a form, which today make the subject of cosmetic gynecology. Let us explore the solution number 2 here, and that is what we're going to be talking about beyond lasers and radiofrequency, the future of feminine rejuvenation. If we talk about the present energy options available in the market, we have the carbon dioxide lasers, we have the erbium YAG lasers, we have diodes, which are actually not lasers, they're semiconductor devices, but since laser is a marketable term, they prefer calling them lasers. Then you have different radiofrequency devices, then you have the plasma energy, and you have HIFU. Now, before I get into it, let me tell you what all it can do. It can totally rejuvenate, reclaim, and revive femininity. It can take care of urinary incontinence up till certain grades. It can take care of both if you're using the right device and in the right manner. It can take care of not only the stress but also the urgency incontinence. It can treat vaginal laxity, right? Now, a loose vagina is not a fancy term. It is a medical disorder, and it is the #1 pelvic floor dysfunction. And vaginal laxity, therefore, is covered in medical practice. So it can treat vaginal laxity and create a tighter vagina, something which a woman had pre-pregnancy, pre-delivery. It can take care of vulvovaginal lichen sclerosis, right? We are treating non-healing fistulas using these devices, and many additional functions on the vulva, and also treat vulvovaginal atrophy. now the latest thing, and which we're going to be talking today towards the end of this discussion, is something amazing, that the same kind of devices have started treating cervical diseases, and what a marketing term which we have given it as cervical rejuvenation, but it has started treating cervical diseases, and we're getting almost 100% results in cervical ectopy, so-called cervical erosion, and HPV infections up till CIN1 are getting reversed. Now this has totally revolutionized the way gynecologists will practice gynecology, and probably there is a ray of hope that these treatments actually can be preventive for cancer of the cervix, because we know that cervical erosion and cervical ectopy are risk factors for HPV infections, which further leads on to the cancer of cervix. Although we are yet a little away from proving it properly, but definitely we have enough preliminary data to say that there is a ray of hope. Now, this is what the energy-based devices can do. Not all of them can do everything, but that is what majority of the devices claim to do. Now, let us see what works in gynecology. Now, I have given it a little red and green color to tell you that red, everything what is in red has a potential to cause harm. And following the medical principle, primum non nocere, first do no harm, everything what is in red goes out. And I will talk about the science why they go out, just because, not because I'm standing here on the stage and you're sitting there and I'm saying and that is correct. No, that doesn't work like this. There's no medicine of eminence which runs anymore. Today it is evidence-based medicine, and even I keep learning daily from my students. If they can convince me, I will get convinced, or I will convince them. That is the way we practice medicine, and that is the way I have been practicing medicine for all last 3 decades. I have been into medical practice. Now, why I tell? Because the carbon dioxide lasers are ablative. Although one particular carbon dioxide laser, which is not available yet in India, claims that their pulse duration is less than the thermal relaxation time of tissue, and they do not cause fibrosis, but this is not proven by evidence, and I will show you the evidence. I will show you level 1 evidence today what CO2 lasers can do. So I know that many people have purchased CO2 lasers. Many people are inserting CO2 lasers in vagina and treating vagina like the face. If you pick up literatures of the 2018-19 CO2 lasers, there was a wave of CO2 lasers being sold in India. Even the literature says it is working beautifully on vaginal skin. I don't know where did people sleep when they didn't even think that there's no skin in vagina. But people were being taught that because it is safe on face, it is safe in vagina, and it is safe on facial skin, it's safe in vaginal skin. So the CO2 lasers are absolutely out. I will never use a carbon dioxide laser because it's ablative, because it will cause fibrosis and it is proven to cause harm. I will never use a carbon dioxide laser in vagina. A smooth Herbig laser, definitely not a normal Herbig laser, but a smooth Herbig laser, definitely is one of the finest devices which you can use, because it can take the temperatures which are actually required when you use a thermal device for collagen reformation. Now please understand that if you have to do collagen regeneration or neocollagenesis, the temperatures required are beyond 60 degree. At 45 degree, 43 degree, 42 degree, the collagen does not regenerate. It is just initiation of it. Because what has happened is that this whole concept has come from the West, and we all understand that the average temperature in Western countries is at around 18 degrees, right? Half of them stay in sub-zero temperatures half the year, and the rest of the years they stay in 10, 12, 15 degrees. Now when they have been, or their skins have been subjected to 40, 42 degrees, there has been a little improvement in the skin. Now I will give you an example. You all are very fortunate people who live down south of our country. Because if you see, the skin textures and the hair textures of the human population as it keeps going south improves. Because you never come across those temperatures where it damages skin. Now, because those people, the Caucasians who were staying at 10 degrees, 12 degrees, and when they were subjected to 42 degrees of temperature, the improvement was there. So, the company started selling that concept that if a RF device can take a temperature to 42 degrees, it does wonders. And I would not refuse to accept that 10 years back, even I was sold to this idea because we were new, we were learning. And I was absolutely sold to this idea, and I happened to be the first user of the radio frequency technology in this country for vulvovaginal use. But over a period of time, when we did not get results, so we definitely challenged what was being told by the West. And then we applied our mind that this device is taking the temperature to 42 degrees, and in my country, half of my country lives for half of the year beyond 42 degrees, so why do they need this? They absolutely do not need it. And if this would have been the case, then we never would have any of those problems in our country. Meaning thereby that the science, and I will tell you where the science came from, that why you need a temperature of 60 to 63 when you have to regenerate collagen. So for that reason, it is only the smooth Arbe-Miag laser which without ablation can take a temperature beyond 60 degrees and therefore is one of the finest devices which you can use for gynecological purposes. Diode, I will come to it. I will threadbare come to the truth of diode, because in our country is the only country where a 1470 nanometer diode proctology laser is being sold in gynecology and without application of mind, and without even understanding what it is actually doing. I will show you today what it does. Then comes RF. Good RF devices are safe. They do not cause harm. The diode and CO2 lasers have a potential to cause harm. The good RF devices are safe because they take the temperature only to 40 to 42 degrees, but the efficacy may not be what you are actually expecting, and because most of the results are because of water retention, they stay good for 3 to 4 months, and you have to do it repeatedly, the treatments again. Then we have the jet plasma technology, which is the latest kid on the block, has come only 3 years back in our country. Again, just like 10 years back, I started using the RF. I had the privilege of using this technology for the first time, and as they say, it has totally disrupted the game of whole cosmetic gynecology. We will talk about the science of it and the evidence for it, and then in the end is HIFU. High intensity focused ultrasound. I am seeing Dr. Trivedi sitting in the front rows, and he comes from a city where HIFU was the first city in the country to use HIFU to dissolve fibroids. Am I right, sir? So that is the kind of energy it generates. It dissolves fibroids. Do you want to dissolve vagina? Now, HIFU gives uncontrolled depth of heat. And even people who have used HIFU around 10-15 years back on face have started finding problems in fibrosis, and there is a fibrosis in temporomandibular joints in those people who have used HIFU on face a decade back. People are forgetting that when you're putting HIFU in vagina, there is something which was called urethra and urinary bladder. If they have totally forgotten the anatomy of vagina when they turned from gynecologists to technicians, there was a urethra and a urinary bladder which still exists in anatomy books if they have stopped finding it. And posteriorly, there is something called as rectum. So you can end up causing rectal strictures. You can cause, strictures in the urethra if you use HIFU. So again, HIFU is not to be inserted in vagina because it has a great potential to harm. Just because it comes for peanuts, it may be, adequate for monkeys, but absolutely not for, as I was listening to the previous speaker, when there was a comparison between the new, these robotic devices and which has been the standard of care. Probably just because the standard of care comes at a high premium cost, it does not make it inferior or other devices superior or useful than that. Now, as I said, when the mode of action is thermal, now please look into it that except for the jet plasma, which works, and it is the DC plasma, which works on biological principles, rest all devices work only and only on thermal principles. They generate heat, and it is only by the effect of heat that there is an initiation of certain enzymes, and because of that the collagen formation cascade starts, and that temperature has to be between 60 to 63. Now where does this temperature of 60 to 63 comes from? Actually, much before we started using these energy based devices in gynecology, it was in dermatology. Now most of these devices show that the dermis should approach from 45 to 65 degrees to achieve the desired results, and for every 5-degree decrease in temperature there is a 10-fold increase in time to achieve the same amount. That means if you are using a device which is at 60-65 degrees and you are using it for 5 minutes, so if you are using a device which is taking only to 40 degrees, you can well see how much time you keep, for every 5 degrees you keep increasing 10-fold time, probably 2-3 hours, and no one does that, and it is not doable. The women will not tolerate it. So that is the reason why the science dictates that this is not going to help. The threshold for collagen denaturation is 60 to 65. Temperatures below 60 have minimal effect, and above 70 have insignificant additional benefits. And all these things came actually from the effect of thermal heating, which was defined on Lelth and histological properties of the glenohumeral joint capsule. What they did, they took out the tissue, they took out the collagen, and they started putting it at different temperatures. And finally, the results were that the temperatures which were around 65, 70 and 75, only there the effect did come. So the minimum temperature remained between 60 to 65. And therefore, any energy-based device which is based on thermal regulation, if it is not able to take the temperatures to 60, it will not give desired results. Temperature must go to 60 plus, so please be very, very clear on that. Now, I just want to ask you people one thing. Do you think that using an ablative energy-based device in vagina is safe in long term? We all are students of science. We all know ablation will heal with fibrosis, right? Anyone has a doubt? All of us agree? Unanimous? Thank you. So do you think you want to give a patient a fibrosed vagina? So we have again a unanimity that ablative devices are not meant for vagina, right? And the science does not support it. The eminence may support it because of financial reasons coming behind, but the science does not support it. Now let us talk about science. Just because we all have agreed, still it is not a sufficient reason for all of us to agree. Let us see what the science teaches us. Now this is, complication report of 3 cases. 3 premenopausal women who were previously treated but have no, improvements. Number 1, they were treated all with carbon dioxide lasers. They have no improvement. But on the top of that, when they actually went for a vaginal surgery post those treatments, the planes could not be found because it was all fibrosed. So, they all were having scarred or friable vaginal mucosa where the surgery and dissection became difficult. Now this is one. Second, you see another 4 cases and see that even there have been, after use of these ablative lasers, when they reclaimed intercourse, there were vaginal wall lacerations, persistent dyspareunia, worsening dyspareunia, and new dyspareunia after these lasers. Now this is what is being caused by the ablative lasers. This is not enough. Indeed, there already has been a FDA alert in 2018 on use of carbon dioxide lasers, and much data has been published. Now, to put an end to all confusion, I would like to take your attention to a level 1 evidence, a randomized control trial, not published in a paid journal, but published in the Journal of American Medical Association as recent as year 2021, right? To determine the efficacy of fractional carbon dioxide laser for treatment of vaginal symptoms associated with menopause. 3 treatments using a fractional microablative carbon dioxide lasers were performed. 43 women randomized to the laser group, 42 to the sham group, and although there were 16 adverse effects in the laser group, the treatment with fractional CO2 laser versus sham did not significantly improve vaginal symptoms after 12 months. I think this puts to rest all confusion about using an ablative carbon dioxide laser in vagina, that neither it has benefit and has additional harm. The point was so emphasized in JAMA, and we all know who are in touch with the academic world that whensoever there is a publication of major impact on the practice of medicine, an editorial comes along with. And in the same issue, Edelman wrote an editorial that it is time for a pause. And they remembered that just because all Tom, Dicks and Harrys were using the meshes in vagina, whereas in expert trained hands there may not have been those many complications, but since wrong meshes in wrongly trained hands were used, and it led to almost a ban of meshes, vaginal meshes in most of the world, the same fate will come to lasers if we continue doing the same incorrect practice. Now this is very, very alarming. And if this continues, what alarms is that this subspecialty will become the 4th regulated practice in India. We have 3 regulated practices. Practices regulated by the government: cardiac stents, orthopedic implants, ART. ART even has a bill, the first medical practice which necessitated a bill to be passed in Parliament. And 4th may be the use of lasers. And it is detrimental to the reputation of doctors per se and our profession. Now, for a laser, if the chromophore is hemoglobin, what is the implication? Now let me explain you that how does the chromophores affect. So what is laser? All lasers do emit light. That light is absorbed by a chromophore and that generates heat. And if that heat is generated in the right chromophore to a right temperature, it leads to the correct end result. That is the simple science behind lasers. As simple as it can be made. There can be water, hemoglobin, melanin, and another chromophore is adipose cells, the fat, which we are not bothered about at this point. But these are the 3 major chromophores. Now, since majority of people sitting here are women, I am sure you all, either have got done or know of someone, or at least know of something which is called as a laser hair reduction, right? Now, laser hair reduction previously, so all these centers have become glorified beauty parlors. Previously, women used to get a waxing done at a beauty parlor. Now the trend is you go to a dermatologist or an aesthetic center and get a LHR done. Now, the laser which works for hair reduction is generally a diode laser or an Alexandrite laser, and the chromophore is melanin. That means all the light generated is absorbed by melanin, and that is where it just finishes or reduces the hair. It's reduction, not removal. So it reduces the hair growth. Similarly, if you have to burn veins, like in proctology, if you want to burn hemorrhoids, so you use a laser where the chromophore is hemoglobin, so that the heat is absorbed by the blood vessels and blood vessels are burnt. And if you want to generate collagen, you use a laser where the chromophore is water, because it is finally the water which is the necessary requirement for collagen formation. Now there is a diode laser with 1470 nanometer wavelength, which was used for proctology and in surgery to cut. So many surgeons use it. And these laser companies came up with an excellent idea. Although I appreciate, southern part of the country where women are more independent and take more independent professional decisions. But a part of country where I come from, there is much more financial control in hands of men. So many gynecologists have surgeons as their husbands, and these companies started targeting those surgeons telling them you buy this laser. अरे मैडम का क्या, ये 2-4 केस ये भी यही वजाइना में भी डल जाती है, आपके काम आएगी, आप इससे हेमोरॉइड करोगे, आप इससे कटिंग करोगे. And somehow they entered this field because gynecologists were not even trained on the concept of this, and the major chromophore for a 14-17 nanometer being hemoglobin. So if you insert it into vagina, it finds the capillaries, the blood vessels in the vagina and burns them. Whereas the end result of our work is neoangiogenesis and neocollagenesis. We want to have new blood vessels so that there is much more nutrition, much more lubrication and much more growth in vagina, and to form new collagen. And here they're just burning whatsoever little was there also. But just because these companies could hire some people who walked with them, talked with them and talked for them, so they ended up selling these lasers also to gynecologists, whereas they were meant to burn blood vessels, now they're burning vaginas in the name of tightening vaginas. Now I'm just not saying, you can do a Google search and find out for yourself the chromophore, and this is not that the science didn't know it. Science knew it way back in 2011, that when the veins were treated with 14-17 nanometer laser, it did not show any sign of contact damage. That is why the vaginal mucosa does not burn, but there is deep coagulative necrosis, vacuolizations and fissures at the subintimal sites. That is how it kills or burns all the capillaries, and at the intraintimal site of the intimal hyperplasia and the medias. So this is what a diode laser does. Now if any one of you has it, I hope you know what to do with it. So if this is the situation, what is doable? Currently we have two technologies which are safe and efficacious, which are left out of all of this. One is a smooth Herbig laser and one is a jet plasma. Now smooth Herbig laser works on heat, and we will today talk about the jet plasma technology now, which works on cellular level and at biological principles. Now this is a device which is the only energy based device beyond lasers and radio frequency, and works at the cellular level. How it works then? It causes thermal stimulation, takes the temperature to around 40 degrees, and that is where its similarity with the RF ends. But that is not enough. So it causes membrane depolarization, reverse electroporation and collagen activation. Now because of these things, it works at cellular levels, opens up nanopores in the cell, the nutrients required for collagen formation, that is water, enters the cell, and the process of collagen formation and neoangiogenesis is shortened. Meaning that if you have to give, let us say if you have to give a smooth Herbig laser treatment, you have to give one treatment every month, and although the company recommends 3 treatments on Caucasian patients, but we have been using that laser for a decade now, and we have realized that for our population you need 4 treatments. So it takes 4 months, right? Whereas when you use this, the treatment gap can be as less as a week, but we give it after every 10 days. Although on Caucasian population the recommendation was 4 treatments, but we ended up giving 6 treatments, but still we finished the treatment in 2 months, creating a shorter treatment duration and a better satisfaction amongst the patients. Now would I be able to get 5 minutes extra, or should I, because I am just left with 6 minutes? Okay, fine. So I will titrate it accordingly. Now the treatment is simple. There is no learning curve. You can be trained to use any of these devices in 15 minutes stat. What you need to learn is how to choose the right patients, which patients it will work on, how it will work, how to manage the issues which come up. That is what is important, and that is what makes you a cosmetic gynecologist. And choosing the right device only after yourself seeing, checking, testing all devices. That is what is important. Now I will show you a small video if it works. Okay. Just to show you how simple the process is. So this is one of the applications. This is one of the hand pieces which goes in vagina. You put a little ultrasound gel and do the treatment for around 20 minutes in the vagina. This is one of the applicators with which you can use it. it just goes in the vagina and leaves the energy there, the plasma energy. Now, it is very important also to understand the difference between different plasma energies. There is a DC plasma, the direct current plasma. There is a AC plasma, the alternating current plasma. There is a helium plasma, and there is a neon plasma. So the only plasma energy which is safe in vagina is the DC plasma, only used with silver applicators. You cannot use a golden applicator in vagina because it will turn ablative. So only a DC plasma with silver applicators is the only thing which it is used for. And the therapeutic effects are the fastest. Now, these are different hand pieces which come up with the device, a G applicator, wave, flat applicator, so on and so forth. Now, before we will end it, I will also show you today, because we are starting an Elisante center here in Visakhapatnam with Dr. Sirisha, and this will be the first place to offer the cervical treatments in this part of the country, and we will denude these pictures before I close the discussion today. Now, what is reversible electroporation? Basically, a high voltage electrical pulse is given to the cell. Small temporary nanomores are formed in the plasma membrane, and they allow the macromolecules and other ions to get into the cells. That is how it works. This small video will again show you how it actually works. Okay. So when the plasma current is passed on to the cells do open up, and the key word is reversible. If the device is unregulated, although fortunately there are yet no cheap Charlie Chinese versions of the device available, but it may come up. But in the end, if it is irreversible, if it ends up deregulated, irreversible, because the technology is patented, smooth Herbimiac as well as both the technologies are patented and are made only by one manufacturer in Europe for both the technologies. But if it becomes irreversible, the cells will die, and you will have the same result as you will get with either a diode laser or with a CO2 laser. So that is the key. The reversibility is the key. Okay, so we have seen it, how it works, and now the bigger thing, is there evidence? Because we have shown evidence towards that why the CO2 lasers cause harm and why they don't work. We have shown the evidence towards diode. We have talked about the energy-based devices. We know the RFs cannot go beyond 42 degrees because they are in contact, they increase the temperature in contact, and beyond 42 the vaginal mucosa will start getting scalded, and therefore since the temperature is not reaching beyond 60, the effects will remain suboptimal. Now, is there evidence towards this? Now, the best thing is that this is the only technology today in gynecology which has got not only subjective but objective evidence, which was published in the Swiss journal 2 years back. Now, 91 patients were randomized at 5 different European centers, and it showed that improvement of vaginal laxity was conjoined with the benefits of in symptoms of urinary incontinence. All these technologies, when they normally bring up any paper, anything, they talk about patient experience, right? It is all subjective. Please understand, the companies have deep pockets. It is not only the corruption. We just हम बदनाम हैं इंडिया में कि यहाँ corruption है, यहाँ झूठा डाटा बनता है, पूरी दुनिया में झूठा डाटा बनता है. So 1,000 euros is a big amount of money even in Europe, and you can give 1,000 euros to a woman to tell, yes, I am feeling good after this treatment. She just has to fill up a form. It is not that the world distrusts us and we should trust them. Absolutely no, they are as corrupt as anyone else. So the companies can give them 1,000 euros to fill up a form that yes, after these 3 treatments, I am feeling very good. So that is why whenever you see a subjective study, we all know how the FDA, the American FDA, was on a payroll of Pfizer in COVID for the vaccine. We all know that, right? So that is the great America and the great FDA and the great Pfizer. So the important is, as doctors, we have to understand that till the time we do not see objectivity in the data, we should not blindly trust it. And this is the only technology which has, because it works, it has been able to get a objective data. The study showed not only patient satisfaction subjectively in more than 90% patients, but also subjectively first randomized trial where the patients were subjected to pre and post treatment biopsies. Of the 91 patients, 43 were in the treatment arm and 25 agreed to get a biopsy done. No other technology in last 10 years, because these are just there for a decade, no other technology in last 10 years has been able to get this kind of data, because they're all worried that what will happen if it does not work. Now the biopsies have shown 101% average increase in epithelial thickness, and that is the end result we are actually looking for. And the best part is that it has shown a rete rigis extension, which shows that there is more rugosity also which comes up with the treatment, and none of the biopsy samples evaluated showed any damage of any physical damage, thus proving safety. And if you have noticed in the study that the treatments were sustainable for 12 months. So again, whereas we saw that the study published in JAMA, the treatments had no efficacy, and the study published here in the Swiss journal with a different technology shows a 12 months efficacy. And that is what actually makes this technology different. We're very happy that we're introducing this technology today here also. It's not that, just because we are introducing it here, that's why we're speaking on it. We are introducing it here because we know what works, right? We have all options. We have everything, which we can, but we know what works, and we want to give the best treatments at all our centers across. So whatever works only we use for our patients at El Sante centers. It is affordable, it is safe, it is the best ROI. We're not discussing about that here, but any gynecologist with the average practice of 20 patients a day can get the return of investment within 1 year if trained properly and uses it correctly. Now, if it is so good, then why every healthcare provider has not yet integrated it into their practice? Now, this answer you will get from this question, that do you think that a specific and adequate training beyond the postgraduate training is required for an obstetrician gynecologist before one starts providing such services? Now, this is what we recently published in the Studs 7th edition. Professor John Studd had asked me in 2015 when he was there, he is no more, we lost him in COVID, but when he was there, he asked me that I must write a chapter on cosmetic gynecology. And I had to politely refuse. I said there's not enough data today that we can write on it. And that is when I wrote about urinary incontinence in Studs, I think 2nd or 3rd edition in 2015. Now, this is when the data was there, and after John Studd, we lost John Studd, and the rest of the editors reached out again and said, now we must, because now it is a recognized subspecialty. Now, the contemporary residency programs do not provide the cognitive knowledge and the practical skills which are crucial for competency in cosmetic gynecological procedures. We definitely need one day that residencies, the obstetrics and gynecology residencies must include it. I'm very happy to share that many professors, many head of the departments from various medical colleges have come with us in the last 3 years, got trained, and they're finally taking this knowledge even to their residents. And of course, we have trained now more than 500 practitioners of gynecology in India, and I think there is no district left in the India, or at least 50% of districts where we have an ICCG grad practicing cosmetic gynecology, because the solution lies in this. Solution lies in training into non-deceptive practice of cosmetic gynecology. So whatever curriculum we got approved with NMC, we brought it to the Indian College of Cosmetic Gynecology, which is the academic arm of the Society of Cosmetic Gynecology of India. We all know FOXY, it's our parent organization as gynecologists. So what ICOG is to FOXY, ICCG is to the Society of Cosmetic Gynecology of India. And we have been trying to bridge the gaps. Because it's a new subspecialty, we had to walk very cautiously. The whole world was seeing us. We were open to criticisms from all ends. So proudly, we have ended up as the first training program in the world to integrate complete hands-on training on every possible technology into this. Face and vagina are not same. And let me tell you that we are witnessing a cosmetic gynecology revolution in India. I will show you a few pictures and you will understand what I say. I left All India Institute in 2022 and we established Indian College of Cosmetic Gynecology, and I pledged my services to ICCG in 2022. Somewhere in mid, we started training programs for cosmetic gynecology. And today, as we have just entered 2025, we have ICCG grads spread across all continents in the world except Australia. We have North America, South America, Europe, Asia, Middle East. Every Indian state and at least 50% of Indian districts. We had head of the departments of prestigious colleges, even like Armed Forces Medical College, come and trained with us. Many faculty members from different AIMS and other colleges of repute have come and trained with us. Now this is a very special picture, right? You can see two encircled faces. So this is what brings today me to Visakhapatnam. So we are very proud to have Dr. Sirisha, although I know Dr. Sirisha is an AS IVF specialist and she's not going to practice cosmetic gynecology in all probability. But because she wanted to integrate it into her hospital, she definitely did the right thing by learning what it is and what she should do. This is actually not less than a revolution. Don't you want to join this revolution? No. Don't you think? Now let me make you all listen to Dr. Sirisha. The volume is not there? Yeah. So they must listen to you. Okay. So there is no volume.
I'll tell about it.
No, I thought that they must listen to the boss lady.
Explain everything in detail about the
I don't know where the music is coming from. Okay, forget it. No, it's not coming from the laptop. I don't know. Fine. Anyways, leave it. So, any which ways, so you all can take a picture of this slide and definitely this will tell you how to join the revolution of cosmetic gynecology, which is happening globally. Now let me tell you a very interesting thing, what makes me proud. Right from, when I was a child, I have always thought what I have done for my nation. Today, after Ayurveda, if India has exported anything to the world in modern medicine, it is cosmetic gynecology. Everything else we have imported from the West. Today, we are exporting cosmetic gynecology to the world. India is the first country in the world which has established a university MCH program in cosmetic gynecology. India is the first country in the world which has recognized cosmetic gynecology as a subspecialty. I know there are a lot of heartaches which I see all over the world happening, but then my nation stands tall and I had that little contribution of making it happen. So that is what actually makes makes me swell with pride that at least this is little thing which I could do for my nation in my lifetime. Now, before we close it, this is something which is very, very important and I will definitely tell you about this because this is an issue which is again very close to my heart. Anything which relates with women's healthcare and where you can bring in a change in their lives is something which is extremely important. The whole world has been trying to prevent cervical cancer. Today, if there are cervical diseases, the only way is either a cryo or a thermal ablation. And we all know what we do. We're just burning the mouth of the cervix and not treating the endocervix. It makes even the diagnosis of the cancer difficult and gets delayed if you have actually used a cryocautery or a thermal ablation. Although the thermal ablation companies could get thermal ablations approved by FDA as a treatment for cervical diseases, but we all know we end up doing more harm than good. Second, because you just cauterize the whole thing, you're burning. Finally, you're burning the cervix. You're not doing anything. You're actually burning. You're burning either by heat or by cold. So there is a discharge it increases the risk of preterm labor if the woman still has to undergo pregnancy, and it delays the diagnosis of cervical diseases. So this is a technology which has come up, and these are the cervical hand pieces, what you see here, which we can use with the jet plasma technology. And we have been using it since August. After we saw people trying and testing it and getting reasonable results on European women. I always say Indian women are not there for testing. We will now test on Europeans and we will treat our women, because our women are much more precious, than any other women across the globe. So after they found that it is safe and it is treating, we have seen from August that it is 100% reversing cervical ectopy, cervical erosions, and heavily beneficial in cervical discharges. 3 treatments at a gap of 10 days, 15 days each, both at ectocervix as well as the endocervix. The only non-ablative cervical treatments available in the world today. And proudly, we will be starting it at Visakhapatnam from, I think, today evening onwards. Dr. Sirisha should be able to offer it to the women of Andhra Pradesh. Another important thing which I want you all to take back home, because as doctors we normally are very poor in financial knowledge. So whenever you buy a medical device, in India GST on medical devices is 12%. If anyone is charging you 18% and telling you it's a medical device, you're being fooled. It's a beauty parlor device or a cosmetic device or a toy or anything. On cosmetic devices, the GST is 18%, and on medical devices, the government of India has mandated a GST of 12%. So just a very small thing to make you sure that what you're buying is a true medical device. Cosmetic gynecology is the fastest growing subspecialty presently. Women need and ask for these procedures. Structured training and education is a pressing need, and we're trying to fulfill the gaps. Patient safety has to be top concern. Please remember, if a patient has come to you with an antepartum hemorrhage, you have somehow saved her life, and even if she has to go back with a colostomy, she may forgive you. Here, when she comes for these treatments, if you end up ruining her sexual life, she is not going to leave you till the grave. Because all over the world, the biggest medico-legal claims are where you have ruined a living woman's sexual life. If you kill her, the claim is there, but claim is less. But if you ruin her sexual life to a living woman, you made her a living corpse, so the claims are much higher all over the world. So be very, very cautious. Here, the scope for any negligence is zero. You cannot even think in your dreams to harm a patient who has come for quality of life treatment. So that is why patient safety has to be the top concern, even more important than a surgical treatment here. Objectivity, quality, credibility, and transparency must be maintained. We will also take this opportunity today to invite you all to the 4th World Congress of Reconstructive and Cosmetic Gynecology, RECOGYN 2026. It is actually RECOGYN which sowed the seeds of cosmetic gynecology exactly 10 years back in this country, and we will proudly host it for the first time in Gurgaon from the 2nd to the 4th of October next year. We do it once every 2 years now, and we will be happy to see you there. Thank you very much. And thank you, the chairs, for giving me a little extra time.
Thank you, sir, for your excellent deliberation on a new subject.
Sit.
So thank you very much. The first session itself was magnanimous, and it is a very
Very, very good beginning, eloquent beginning. So, with this, we would like to honor the speakers of the first session. I would request Dr. K. Subbaraju sir to honor our esteemed speaker, Dr. Navneet Meghon. I would request Dr. Sirisha and team Medsi to join in. Tarbat? Sirisha. I would also request Dr. Y.L. Narsingh Rao sir to honor our dietitian, Mr. Kalyan, with a memento. Mr. Kalyan, I think Kalyan and Dr. Padma Priya Vivek have left, so next I would request Dr. Sirisha to honor our chairpersons with a memento. Dr. K. Subbaraju sir, Dr. Y.L. Narsingh Rao sir, and Dr. Pallavi, Dr. M.N. Pallavi, Dr. Narsingh Rao, Dr. M.N.V. Pallavi. Thank you very much, chairpersons. And now, we would like to begin the introduction and inauguration program. We are presenting a video of Medsi Hospitals and IVF Center. You all can enjoy this while we just make things ready for the inauguration. And due to paucity of time, we can have the tea break. We can have the tea and coffee served during the inauguration in the hall. Yes.
I would request everyone who has gone out to come into the hall and occupy your seats. We are just beginning with the inauguration. An empowered organization is one in which individuals have the knowledge, skill, desire and opportunity to personally succeed in a way that leads to a collective organizational success. With this, I would like to invite the esteemed dignitaries onto the dais for the inaugural function. To begin with, I would like to invite Dr. Sirisha Rane, infertility specialist, obstetricians and gynecologist. Her positions include, she is founder and managing director of Medsi Hospitals. Madam C.V. Patana. Founder and managing director of Vizag IVF Center. She was special invitee ART Board, AP State Government, Joint Secretary AP Nursing Homes and Hospitals Association, Apna, AP State. She is the Vice President of AP ISAR Chapter and she is the Vice President of OGS Visakhapatnam. Her awards include Times of India Health Care Award from Central Minister Ram Mohan Naidu Garu. She has received Times Health Excellence Award 2024, Icon of Fertility Care. She has received Honorable Award Most Preferred IVF Doctor in Andhra Pradesh, presented by Sir Shri M. Venkaya Naidu Garu, former Vice President of India, on 3rd September 2023. Foxy Dhira Award 2022. Her past positions include, she was a Joint Organizing Secretary of Andhra Medical College Centenary Celebrations. She was the Secretary of AP Nursing Homes and Hospitals Association, Apna, Visakhapatnam. She was the Secretary of OGS Visakha 2022-23. She was the Secretary of IMA Women's Wing, Visakhapatnam, and Joint Organizing Secretary for Yuva Foxy South Zone. She has published many articles and papers on fertility. I welcome you, Madam, on the dais to occupy the chair. Next, I would like to invite Dr. Navneet Magan. He is endoscopic and robotic surgeon, pelvic reconstructive and cosmetic gynecologist. He is the founder head division of reconstructive and cosmetic gynecology, All India Institute of Medical Sciences, India. He is the founder of Elisante Center for Reconstructive and Cosmetic Gynecology, Dean, Indian College of Cosmetic Gynecology. He is the Vice President of American College of Cosmetic Gynecology, has to his credit over 80 national and international publications. He is the Editor-in-Chief, International Journal of Reconstructive and Cosmetic Gynecology, National. We have already heard his eloquent lecture just before the inauguration, and I would like to briefly tell you that he is into all the national and international arena, and I welcome you, sir, on the dais. Next, I would like to invite our esteemed senior person, Dr. Prakash Trivedi. He is the director of Dr. Trivedi Maternity Nursing Home, Dr. Trivedi's Total Women Healthcare Hospital and Akar IVF Center. He is a gynec endoscopist at Fortis Hospital, Mulund Jupiter Hospital and Thane Fortis. He is the ex-head of the Gynec Department and honorary professor of D.Y. Patil Medical College and V.C. Gandhi Rajwadi Hospital. He was a board member, IH, for 4 years and closely associated with AAGL, the world's largest organization for female laparoscopic surgery. He is the honorary professor and head of the department Gynec Rajwadi Hospital, D.Y. Patil Hospital Medical College for 17 years. Gynec endoscopic surgeries, he has performed 35,000 gynec endoscopic surgeries in the last 25 years, and he has almost 15,000 hysteroscopic procedures to his credit. His exceptional achievements are from receiving gold medal at MD Gynec 1983 to Indo-American Award of Professional Excellence. He has conducted several workshops and he has written 9 books, of which Beyond the Boundaries and Modern Gynecology is the latest one. He has done world's breakthrough research on in-bag morcellation for removal of large uterus and fibroids, and an expert for female urinary leak and designed urinary leak correction tape. His original research on fibroids and infertility, a study of 2,142 patients with totally new findings, is now accepted by Harvard Medical Center, Boston, Massachusetts, USA. With this vast curriculum vitae, I welcome you, sir, on the dais. Next, I would like to invite Dr. S. Ashish Reddy. He is a consultant microsurgical andrologist and director, Asian Andrology Hospitals. He is a member of International Society of Sexual Medicine, member of South Asian Society of Sexual Medicine, awarded Budding Andrologist of the Country by Economic Times 2025. I welcome you, sir, on the dais. Next, I would like to invite Dr. C.H. Shamala, Madam. She is presently the Observer, APMC, former Professor of Obstetrics and Gynecology at Gayatri Vidya Parishad. She has worked in the Department of Obstetrics and Gynecology, Andhra Medical College for 15 years. I welcome you, Madam, on the dais. Next, I would like to invite Dr. K.V.S.M. Sandhya Devi, Madam. She is presently Principal, Andhra Medical College, Visakhapatnam, and Professor and Head of the Department of Obstetrics and Gynecology, Andhra Medical College, King George Hospital, Visakhapatnam. She has worked as Nodal Officer for State Lifeline Center for Maternal Mortality and was a Vice President, OGS Vishaka, 2024-25. I welcome you, Madam, on the dais. Next, I would like to invite Dr. Radha Tatapudi. She is Emeritus Professor, Dr. YSR, University of Health Sciences, Member Specialty Board, National Board of Examinations, New Delhi, Organizing Chairperson for Yuva Foxy South Zone 2020. She was formerly Principal, Andhra Medical College, Visakhapatnam, Emeritus Professor, Dr. NTR, University of Health Sciences, Professor and Head of the Department, GIMSR, Geetam, deemed to the university. She has published several journals of pregnancy hypertension, EGOG and IJRCOG, and edited textbooks and contributed chapters to several books. I welcome you, Madam. Next, I would like to invite Dr. K. Subbaraju, sir. He is former Additional Director of Medical Education, former Professor and Head of the Department of Obstetrics and Gynecology, Andhra Medical College, and retired Civil Surgeon, King George Hospital, Visakhapatnam. I welcome you, sir, on the dais. Last but not the least, the most important, I welcome Dr. R. Sashiprabha Madam. She was the Director of Medical Education, Andhra Pradesh from 2003 to 2004. She has served the Federation of Obstetricians and Gynecologists of India Coastal Branch in various capacities as member, executive member, treasurer, secretary, vice president and president. She has done her MBBS from Andhra Medical College and bagged 3 medals as undergraduate student. She has done her diploma and masters from Andhra Medical College and she was topper in her DGO examination. She was the principal Andhra Medical College and superintendent King George Hospital as well. I welcome you, madam, on the dais. God, our Creator, has stored within our minds and personalities great potential strength and ability. Prayer helps us tap and develop these power. As rightly quoted by APJ Abdul Kalam, I invite the Nightingale of OGS Vishaka, Dr. T. Radha, for invocation.
Check.
या कुन्देन्दु तुषारहार धवला या शुभ्रवस्त्रान्विता या ब्रह्म श्री विद्यारोग्य सिद्ध्यर्थं शिवपुत्रं शिवंकरं विज्ञानानन्दकर भास्वन्तं विघ्नराजम् अहं भजे विघ्नराजम् अहं भजे अहं भजे.
If you light a lamp for someone else, it will also brighten your path. With this, I would like to invite all the dignitaries on the dais to traditionally light the lamp and enlighten today's meet. I also request Dr. Padmavati Naidu Madam, the upcoming president, also to join in the lamp lighting. I also would request Dr. G. Surya Prakash sir, interventional cardiologist.
President of society?
Yes.
No,
Yes, yes, sir.
President of society is ridiculous.
Journey of his life.
Since we have the investiture ceremony also coming up, so we will briefly do our inauguration by doing the launch of 2 videos that we have. So, Elie Santé is a French word that means her health, and its vision is to enable all women live healthy lives. Dr. Megan's dream is to help every woman alleviate all her intimate area concerns and restore youthfulness in the quickest recovery time possible. With this, I invite our esteemed guest, Dr. Navneet Megan, to launch the video of Elie Santé, the Center for Reconstruction and Cosmetic Gynecology, Visakhapatnam branch at Medsi Hospitals.
great honor and great privilege, and I think so in India and Bombay they always tell ki I was the person who introduced coenzyme Q10 in 2002, and the company was to get closed, And when I gave 3 talks on male infertility in Kanpur, Allahabad and Lucknow, the company people were after my neck, because from 250 strips they started selling 3 lakh strips. So in the same year I had introduced dydrogesterone. So I feel very homely when I'm talking with andrology. Let my friend talk.
Thank you so much, sir. Thanks for your great words. Asian andrology, we deal with male infertility and sexual medicine. Any cases of fertility might be an obstructive cause, non-obstructive cause. Here at Asian andrology, we deal with microtesticular surgeries where we can give every parent their own biological child. That's the only concept of Asian andrology. For any couples where you think donor will help, definitely here we can intervene and give them their own biological children. That's our motto, to give them biological children. And any kind of sexual problems, might be anything male or female, we deal with that. We are an advanced center for penile implants. And thank you so much for all your blessings.
Only those who have patience to do simple things perfectly ever acquire the skill to do difficult things easily. With this, I invite Dr. Sirisha Rani to formally welcome the gathering with her welcome address.
I'll just take few minutes. I just want to tell about the Medsi Hospital's journey. I'll just take 2 to 3 minutes. It has not been easy, constant stress, countless challenges, but building a good hospital has always been my passion. Year 1, identifying the place, laying the groundwork, and year 2, rising through the challenges, weather conditions, and overcoming the obstacles and building momentum. And year 3, the Medsi is like this. Recruitment of the staff, state-of-art equipment, and preparedness to open our doors to the future of healthcare. You can see the pics of present status, and Medsi is ready to launch today after 3 years, 3 days. I have started April 3rd, 2022. Now it is almost 3 years, 3 days. So these are some pics of Medsi. So I'll just tell you the making of the Medsi. It's all started here as Vizag IVF Center in 2015 by Dr. G.R.K. Raju and Dr. Sashi Prabha Madam, and 2017 at Vijayanagaram, 2018 at Gajuwaka by Dr. Subbaraju Sir, and 2023 at Srikakulam, and 23 at Vijayawada, and 24 in Telangana. I am the only person who started in Telangana from Andhra Pradesh. Everyone is like... And Vizag IVF emerged as one of the fastest growing fertility chain in AP, and all branches of Vizag IVF brought under the umbrella of Medsi IVF now. That's where the birth of Medsi IVF took place, and finally Medsi IVF became the part of Medsi hospitals, multi-specialty hospitals. And I'm happy to announce that we are starting El Sante Center in Vizag by Dr. Navneet Magan. He is visiting every month, and he'll be helping us in all surgical and non-surgical procedures. And we are also, I'm happy to announce that he is going to start the training programs at Medsi. The other thing we have launched just now, the Asian andrology, which is most often is overlooked, the male fertility. So we are giving importance to that. And Dr. Ashish Reddy, one of the popular andro surgeons in AP and Telangana, he is visiting our Medsi, and now he is full-time consultant at Medsi Hyderabad. So I just want to tell something to our youngsters out there, and this is the first Life Inside Sandhra Medical College, my temple of learning, and the second one is Krishna IVF and Krishna Hospitals. Dr. G.R.K. Raju taught us the art of perfection. The VSR Raju was the epitome of time management. He used to come just the head on the perineum. I don't know how his timing was unmatched. The third is Dr. G.A. Ramaraju, my teacher, guide and philosopher, taught me the true essence of patient care. And under his guidance, we worked tirelessly. That intense training was the true transformation of my life. I have to thank all these 3 lessons in my life. And the third most important, people may not know, the third life insights is OGSV. People are thinking that we are wasting time about the society activities, and it is not that. You have a lot of things to learn from OGSV. I just want to mention that. These are the mentors. So many mentors are there. I have mentioned a few of them. Dr. Shashi Prabha ma'am is an inspiration, a pillar of support with golden touch. Her ability to nurture and encourage young talent has left a lasting impact in many. Dr. Subbaraju sir taught me the perfection and discipline from the very beginning of my practice. He encouraged me, guided me, and he is a truly wonderful teacher. And Dr. Radha showed us how to carry ourselves with grace, stay calm under pressure, and aim for excellence. And I had the privilege of working with her on many conferences. She is an all-rounder and strong supporter of young gynecologists and doctors. Working with them was a wonderful experience. I am deeply grateful for the lessons they have shared. Dr. Padmavati T is a perfect blend of joy and perfection. It has always been a pleasure working with her as a secretary. And Dr. Padmavati Naidu may be perceived as a firebrand, but she is incredibly supportive, and she helped me fill my first nomination form and consistently uplifted and promoted young professionals, a true administrator with vision and strength. And it's a truly blessing to work with such mentors. I encourage all the juniors to be associated with OGSV. So we are conducting a national conference in May 17th, and then who are interested, they can come and join with us. So you will love it. That's my advice for the youngsters. And finally, I warmly invite all my friends for the launch of Medsi Hospital today at 4 p.m. Please come and share your valuable inputs, witness how a gynecologist has built a multi-speciality hospital with passion and purpose. You will notice the pastel shades, feminine touch throughout, a reflection of the multitasking spirit we women excel at. No one does it better than us. And your presence, blessing and support would mean a lot. Finally, thank you, Dr. Prakash G, Regional Director of Care Hospital, Maichinana. He's truly honored to have you with us, and thank you all for the support. And finally, be your own support system, stand for yourself, celebrate yourself, love yourself, and respect and learn from the seniors. Be ethical in practice, work hard, there's no substitute. Finally, pray to God. Thank you for all the support.
And now, to honor all these dignitaries on the dais, I would request Dr. Prakash Trivedi to honor our senior most Professor Dr. R. Shashi Prabha Madam with a memento. Also, Dr. T. Radha, I would request you to honor Dr. T. Radha with a memento. And Dr. K.V.S.M. Sandhya Rani Madam. Thank you, sir. I would request Dr. Shashi Prabha Madam to honor our speakers, Dr. Ashish Reddy, with a memento. I would request Madam to honor Dr. Prakash Trivedi sir also with a memento. Thank you, sir. Thank you, Madam. Dr. Prakash Trivedi sir, I would like you to honor Dr. C.H. Shamla Madam with a memento. And finally, I would request you to honor Dr. Sirisha Rani, the backbone of Medsi, with a memento. Thank you very much to all the dignitaries on the dais. And now we move on to the investiture ceremony. Vision without action is merely a dream. Action without vision just passes the time. Vision with action can change the world. As rightly quoted by Joel Barker, I would like to invite our outgoing secretary, OGS Vishaka 2024-25, Dr. Kiran Mai, on the dais for the investiture ceremony. And I hand over the proceedings of this ceremony to Dr. Kiran Mai.
Madam, the executive body on the executive body.
There you go.
sharing
Good morning, everyone. Now we move ahead with the investiture ceremony. Leadership, as we know, is not just a title. It's a responsibility, a commitment to serve, inspire, and drive a change. And today is that day of year when we welcome the newly elected executive and untrust and pass on the responsibilities of a society to them. At this juncture, I would like to invite our beloved President, Dr. Y.L. Narasimha Rao sir, onto the dais. Sir? Sir, please come. I invite our President, Dr. Y.L. sir, to come onto the dais. I request our Dynamic Secretary, Dr. Kiran Mai, to join in. Now, let me take the honor to invite our incoming President, Dr. Padmavati Naidu, onto the dais. She is known for her enthusiasm and her fearless attitude. Welcome, ma'am. She is the MD of Padmavati Nursing Home. She has been awarded Wonder Foxen Award and is also the President of AP Private Hospitals and Nursing Home Society. Now, I invite Dr. M.V.N. Pallavi, our incoming secretary, to come on to the dais. She is a senior consultant obstetrician and gynecologist and a director of Health Clinic. Now, I request Dr. Y.L. Narasimha Rao sir to address the gathering. Sir.
dignitaries on the dais, Secretary, respected dignitaries on the dais and off the dais, Secretary Kiranmayi, incoming President Padmavati Naidu, and Dr. Pallavi, incoming Secretary, and off the dais so many professors and legends like Prakash Trivedi and Navneet Megan, and dear friends. This is the last CME of our executive tenure. Myself as President and Dr. Kiranmayi as Secretary. And also today is the investiture ceremony for the President, incoming President Dr. Padmavati Naidu and Pallavi as Secretary. In this year, we did our best for the serving our society. And Secretary is the key person. Kiranmayi did a lot of hard work and spared her valuable time and sacrificed her a lot of practice and served the society. And I thank our senior professors, Dr. Viswamtv Madam, Krishnama Madam, Subbaraj Garu, and Sitaramaraj Garu, Radha Madam, and Dr. Padmavati Madam, who are constantly guiding us in the society activities. I thank them. And our Vice Presidents, Dr. KVSM Sanjay Devi, HOD Gynecology in Andhra Medical College and Principal also, no. She and Dr. Ragasudha, Dr. Vijayawada, and Dr. Sirisha, they all did a splendid job as Vice Presidents. And many others, like Dr. Somani as a PA, Public Awareness Committee Chairperson, did a lot of hard work. She conducted many health camps and awareness camps, especially in tribal girls' hostels, government women's college, and so many activities. At some Vaibhav Venkateswara temple also. So many activities there. Kiranmayi will present them. And Dr. Vani as a Sikh chairperson, and many others. They contributed very much. And coming to the members gave us this opportunity to serve the society. We always remembered that, and we wanted to be, we tried to be transparent, democratic, and justifiable to all. And we wish that a friendliness and a camaraderie should exist between the members and the office bearers. And I wish all the best to the incoming President, Dr. Padmavati Naidu, Secretary Pallavi, and their executive team. Padmavati Naidu, she has also experienced, she earlier worked as the President in Appana, and I am confident they are young and energetic, and they will do best for our society. Thank you all.
Thank you, sir. Now I request Dr. Kiranmayi to present the Secretary report for the year.
Good morning, everyone. I am here to present an overview of the work done by our society, Obstetrics and Gynecological Society of Visakhapatnam, over the last 1 year, from 1st April 2024 to 31st March 2025. OGSV has been actively engaged in various activities from April till date. It may be difficult for me to mention each and every activity in the time given, but I will try to outline the key initiatives, the educational programs, the community outreach programs we have done during this period. We all know the Obstetrics and Gynecological Society of East Andhra Pradesh had its humble beginning in 1966, and it was renamed to Obstetrics and Gynecological Society of Visakhapatnam on 30th May 2007 under the presidentship of Dr. K. Subbaraju. OGSV saw an increase in membership this year to 560 from 515 last year. I think this is the highest number so far, and we have 5 medical colleges associated with OGSV. So the investiture ceremony in April 2024 marked the formal transition of leadership. We honored the contributions of the previous executive and introduced our new executive. We had almost 16 monthly meetings, though we call monthly meetings, we had more than one per month. We had privilege of hosting esteemed national speakers. Their contribution not only enhanced the knowledge of our members, but also reinforced that OGSV's commitment to bringing the best expertise to our platform. This is our first monthly meeting on PCOS by Aradhya Fertility Center. In May, we had monthly meeting on reproductive endocrinology and interventional radiology associated with ERIS. And Dr. Samita Bharadwaj educated the delegates on Manyata program. In June, we had monthly meeting associated with Vijaya Diagnostics, and Dr. Sneha Buyar was one of the faculty. This is live relay from Kolkata on HMB by Professor Giovanni Grandi from Italy. July was very busy month with many meetings. On 7th, we had Gestosis Committee meeting associated with Spectra. Dr. Alpesh Gandhi, Dr. Suchitra Pandit, and Dr. MC Patel were the guest faculty. And we had CME on Preserve the Uterus associated with Bayer on July 19th. And it featured Dr. Priyankur Rai, who was the chairperson, Public Awareness Committee, FOXY. And on July 20th, we had the training program to staff and faculty at Andhra Medical College. Dr. Shivananda, Superintendent KGH, and Dr. KVSM Sandhya Devi, head of the department, spoke about the Andhra Pradesh government collaboration for Preserve the Uterus initiative. And we had the whole day CME by Safe Motherhood Committee associated with Senora on 21st July. Dr. Poonam Goyal was the guest faculty. On July 28th, we had CME associated with Mayor. Dr. Bhaskar Pal and Dr. Krishna Kumari were the guest faculty. On 1st September, OGSV, in association with Clinical Research Committee, did update on clinical challenges and recent advances in OBGY. On 22nd September, we had symposium on understanding laparoscopy in gynecology associated with Medtronics. And on October 6th, we had CME by Medsi. Dr. Jatin Shah was the guest faculty. On 22nd December, we had a monthly meeting associated with Vrinda Hospitals. And on 2nd February, we had a whole day CME Prithvi by Rainbow Hospitals. And on March 16th, by Nova Fertility Center. So then we had our prestigious 58th annual CME at Vizag Conventions on October 26th and 27th. Near 440 delegates attended the program, again the highest number so far for OGSV annual CME. Dr. Shankabrata Bagchi, Commissioner of Police and Additional District Magistrate of Visakhapatnam, was the chief guest, and Dr. Jaideep Tank, President Foxy, was the guest of honor. We had two orations, Dr. H.M. Lazarus oration delivered by Dr. Jaideep Tank and Dr. Achut Menon oration by Dr. Rekha Kurian. So not only our local meetings, but many OGSV members have actively participated in regional, state, national, and even international conferences. I'm sorry I may not mention all the faculty names because of the time constraint. Till October, I have already given the update in annual CME in my secretary report. So I will more emphasize on the activities after October. Dr. K.V. Sridevi at Yukti Hyderabad, trainer at CUSP, Foxay Chennai, and Opus Delhi. This is Rajahmundry Obstetrics and Gynecological Society annual CME Amrut Dhara in December. Dr. T. Radha delivered talk on peripartum cardiomyopathy. Myself on robotics in gynecology, and Dr. Niharika on RH negative pregnancy. Coming to the state and journal CMEs, we had a significant participation from OGSV in APCOG Eluru. And the regional conferences, journal conferences, Dr. Niharika at Wisdom 2024, and at Southcon Vice President Conference Mahabalipuram, Dr. Sridevi at Vice President Conference Pune. Coming to the national conferences, OGSV had its mark in 3 national and 1 international FIGO conference this year, and 1 more we are hosting in May at E3Con National Conference in Kurnool. Then in November, OGSV had the opportunity to co-host AICC RCOG South Zone Annual Conference. Thanks to Dr. Ragasudha, who was the organizing joint secretary, and Dr. Sudharani Madam, who is the HOD Geetams. And this is the representation of OGSV at AICOG, Dr. Syamala, Dr. Rajalakshmi, and Dr. Niharika. And this is OGSV representation at Global Conference FIGO on updates in OBGY. Coming to the live workshops, we had a hysteroscopy live workshop on June 9th by Rainbow Hospitals. And as a part of Eagle project, we have conducted hysterolaparoscopy workshop in Andhra Medical College under the guidance of Dr. KVSM Sandhya Devi. Coming to the teaching programs, OGSV is proud to serve as faculty for 103rd MSc FMA skill course conducted at Andhra Medical College, and we trained more than 80 gynecologists. And this is NTR UHS Journal CME in Gayatri Medical College by Dr. T. Padmavati. Coming to the postgraduates participation, Dr. Supraja, postgraduate AMC, was awarded first prize in poster presentation at 9th APCOG conference. Dr. Medha Premanath won Mrs. Indumati Javeri prize in AICOG 2025. And this is our postgraduates participation in quiz in annual CME, and this is the postgraduates participation in Eagle project. And apart from these academic activities, we had many RTMs, many webinars. Then we have attended all the 3 MCMs this year. MCMs really serve as vital platform for fostering the collaboration among the committee members. So this is MCM in Kolkata in April. This is where Dr. Sunita Tandulwadkar promised us to host the presidential conference, which we are going to host in May 2025. And this is team from APOG at MCM in September. This is in AICOG Mumbai MCM. We handed over our first brochure of waves to the President, Dr. Sunita Tandulwadkar. And we had various CMEs with various committees of FOGSI, Safe Motherhood Committee, Clinical Research Committee, No to WA Committee, Public Awareness Committee, Gestosis, Oncology, and Endoscopy Committee. These are the various members of OGSV as members of the committees at FOGSI. Coming to the contribution in books, Dr. Sailaja contributed a chapter on rupture uterus. Dr. Niharika co-edited book on pioneering women's health and also contributed one chapter in FOGSI focus on AUB. Coming to the awards, Dr. Sudha Padmasri received Dronacharya Award at ISAR. And we all know it's a proud moment. Dr. R. Sasiprabha was felicitated with a Lifetime Achievement Award in Southcon Vice President Conference, Mahabalipuram in June 2024. Really her expertise, mentorship and service have been pillars of strength for OGSV. Thank you, Madam. And another proud moment, again, Dr. Achyut Ramaraju received the ACE Lifetime Achievement Award at the 12th International Congress of the Academy of Clinical Embryologists in Pune 2024. And Sir also received Dr. Durusha Award at ISAR. We really take great pride in celebrating their remarkable achievements and our gratitude for their lifelong commitment to the profession. So coming to the Public Awareness Committee, under the guidance of Dr. Saumini, Public Awareness Committee Chairperson, Madam has done a lot of activities this year. Dr. Saumini, Dr. Sailaja conducted various educational and awareness programs at KGH, Safe Motherhood Day, Preeclampsia Day, Breastfeeding Week, and awareness camp at Tribal Girls Hostel, educating 450 girls on menstrual hygiene. And they have celebrated Adolescent Girl Child Day on January 24. Around 300 girls have attended, and we have conducted a CA cervix, breast and breast screening, and also screened 75 cases at Vaibhav Venkateshwara Kalyanam, Murli Nagar. And we know in solidarity through the heinous incident happened at Arjikar, OGSV conducted a beach rally under the Abhiya initiative. And condemning this, we conducted a rally in KGH and even supported IMA decision for 24 hours protest. And we have submitted our representation to the district collector and the commissioner of police. And the leadership has changed from January 1st, 2025 at the FOGSI, you know. So we have taken the presidential initiatives this year. One is Know Your Numbers. We have conducted a health camp on 280 girls in tribal hostel at MVP Colony, did KYN there, checked their HB, RBS, weight and BB. Another initiative on for Do TK Zindagi Ke, we have conducted a program on this, and as an initiative of Sampurna, we have conducted a program at KGH involving postgraduates, and as an initiative of EAGLE, I am given the responsibility of AP State Coordinator and one of the South Zone Coordinators for EAGLE project, and as an initiative of this, we have conducted the first project in Andhra Pradesh at Andhra Medical College, and it is appreciated as the biggest EAGLE project so far. And we have conducted a second EAGLE project at ACSR College, Nellore. Coming to the extracurricular activities, I have already mentioned in the previous report, we have participated in WDSL conducted by VDCCA and we bagged 2 prizes. And coming to the culturals, maybe this is also the first time Dr. Sirisha has organized this. We had a stand-up comedy which all our OGSV members have enjoyed a lot at our annual CME. And we have many talents in our OGSV, Dr. Syamala, Dr. Vidya Sudha, the singers, and many performances from Andhra Medical College and OGSV members. So you can see all the past presidents, all seniors, incoming presidents, president-elect, everyone encouraging and enjoying. This is called OGSV family. And this is OGSV team at RCOG representing different states of India. So we had privilege to host all the 3 FOGSI presidents, Dr. Jaideep Tank 2024, the president-elect Dr. Bhaskar Pal 2026 have already come to Visakhapatnam, and we are going to host Dr. Sunita Tendulkar, President 2025 also in this May. So, and we already had a general body meeting also where Radha Madam emphasized all the opportunities, what opportunities all the junior gynecologists will have in FOGSI. As Dr. Sirisha has mentioned, don't think it is a waste of time. So there is a lot of opportunity in OGSV, just participate, then you will know. So OGSV has already provided total 16 APMC credit hours this year and many ICOG credit points also. So what not, we had monthly meetings, regional CMEs, state, national, international conferences, RTMs, webinars, live workshops, teaching programs, postgraduate participation, FOGSI committee involvement, MCMs, GBM, general body meeting, contributed chapters in books, lifetime achievement awards, public awareness activities, extracurricular activities, took up the presidential initiatives and provided the APMC credit points also. Thank you all for the active participation, and we have the upcoming presidential conference in May, Waves, which our incoming secretary Dr. Pallavi will give the details about it. And as I mentioned in earlier meetings, we are starting the state chapter of IAGE with Visakhapatnam as headquarters also. The registration is in process. So thank you so much. All the activities conducted reflect our dedication to professional development and community service. I would like to thank all the members of OGSV for their active participation and dedication in making these activities successful. And my heartfelt gratitude to our President Dr. Y.L. Narsingarao sir. ఎవరికైనా కృతజ్ఞతలు చెప్పాలన్నా ఎవరినైనా ఓదార్చాలన్నా మదర్ టంగ్లో చెప్తే బాగుంటుందని మా ఫాదర్ చెప్పారు. థ్యాంక్ యూ సార్. సార్ నాకు టీచరు, నేను అండర్ గ్రాడ్యుయేషన్ అప్పుడు ఎంత కూల్ కంపాషనేట్గా టీచింగ్ చేశారో ఇప్పుడు కూడా అంతే కూల్గా అసలు ఏదైనా సరే చేసే కిరణ్మయ్య అని ఒక్క మాట అనేవాళ్ళు. థ్యాంక్ యూ సార్. అండ్ ఐ థ్యాంక్ ఆల్ ద సీనియర్స్. ఐ లెర్న్ట్ ఎ గ్రేట్ డిసిప్లిన్ ఫ్రమ్ డాక్టర్ శశిప్రభ మేడం. ఇప్పటికీ ఫోన్ చేసి ఫస్ట్ టాక్ ఎప్పుడు స్టార్ట్ అవుతుందమ్మా, లేకపోతే ఎగ్జిక్యూటివ్ మీటింగ్కి ఎప్పుడైనా ఆపితే నేను ఈరోజు రాలేకపోతున్నానమ్మా అని ఫోన్ చేసి చెప్పేవాళ్ళు. థ్యాంక్ యూ మేడం, రియల్లీ. అండ్ సుబ్బరాజు సార్ ఎప్పటికీ కూడా ఏదైనా మీటింగ్ అంటే కనుక కిరణ్మయ్య ఫోన్ చేసి కిరణ్మయ్య ఇది చెయ్యాలి గుర్తుందా అని గుర్తు చేసేవాళ్ళు. యాక్చువల్ మేం చేయాలి, సార్ చేసేవాళ్ళు. ఈరోజు మీటింగ్ ఉంది కదమ్మా అందరికీ చెప్పావా. సో దట్ గ్రేట్ డిసిప్లిన్ వీ హ్యావ్ లెర్న్డ్ ఫ్రమ్ అవర్ సీనియర్స్. థ్యాంక్ యూ సో మచ్. And all the seniors like Dr. B.S. Krishnamma madam and advisory committee, I should mention Dr. T. Radha madam. ఎన్నిసార్లు విసిగించానో నాకు తెలీదు. మంత్కి ఒక మంత్లీ మీటింగ్ ఏమో, కానీ నేను ఒక 10-15 టైమ్స్ అయినా మేడంకి ఫోన్ చేసి ఉంటాను. అండ్ డాక్టర్ టి పద్మావతి మేడమే నన్ను ఫస్ట్ అసలు ఓజిఎస్విలోకి రమ్మని ఇన్వైట్ చేశారు. ఏదో ఒక ప్రోగ్రామ్కి ఎంఓసి చేశాను. అప్పుడు యూ కమ్ టు ఓజిఎస్వి ఎగ్జిక్యూటివ్ అని. థ్యాంక్ యూ మేడం. అండ్ ఐ థ్యాంక్ ఆల్ ద వైస్ ప్రెసిడెంట్స్, డాక్టర్ కేవీఎస్ఎం సంధ్యాదేవి మేడం, విద్యారమ్మ మేడం, రాగసుధ అండ్ డాక్టర్ శిరీష, ఇంకా డాక్టర్ శ్యామల మేడం ఎప్పుడు గైడ్ చేస్తుండే వాళ్ళు నేను జాయింట్ సెక్రటరీ చేసినప్పుడు. డాక్టర్ సౌమిని మేడం ఫర్ ద పబ్లిక్ అవేర్నెస్ కమిటీ యాక్టివిటీస్. అండ్ థ్యాంక్ యూ డాక్టర్ సీతారామరాజు సార్ నేను వచ్చినప్పుడు ప్రీవియస్ యాక్టివిటీస్కి. అండ్ ద పాస్ట్ సెక్రటరీ డాక్టర్ నిహారిక, థ్యాంక్ యూ సో మచ్. ఇంకెవరైనా మర్చిపోయి ఉంటే సారీ. థ్యాంక్ యూ.
Thank you. As you have shown, it's been a...
అసలు మర్చిపోయాను, పద్మావతి నాయుడు మేడము. అంటే నేను అసలు టీ పద్మావతి మేడం నన్ను రమ్మని అడిగారు. పద్మావతి నాయుడు మేడం లిటరల్గా తిట్టి ఇందులోకి దూర్చారు. నేను చేయలేనేమో మేడం చిన్నపిల్లలతో అని అంటే, ఈ మంత్కి ఒక్కసారి రాలేవా అని చెప్పి తిట్టి నన్ను ఇందులోకి తీసుకొని వచ్చారు. థ్యాంక్ యూ మేడం.
Thank you. So as we have seen, it's been a year filled with great academics, wonderful workshops and colorful cultural events. Now to move on, I request our beloved President Dr. Y.L. Narasimha Rao to welcome the incoming President and to hand over the President Medallion of OGSV to Padmavati Naidu ma'am. Thank you, sir. Now I request our new president to address the gathering and speak a few words on our committee's future agenda.
Good morning and namaste to my respected teachers and seniors, Dr. Shashiprabha Madam, the doyen of our society, Dr. Subbaraju Sir, my mentor Dr. Radha Madam, Dr. T. Padmavati Madam, Dr. Sitaram Raju Sir, outgoing President Dr. YLN, our dynamic Secretary Kiran Mai, and my incoming Secretary Dr. Pallavi. Today's special guests Dr. Navneet Megan and Dr. Prakash Trivedi Sir, my dear colleagues, juniors, postgraduates, my beloved Kohinoor classmates and friends. It's with immense gratitude and heartful of pride that I stand before you today as the unanimously elected president of the prestigious 59-year-old Obstetrics and Gynecology Society of Visakhapatnam. Thank you each one of you for placing your trust in me. I promise to carry forward the legacy of OGSV with sincerity, passion and unwavering dedication. My journey with OGSV began as Joint Secretary. That moment marked the start of beautiful and fulfilling commitment, a commitment that has shaped me as a professional and as a person. Since then, there has been no looking back. I have invested my time, energy and skills and above all my heart into every step of this journey. As Joint Organizing Secretary of South Zone UFOXI Conference, I embraced multiple roles and challenges. That experience wasn't just about organizing an event, it was about showing what OGSV was capable of on a national level, and it was our first conference step into the wider FOXI world, and we made it count. From there, I served as Vice President and nominated member. In every meeting, every event, every initiative, I was present. I took on responsibilities with pride and gave each one my all. Whether it was annual convention or academic programs, I worked with a single-minded goal to uplift OGSV and contribute meaningfully to its mission. Every step in this journey has been a lesson in leadership and a chance to serve and a moment to grow. And today it's a great honor and a humbling privilege to be entrusted with the responsibility of leading OGSV to the next chapter. But I cannot do this alone. I seek your wholehearted support, your energy, your ideas and your involvement. Together we can make this tenure not a successful one but a truly transformative one. I am thrilled to announce that my tenure is beginning with the prestigious national conference WAVES. Here I want to emphasize people are getting confused between the WAVES Presidential Conference and APCOG. APCOG is a state conference and WAVES, the Presidential Conference, is a national conference. So I request all of you who have been asking outside more about APCOG than WAVES. WAVES is our conference, national conference, which is being held at our doorsteps, where all the faculty who of the FOXY are coming and giving us, they're going to impart us so much of knowledge. So I request all of you to give importance to our presidential conference rather than APCOG. It's not just a conference WAVES, it's a celebration of knowledge, a chance to learn, to grow and shine together. I earnestly request every member of OGSV to register and participate. Let's come together and make WAVES a resounding success that showcases our passion, potential and power as a society. My vision for this year would be expanding our membership base, because the strength of OGSV lies in the unity and enthusiasm of its members. Elevate OGSV in the FOXY map through active participation, visibility and representation at the national level. You have seen last year how we have participated at national and international level. Same way we want to go a step ahead. Foster robust academic activity by promoting CME programs, workshops and research collaborations that benefit every member. Champion of women and girl-centered activities, reaching out to those who need our care, compassion and medical guidance at the most. Support the FOXY President's initiative, Cancer Vimukt Bharat, with powerful message of Do Teeke Zindagi Ka. Let's make cervical cancer prevention a personal mission by promoting HPV vaccine and educating women to every community. Strengthen our public awareness efforts by conducting talks, outreach and awareness drives through our committee members. Address adolescent anemia with focused energy by organizing hemoglobin detection camps in government schools and offering nutritional counseling. Even an hour of your time can make a lifetime difference to a girl. In conclusion, I stand here today with heart full of gratitude, a spirit of service and a dream for OGSV that is bold, inclusive and progressive. This is not just a position, it's a responsibility. With your support, I am confident that together we will create a year that is remembered for its energy, innovation and impact. Let's continue the journey hand in hand with purpose, passion and pride. Thank you.
Thank you, ma'am. Now I request our incoming secretary, Dr. M.V.N. Pallavi, to speak a few words on our upcoming presidential conference.
Respected mentors, dynamic predecessors, distinguished guests and dear members, a very good morning. It is with immense pride and gratitude that I accept the role of Secretary of OGSV on this auspicious day of Sri Ram Navami. Our mentors, respected Dr. Ramakrishnan Raj Garu, Dr. Sasiprabha Madam, Dr. Subbaraj Garu, Dr. Radha Madam, who with their positivist vision always seek to foster thriving and resilient systems in place for our OGSV. And of course, the dynamic leadership of our predecessors for guiding us to this moment and have left us a very high bar to reach. As I begin my tenure, our team, OGSV, and the organizing team has taken up this significant and humongous responsibility for conducting the prestigious FOXY Presidential Conference, which we were entrusted by the efforts of our previous team members and Radha Madam. So the conference is aptly named as WAVES, which is a true reflection of a beautiful city of destiny and also stands for Women Advancing Through Vision, Education and Science, symbolizing a commitment for women's healthcare. This is an incredible opportunity to take our society to the next level and put it on the national map. Today, I am reminded of this quote from the pioneering British doctor, Dr. Thomas Sydenham. The art of medicine was to be properly learned only from its practice and exercise. So with this philosophy in mind, we are privileged to host WAVES FOXY Presidential Conference, which will feature national and international medical savants as faculty, including the President of FOXY, Dr. Sunita Tandulwalkar, and whose leadership in advancing the fields of obstetrics and gynecology and her dedication in improving the women's health across the country is truly inspiring. Along with the Vice Presidents of FOXY, we also have renowned international faculty such as Dr. Anant Karamanchi contributing to the depth and quality of our sessions. The scientific program will cover a wide array of disciplines in OBGYN, showcasing the latest advancements, including the integration of AI into our field. We also have engaging workshops led by experts focusing on relevant cutting-edge topics. A special initiative, KYN Know Your Numbers, which is focused on ensuring defatigable women's health by FOXY, will also be a part of this conference involving celebrities. And most importantly, this conference is a fitting debut platform for all the young budding gynecologists and FOXians to showcase their work through posters and paper presentations. And not to forget the icing on the cake, we have 4 APMC credit points and ICOG points too. And all work and no play always makes Jack a dull boy. So in addition, we have a cultural program curated by Sri Lekha and her team to help us rewind and enjoy the true spirit of togetherness and renew old friendships and foster new communications and connections. The conference will take place amidst the roar of the sea and the echo of the valley at the exquisite Radisson Blu, a perfect venue for such an esteemed event. I encourage all members to register and participate in large numbers to make this event, our event, a resounding success. Let us all rise to the occasion and work together to ensure that WAVES is just not an event, but a milestone in our society's journey towards greater excellence and recognition. As Abraham Lincoln said, the best way to predict future is to create it. So let's create future by bringing our society onto the national map. Looking forward to all your wishes for a successful tenure wherein I would want to work with each and every one of my colleagues and hand in hand, and thank you so much.
Thank you, ma'am. Now I would want to introduce the rest of the executive to the gathering. As I call upon the names, I request the members to come on and stay back on the dais for a group photo. Starting with the advisory committee, we have our seniors to help and guide us through the events. Dr. Krishnamma ma'am, Dr. Subbaraju sir. Sir, please come on to the dais. Dr. T. Radha, Dr. T. Padmavati, this year we have a president-elect for year 2026-27, and I invite Dr. KVSM Sandhya Devi onto the dais. We have 4 vice presidents. We have Dr. Saumini, Professor AMC, Dr. Vidyarama, Professor AMC, Dr. Sirisha Rani, and Dr. Sridevi, Dr. KV Sridevi. As joint secretaries, we have Dr. N. Shivani, Dr. Suvida, myself, and Dr. Srujan. Dr. Shamla K will be the treasurer for this year. Moving on, we have the website committee, and Dr. Rekha and Dr. Niharika Allu would be the members. For the Public Awareness Committee, we have Dr. Usha Devi, Associate Professor AMC, and Dr. Sharmila, Associate Professor AMC. As members of OGSVC, we have Dr. C.H. Shyamla, Dr. I. Vani, Dr. G. Rajalakshmi, and Dr. Rajshri. Moving on to the nominated members, we have Dr. B. Sudharani, Dr. J.V. Narsimha Rao, Dr. N. Uma, Dr. Hemalata, Dr. M. V. Sujata, Dr. B. V. Satyavati, Dr. Usha Prasad, Dr. A. Padmaja, Dr. Kiranmai Gotapu, Dr. Chitrareka, Dr. Samita, Dr. K. Vidya, Dr. V. Saroja, and Dr. R. Dedipya. I request members who are present to come on to the dais. And as postgraduate representatives, we have Dr. Shaini, Dr. K. Radhika, Dr. Ashrita, Dr. T. Kavita, Dr. Manognya, and Dr. A. Manisha. So here we have the complete team of OGSV, and they'll be helping us and guiding us through the next year. I request everyone to settle down for a group photo. Okay. President seeking blessings from Shashi Prabha ma'am. Thank you. Now, as a gesture to appreciate the dedication and the timeless efforts put on by the outgoing team, I request seniors to stay back so that we can felicitate our President and Secretary. I would also want to invite Dr. Shashi Prabha ma'am and Dr. Sita Ramaraj Garu to join us for the same. going ahead with the felicitation of our past president, Dr. Vayalan sir, Dr. Vayalan Narsingha Rao sir, our outgoing president. I request all the seniors to join in. Blazer. Now I invite our beloved secretary, Dr. Kiran Mai. Meanwhile, a car has been put on in the parking. Number is AP40CD3599. So whoever is the owner, please go and attend to it. The engine is put on. Car number 3599. It's a Honda Elevate. Yeah, one more goals to work in OGSP for that beautiful sari. Thank you. Now we'll go ahead with the academic session.
A small announcement to everybody. Please check your signatures being done again in the Excel sheet placed in the registration counter against your names to obtain your certificates without missing. Please check your signatures, please.
అది కూర్చోట అవన్నీ దిక్కు
దీని మీద పెడతారా
దాని మీద పెట్టిద్దాం మైక్ కూడా పెట్టేసాం
Clear the stage for the next session.
promise of good health for them and yourself. Mid-Sea Hospitals was
Madam. She is the past president OGS Vishaka, professor and head of the Department of Obstetrics and Gynecology, Gayatri Medical College, Visakhapatnam, former vice principal of and head of the Department of Obstetrics and Gynecology, Andhra Medical College, former state nodal officer, Maternal Lifeline, Andhra Pradesh. Request Madam to come on the dais and occupy the chair. I would also request Dr. C.H. Padmavati Naidu. She is present president, as you all have seen, and I would like to congratulate her today on her president's investiture. She is not there? Okay, she'll come in some time. I would also like to invite Dr. K.V. Sridevi, specialist fetal medicine, to come and occupy the chair on the dais. I hand over the proceedings of this session to the chairpersons. First topic, Madam, Ergolix. Ergolix, the game changer. Dr. Prakash Trivedi. And CV on that.
It's my privilege to introduce Dr. Prakash Trivedi to deliver lecture on Ergolix. He is the director of Trivedi's Maternity Nursing Home and Akar IVF Center, and he is a gynec endoscopist, Fortis Hospital, Mullen Jupiter Hospital and Thane Fortis, ex-head of the gynec department, honorary professor, D.Y. Patil Medical College, board member IAGE for 4 years and closely associated with AAGL, the world's largest organization for female laparoscopy surgery, honorary professor in Endov Department, Gynec Rajawadi Hospital, more than 35,000 gynec endoscopic surgeries he did in last 25 years, one of the largest series in Asia. He has exceptional achievements from receiving gold medal at MD Gynec to Indo-American Award of Professional Excellence. Sir, with you.
Sure. Yeah, I think so. By the time they connect, not like KBC, not taking out my time. A great pleasure to be present for the first time in Vizag. Thanks to Srisha Madam and the society and all of you. Couple of important things, and I think so I was very happy to listen to Navneet's talk, because way back in 2006-2007, when I started my new consulting room, I was the officially qualified cosmetic dermatologist of face, everything trained in Gold Coast. And we had invested almost 1 crore of rupees. Me and my wife, she was a diet expert. And what used to happen funnily is that in the daytime I used to do laparoscopic removal, fibroid and this and that. And then in Gold Coast I became a guinea pig. So I did filler, Botox, I did everything. And everybody were thinking why this gentleman is so much interested. So I always gave them an example. In IVF we call it feel like an embryo. Then after the course got over, I told how much money you paid. They told this much. So I told I earned so much because this procedure cost of all this peeling, this, that I did every day was 50,000 more than what is our course fee. But then when I started, I realized before any cosmetologists in Mumbai had started, the articles were there in the paper, the whole skin and cosmetic department, they got shaken up. कि कौन है, gynec कहाँ से इतना cosmetic, and we had all the machines. I have 2,000 square feet of luxury lounge, consulting. So I know actually pure cosmetic, and when we started, it was becoming so heavier that every patient used to bring husband, जरा इसको गोरा कर दो, son, जरा इसको ये कर दो. I mean, they will bring themselves. And then the funny part was non-surgical weight loss. We had Pro Elix machine. So in that you have to. We used to have models. We had Jackie Shroff's somebody and XYZ. So you had to do actually the procedure wherein they are hardly dressed. So I used to do, in the afternoon I used to have 2-3 procedure, and everybody used to tell, no, we want sir only. So my wife and everybody is telling, why sir only? I told, because sir is because I am continuously talking to them, because they are hardly having very less clothes. And then when you are doing, so you have to keep them involved. Then after some time, that work became so much, then I thought, who will do, my wife is an embryologist, who will do IVF? Who will do laparoscopic surgery? Who will do urinary incontinence? So then we told, actually we should have outsourced at that time. And then as in Navneet's talk we got, now any Tom, Dick and Harry, that in those times even a homeopath used to start cosmetic. Even a pharmaceutical company used to start cosmetic. So I have very in-depth knowledge of cosmetic, and in 1995 I was the first qualified CO2 diode laser in laparoscopy. And in Foxy I published that in laparoscopic surgery the role of all this laser is in the dustbin, because CO2 was too costly. We had in Jaslok, diode was like a torch pointer and various things, and by the time you adjust the probe and excess charge. So I told all the 3 companies, whatever is the frank opinion I will tell. The other important thing is, apart from the fact which I told about coenzyme Q10, in 2002 I got my gold medal because of urinary incontinence in 1983. V.N. Purandare thought that nobody knows so much of urinary incontinence. So in 2002 I designed a tape T-suit which got the national award in Kochi AICOG. So we have the largest reference in the world for female urinary incontinence. I released a book in 2011. Then after that, another important point was the medical treatment. The urologists find that it is too small a subject, and gynecologists don't know. You either give Norflox, this, that, and etc. It was I who introduced urogynecology in Foxy. And Foxy 2025 to 2027, I will be a FIGO representative for urogynecology and pelvic floor disorder. So that's a huge branch representing the whole India. So coming to another point which I also wanted to mention, one with Navneet told, and I will just little bit, I will totally agree about what cosmetic aspect he told. Any and every Tom, Dick and Harry is nowadays IVF people cosmetic, this one cosmetic, this one cosmetic, this one cosmetic, and the amount of glorification of cosmetic goes. I used to discuss with my friend Ajay Rane, and because we have done a lot of work with mesh and so many other things. So I think so you have to identify what is best. Now, for example, a female goes and does some vaginal cosmetic enhancement after spending 75,000. Is she going to come out and tell कि नहीं कुछ फर्क नहीं पड़ा? फर्क एक ही पड़ता है, थोड़ा fibrosis बढ़ जाता है. Where do you generate the collagen from? See, in UAE, people don't have SUI. People don't have vaginal problem, because they have multiple deliveries. In one day they are discharged, the pelvic floor is good, So you have to understand, as he rightly pointed out, contraction of collagen. So now many things are aimed at generating collagen from an Asian woman wherein the collagen level is less. So I thought before starting my talk, I will give a little bit of a brief about this because that was relevant to his subject. And I always get, when I was a cosmetologist, people used to come and pay money as you want. And we were the only one in Mumbai. But then we stopped it because then who will look after our female? I love to always chase subjects which are difficult. So again in 2002 I had introduced dydrogesterone, which is the best medicine for patients who want fertility and endometriosis. Today I will highlight on oral antagonists because right, left and center everybody is talking about oral antagonists as a panacea. I know many laparoscopic surgeons, oh you don't worry, oral antagonist is going to come, it will change the scenario. IVF people also, don't worry. But what my point is, when we go into a molecule, you go into the depth of the molecule. Because the pharmaceutical company feels that gynec don't know to operate. They are very clear. Prescribe some medicine for two years, 1 year, they are happy. So basically, you have to remember that the biggest controversial disease in women, and I call it as a disease of the millennium, which is endometriosis. Right from Mel Cohen's time, and I used to talk to him, sir, why do you give pseudo menopause? Why do you give pseudo pregnancy? So I used to tell, why you give pseudo treatment? Why you don't give actual treatment? So we all are brainwashed on endometriosis. Endometriosis suppress. So we had danazol, we had depots, we had so many other things. Of course, during that time, dydrogesterone was introduced, but I introduced in India in 2002, which is the largest study in the world. Now, pre-treatment OC and progesterone doesn't do any damn thing. It's total waste of time if you're interested in fertility. The biggest shock I got when in 2019-20 I was called to Singapore, Malaysia, Taiwan and many places to talk about optimum use of dydrogesterone. I was shocked because the ESHRI 2022 guideline mentions that the only treatment, medical treatment of endometriosis is ovulation suppression. So my flight from Bombay to Singapore, I read the guideline once, then I read the guidelines on the day prior, and that guideline has my entire research done from 2002-2007 with laparoscopic surgery followed by no suppression, giving dydrogesterone, and then so 40 to 60% were pregnant in 7 months till the time people were giving depot. Danazol only gave hirsutism, weight gain and loss of money. So basically you have to understand that we have to be very clinical surgeon. By clinical surgeon I means that you have to understand when to operate, when not to operate. And the slide was old because now we have finished 56,000 surgery in 32 years. Whether it's fibroids, endometriosis, only 32,000 laparoscopic myomectomy. So plenty of surgeries we have done. But I don't mix up surgery between molecules. Because if you mix surgery between molecules, you will be misguided. Laparoscopic surgeon have an aura. I'll show you some surgery just to finish the thing. Aura that, anybody who doesn't know to operate should give oral medicine. So I asked, what will you do if your daughter had an endometriosis? Or your daughter-in-law had endometriosis? They didn't have any answer. Because laparoscopic surgeon have megalomania. Look what I can do with laparoscope. So it is absolutely ill-founded. 25 years I used to talk to, I was an endoscopic surgeon for almost all ART people in India. And I felt that 25 years they were misguided by ESHRI guideline and ART person for endometriosis. They kept on giving depot, they kept on suppressing. Patient who has come to you for fertility, you advise them contraception. So from that time onward, from 2002, I started, down south Dr. Rajan started, then PC Mahapatra started, then BN Chakravarti started, then everybody started. So basically you have to spend time on a molecule. So now oral antagonist. Is it a game changer or a passing wave? Now why we have to understand? Because 60% of endometriosis will come to you after the age of 30. So before that she is already ruined by one surgery, or before that they are giving multiple things. Secondly, you will have 40 to 60% who have severe menstrual cramps. There are many people who will have pelvic pain. There are many people who will have their relatives having endometriosis, and they also get endometriosis. Most important is the diagnosis of endometriosis is delayed by 10 years on an average. So basically you have to remember that the burden is with 48,000 gynecologists. Nowadays in North I see surgeons operating endometriosis laparoscopically. The gynec is standing. They are not even washed up. And there are many patients at 35-year-old, they get hysterectomy done for endometriosis. So you have to understand that the responsibility is big. Dysmenorrhea, non-pelvic pain, dyspareunia, diagnostic delay, and suboptimal treatment of various things. Why? Because you are not treating endometriosis, you are suppressing, you are taking paracetamol for headache. 1997 I was talking to Jack Doniz and Kamran Nezad. We put danazol into dustbin because it did nothing except androgenic side effects. So basically you have to draw a balance between, you have to reduce these side effects which can be bone mineral density loss, vasomotor symptom, thromboembolic phenomena, improve pain relief, improve heavy menstrual bleeding, improve fertility, and most important is improve quality of life. Now these few surgeries I am showing because I used to remember in North-South, there was some phases in my life where I went to Goa, all 7 cases were endometriosis. I went to Calcutta, all 7 cases were endometriosis. Somewhere in North I found that many things which was odd looking, which may be brown, which may be reddish, which may be puckered, everything was endometriosis. For somebody else it was everything was tuberculosis. So I believe that you should have a tissue diagnosis. Without that there is no point. Now endometriosis surgery, the biggest joke is all laparoscopic surgeon, all gynecologists feel that they do the right surgery. But you have to remember that doing right surgery, 80% of the gynecologists will do not a right surgery. So you have to actually introduce dilute vasopressin, peel off the lining, after you drain, again reintroduce vasopressin and take out the lining, so least amount of follicle. Me and BN Chakravarti with NIRH in Bombay, we were working for a vaccine which can reduce the impact of endometriosis. So you can get endometriosis of multiple varieties. Now this was an interesting patient. This was a recurrence. She was unmarried, 20 weeks bilateral endometrioma. Husband count was 4 million. So I did Brossen's technique wherein I undertreated, drained and fulgurated and put her on, she was in the interior of Maharashtra, she couldn't come. So put her on letrozole and I started dydrogesterone on day 5 to day 25. With 4 million count, she had first a daughter 13 years back, then a son 9 years back. No need of anything else, no need, because dydrogesterone permits you for ovulation, permits you for the support, reduces threatened abortion, reduces mid-trimester pregnancy loss. So all this oral antagonists and dydrogesterone and stimulation will be mutually supplementing. Now we, being a referral center for endometriosis, we get bladder endometriosis. The classical history about bladder endometriosis, there will be one cesarean section, they will have bladder endometriosis, which we love to operate because a laparoscopic surgeon, everything is a challenge. But this doesn't respond to medical treatment. So this has to be excised. I'll go further. Then we have at least 6 cases of ureter involved in endometriosis, wherein we have treated laparoscopically endometriosis. Then I have dissected the ureter. I always dissect the ureter with a surgeon friend of mine. And I call my teacher, senior urologist, after I have dissected the ureter. I call before, no, Prakash, we'll do open. So every time when I have dissected, then we had done uretrovesical implantation, and then he used to call me at night, honestly, with your 4K 3D laparoscopic surgery, it is better than any book to see the surgery. Obviously, we have to pay to anybody who is attending. Then there are a lot of complex disease. Now you understand that all will respond to oral antagonists. It cannot respond to oral because it never responded to depot. In fact, red wine, with him he's a father of endometriosis surgery, he passed away. He was with me in Calcutta in South, and he used to tell that the biggest fraud in the world was the Lupron fraud, because Lupron company had 7 out of 10 owners who were gynecologists. So that giving depot, long depot, etc. depot, they were all company driven advances. Now here if you are seeing dissecting the ureter, and why I am showing you this is because we do all these surgeries. Most difficult surgeries of the world comes to India. It comes to my place also. It will go somewhere else also, because apart from 3 of us who started, one of my friend passed away, but another friend always moves internationally. So nationally I was the only person going from 32 years. Now we have so many people who are expert in different surgeries. So now I joke that young boys don't dream about Nayantara, don't dream about Madhuri Dixit. At 3 a.m. they have rectal nodule in their dreams, and that also asymptomatic. So basically you have to remember that it's an estrogen dependent disease, and this was the ESHRI 2022 guidelines, which I told you make a big blunder. So after that they called me. After that my entire talk of Singapore and all was lifted by China and Russia, and all the researches after that, first 60% was my content, then they put IUI, then they put IVF, because the entire thing was new. Then when I discussed with the ESHRI people, so I told you, I acknowledge that you have published my whole research, but how can you mention that medical treatment is suppression of ovulation, and suddenly they got tube lights. Then they had Empire State Guideline, 3 hours discussion, and when I saw that question, all questions were mine. So that means, like dydrogesterone, I used to always joke, I am one Akshay Kumar with 137 heroin now. Dydrogesterone, there are many companies making. So then I informed them, and then they acknowledge, and then Empire guidelines will be soon coming. So we treat with hormonal contraception, but sometimes I feel estrogen, why do you give any endometriosis estrogen? Because estrogen supports the disease. So OCs doesn't have any place. Then analogs and antagonists, if blocked for long period, will shrink the disease, but will not treat the disease. It will only shrink. Progesterone can halt because it leads to decidualization. Then conservative surgery. All of us, Srisha is an ART expert, there will be many ART experts here. All of us give depot for inflamed endometriosis, in endometriosis when we are taking for ART, recurrent endometriosis. We all give. The long 6 months, 9 months depot is disqualified nowadays because they feel it is not required for such a long time, even prior to IVF. So Dynogest again, if you do prior to IVF, it will reduce fertility rate. So again it is not recommended. So there are clear RCTs. Now when we go to oral antagonists, what is new about oral antagonists and why people were, because everybody were thinking if there was something which can be given orally to down-regulate for endometriosis and to down-regulate for pelvic pain, down-regulate for infertility, to down-regulate for various aspects. But it is less costly and can be taken orally. So so a lot of endometriosis which will have major presentation is pelvic pain, infertility, abortion and recurrent surgeries. Now, all these things can be prevented by oral antagonists, which it becomes promising because it suppresses directly GnRH, so it decreases FSH-LH, so it decreases estrogen. My son always told, okay, how do you call it as a non-hormonal? Because it is suppressing. So it is suppressing, but my point is, for example, I had operated a patient of endometriosis and I will give 4 to 6 weeks of oral antagonists and then take her up for stimulation. Whether I want to give letrozole, FSH and IUI, whether I want to do ART, I can just straight away go because your E2 is suppressed. And I always support with dydrogesterone from day 5, not to day 25, till 31 if she is pregnant, then I continue to 22 weeks because dydrogesterone reduces abortion. Dydrogesterone supplements the immunology aspect and dydrogesterone reduces mid-trimester pregnancy loss. After 22 weeks, there is no point in giving anything. The inflammation, which is urocortin binding protein, is increased. So what does oral antagonist do? The elevated urocortin levels etc. is reduced. Now the advantage here is the whole therapy, I think for a month, may cost 6,000 rupees. So you're not giving a depot, so you're giving just oral, whether 150 or 200. So it makes things easy. It can be even one daily dose also. So there is a lot of advantage. And all of us have patients, bar endometriosis, bar surgery. All of us are patients. So many of these patients can be given a higher dose twice a day for 6 months or 1 year, and patient will be happy. There is no pain. No pain, no weight gain, not excess money, and nothing. So basically, the oxidative stress and the inflammatory cytokines which are increased, wherein estrogen plays a major role. And that is why when you suppress with oral antagonists, it is like giving a depot, but you are giving it at much lower dose, much lower cost. Obviously the presentation can be dysmenorrhea, dysuria, dyschezia, allodynia. Now, allodynia is a very important thing which we see but we don't understand. Unbearable pain in the pelvis going to the leg is endometriosis. So you just put them on 200 milligram of oral antagonist twice a day for 6 weeks, therapeutic. You will find that allodynia is gone. Allodynia is not identified only by most of us. So various other symptoms are there of superficial, deep, and I will not go into simple details of what is severe endometriosis and all. GI tract and rectovaginal and endometriosis, now it has become a fashion. Every YouTube I did the rectal nodule. I just stopped watching YouTube. In fact, I did PhD in numerology and Vastu. I was just telling to Navneet, I am ranked number 4 numerologist of India and Vastu specialist, because I felt I don't want to waste time in watching same surgery. So somebody told, why didn't you do? Maybe it's like Amitabh and Rajnikant mentioning, tomorrow I am going to go here, day after tomorrow I am going to shoot here. Well, 56,000 surgery, how will we continuously keep on projecting? And all said and done, all patient will never give consent to live demonstrate. So they tell we are taking consent and all, it is all fake. It is impossible. I know one patient from Germany, I allow all the patients relative to be inside the operation theatre. from 1992. My son doesn't like it. That patient from Germany, when my fellows and assistant and all came, he told me, no sir, you cannot allow them. I told somebody is assisting me and others are doctors. Well, but you are not allowing me, husband. So for some reason I told. So basically what I am trying to tell is anybody telling in YouTube we are taking consent of all patients, it is cold-blooded lie. Because nobody will like anything to be, but everybody wants to show off how much I do, how much. I used to operate from 8:30 a.m. Even Sanjay Patel, Praveen Patel, all the big people are trained under me. I used to operate from 8:30 till 11 in the night. And they used to go into endoscopic shock, watching so many surgeries. And in addition to that, our consulting used to go till 2 o'clock, and it used to be 110 patients and all. But in that age, 3 hours sleep was enough. So from 1995 to 2007, I slept only 3 hours. But that was more than enough. Even when Kapil Dev came, he was also worried. So I talked to his Kapil Dev's mother. So I told him, Punjab mein I used to go and operate in Jalandhar. So वो पंजाबी में थोड़ा बोला कि now new study comes that you have to sleep for 12 hours a day. मतलब की बात कर रहा है. So मैं बोला, look, I sleep 3 hours, Kapil Dev sleeps 3 hours, Shah Rukh Khan sleeps 3 hours, many people sleep 3 hours. Because if Tendulkar will not score runs, who will score runs? So my point is, if you will not do our work, who will come and do? So if you love your work, you don't get tired. 3 packed deep sleep, it is quite enough. Madam also must not be resting. I am telling you, the world's best branch in gynec, obstetrics, IVF, endoscopy, urogynecology, sonography, and now I may introduce even cosmetic, vaginal surgeon. Greatest are in India and tireless are in India. Like on a Sunday, Ram Navami, such a packed hall can be in presence of Ram only. So basically, we don't get tired. We hardly get tired as long as we are working. Now, comparing with Dynogest, there is no comparison, because Dynogest will have breakthrough bleeding, menstrual irregularity, and you have to wait for 4 months after Dynogest. 4 months after Dynogest for fertility treatment. So don't expect they will give 3-4 months of OC, 3-4 months of progesterone, 3-4 months of Dynogest, and then take her up for the infertility. Instead of that, whether you take algolics or you take any oral antagonist, it is fine, because it has immediate effect, it has designated effect, and it washes out within 48 hours. So that is where the advantage. And the biggest advantage, ART people don't mind, but laparoscopic garib aadmi log ko chinta hota hai, cost. Because the cost of depot and all and oral is, so I told the cost hardly becomes to 6,000 rupees a month. Then again oral contraceptive. As I told you very clearly, first of all, they are not that effective. Second is, why give estrogen on an estrogen dependent disease? So there is no point. Then thromboembolic phenomena and many other, so it's an off-label use. How GnRH agonists took so much time? Because they needed a molecule which was not a peptide and which was small, so it can be taken orally, which had good bioavailability, reduce the pain. This works directly at GnRH receptor level. So there is, and it is immediate. It is not that you have a flare-up like we used to give agonist or a depot. There was a little flare. So flare doesn't take place. So rapid onset, avoidance of initial estrogen flare, effective in reducing pelvic pain, dysmenorrhea, dyspareunia associated, improved quality of life, and reduce surgical intervention. This is very important, because endometriosis patients are fed up. And I always tell people, the first surgery is the best surgery. I have myself, after doing so many surgeries, I myself referred to one of my students, a very difficult case. So I told, look, two people in the world can do. Either I can do or that one can do. But I would suggest you go and do. But you should have the courage to send to some other city. Only problem with this study is, and only this is interesting for you also, not that other thing was not interesting for you, but very interesting is it included 18 to 49 years old, Shisha madam, it included patients with diagnosis of endometriosis over 10 years. So my point was, what were they doing for 10 years? Suppose if somebody had endometriosis 10 years back, you will start treatment. No? So that is one flaw which I see in study. So you can use 150 or 200 milligram twice a day for 6 months with primary endpoint of reducing dysmenorrhea, non-menstrual pelvic pain into 3 or 6 months. Secondary was dyspareunia and quality of life. Now this is Ilaris 1 and Ilaris 2. All these things now people study a lot, and I admire people from UK and many other countries because they have fixed people who don't do any clinical work. They only do publication. And they have fixed people who do statistician. We find it so difficult because we have to do ourselves, because our juniors will come in 1 year, they will become bigger expert. I have trained 2,000 people, of which 700 of them are bigger billionaire than me. And 700 of them are bigger in one branch of surgery. But that was our purpose. So they had studied with the primary endpoint 150 for milder cases, 200 twice a day, for dysmenorrhea, non-pelvic pain 3 months or 6 months, and secondary outcome was, now if you see here, you see the purple one, 46.4% reduction. In the second, you see 50%. Obviously, if we give 200 milligram twice a day, the relief is 75%. But like the depot, you have to have an add-back therapy of calcium and vitamin D. Now, whenever you have add-back, I feel you are making 30-year-old patient menopausal. So my personal advice is very simple. You start using, you can use 200 milligram, you can use, depending on severity. But then after 3 months you do our E2. If the E2 is suppressed, ART people in India are great. Everybody gets pregnancy. So you can straight away take for IUI or ART treatment. You don't have to wait for too long a time. Where you have to wait for too long a time, chronic pelvic pain. For years and years you have. That is where you can give for a longer period of time. So this is again, there is a good relief, and this is compared with placebo. No other medicine gives relief. They only suppress. But this goes and treats the inflammation, it goes and treats estrogen reduction, so it goes and treats the cause. So it treats the cause, it is very effective. As I told you, you can have Ilaris 4 and 5, which is an extended study, wherein you use it for more than 6 months. More than 6 months, as I told you, as far as infertility is concerned, we will never need it. If there is a patient who has a surgery done, after surgery, give them 6 weeks of oral antagonist and start your fertility treatment. Within 6 months, they will be pregnant, whatever fertility treatment you had planned. My favorite treatment is letrozole and FSH. I am not marketing any drug. And in IVF also, I start from the 2nd month. Because by the time you have operated, patient is fine. The most ideal immunological window you get is 7 months after surgery for conception. So before depot is given twice, 40 to 60% of our patients are already pregnant. As I told you, I was and am still the endoscopic surgeon of many ART specialists, and I used to tell, madam, I hope you don't mind, we did the surgery very complex, and 23% spontaneously they became pregnant. But believe me, all the ART, these are 2-3 females I'm talking, well, no, Prakash, we are happy. As long as they are pregnant, we are happy. So it was not like अरे वहाँ भेजेगा तो spontaneous pregnancy हो जाएगा. It was not like that. So this can be done, but only problem here is this is good for, but severe endometriosis, pelvic pain, all of you remember, don't refer to super laparoscopic endometriosis surgery. It is not needed. Unnecessarily they will do so much of peritonectomy, so much of rectal nodule. In fact, one person born, I shared with Navneet, one endoscopy born at our place. He was asked if there is a nodule and it is a painless nodule in infertility. Well, no, I'll first go and treat the nodule. That was the same person which I gave him an example. 37-year-old patient with lichen planus. That gentleman removed uterus, ovaries, lymph nodes, upper vagina. She came to me and while discussing only, I told, look, I am not God. 99% you will be fine, and maybe you are having lichen planus. With the symptoms you can make out. Then we started steroid and other treatment. Now we have other options also which he will be throwing light. She told, no, I will go and now fight with that person. So I told, look, he was God 100%. I am not God, I am 99%. If you had come to 99% first, on these medicines you would have uterus, ovaries, everything intact. And my biggest disappointment was keeping 3 centimeters of vagina. So basically that is why we have to understand the molecules. So if you see dysmenorrhea, again, ELR is 3, ELR is 4, 52, 70, same which we got. Non-menstrual pelvic pain also reduce. Bone mineral density will reduce if you go give more than 6 months. So my personal suggestion is, beyond 6 months you are giving, you start thinking whether you need it or not. So this was the result, 87%. This includes even 200 milligram with the add-back therapy. 87% were relieved. So that is a big number. Adding some calcium or adding some vitamin D is acceptable. But my point is, once you cross 3 to 6 months, you start thinking, are you again falling into the trap of danazol? Are you again falling into the trap of depot 1, depot 2, 3 months depot, 6 months depot, 11.25 depot? So I don't think so those things are needed nowadays. So post laparoscopic surgery, as I told you, give 150 milligram for 3 to 6 months. And as a simple test, you just do the E2. If the E2 is fallen down, if she is not having any complaint, you can take her up for fertility treatment. Pelvic pain, as I told you, you can give with add-back therapy. Moderate and endometriosis, I just categorize, because what happens is 48,000, once they are exposed to Inaugural by 25 company, people will write for 2 years. People will write for 1 year, 2 years without even add-back. So that is why I streamlined the indication. After laparoscopic surgery, you can give for 6 weeks to whatever time, and then start fertility treatment. Endometriosis associated pelvic pain, 6 months, extended add-back. Add-back you don't forget, because you are making menopausal. Then moderate endometriosis, like one, you don't have to give for too long. Young patient with, depending on severity, 150 or 200 milligram, and it's simple oral tablet. It doesn't cost much. Prior to IVF, as I told you, as a down regulation we were giving, you can give oral antagonists and start stimulation. Patients not keen for fertility, you can give higher dose. Patient not keen for fertility, you may consider Dynogest also. We don't have any problem if they are not keen for it. Recurrent endometriosis and allodynia, you have to give proper dose. Non-menstrual pelvic pain, again proper dose. Now coming to the last few slides, in hyperstimulation, now lots of people feel, why not give oral antagonists rather than giving a depot. So you can give oral antagonists after certain period of time. This was a beautiful study which was for donor oocyte to prevent unexpected ovulation. So they compared 75 oocyte donor and 75 historic donor, means wherein the molecule was not available. So they started in both Elagolix every night at bedtime when the follicle was 14 millimeter, whereas others were given the injectable ganirelix or whatever you give. Main outcome compared was premature ovarian, the premature ovulation rate, total oocyte, mature oocyte, estradiol, LH, progesterone. Oocyte retrieval was same in both the cases. No premature ovulation in either of the group. But what you avoided? You avoided the injections and you shifted to tablet. So both group has comparable fertilization rate. So this can be considered for use to prevent unexpected ovulation in donor oocyte. It can be used for hyperstimulation. So in conclusion, oral antagonists represent a critical advance in the management of endometriosis associated with infertility. It offers a non-invasive, effective option to alleviate the symptoms, improve quality of life, improve reproductive outcome. Added with dydrogesterone, it reduces abortion. Individualized treatment and balance with potential side effect. No flare as at depot. Dynogest is not comparable because it is not for. Then ESHRI guidelines is second line of treatment. If OC and P doesn't work, who is telling ESHRI? ESHRI told in 2022 that the only treatment of endometriosis was ovarian suppression, knowing very well that our dydrogesterone was working for 22 years. So again, I don't think so you have to take OC and progesterone as first line of treatment. Important point is, I have just booked 9E, which is that company, 9E from Mahindra & Mahindra EV vehicle. You get great vehicles from India. Why do you need a foreign stamp? So why do we need foreign guidelines? So you have to trust that whatever guidelines, we have to have guidelines. Like Navneet told, that we are going to educate. We have educated people for vaginal surgery, laparoscopy, laparoscopic suturing, urinary incontinence, urogynec, urinary incontinence tape, and you name everything, whatever you. So elagolix is a small molecule, non-peptide, novel therapy, rapid onset. Within 4 to 6 hours, it reaches the peak. Endometriosis related pain and bleeding and non-bleeding days are also effectively managed for pain. Effective treatment option for suffering from HMG for fibroid, where I don't agree. I personally feel that all this fibroid, good I came to fibroid, because in this year we are coming out with a research product wherein which if you introduce that research product into a woman, 5-6 fibroid of 5-6 centimeter will be resolved. There will be no need of surgery. And then add to that, if they want to conceive after 9 months, you remove it. After you remove, after 9 months, she can plan pregnancy. It will come in October. And the delay is only from the company side. My product is ready 3 years back. So if you chase perfection, you can catch excellence. And most important is believe in your belief. You challenge your belief till everybody understands that your belief was not just belief. It was the truth. India is the third largest now economy with so many things coming in the way. So basically you have to try and remember, we have better brains, we have better skills, we have large number of patients, huge volume, but we don't document. So thank you very much. Thank you very much for your patient hearing. Thank you, Hazra Madam. Come. No. I think so. What happens is, between you and me, good that you asked me this question. Even I don't believe in Marina. See, Marina just secretes progesterone. For many people, Marina is a jadui medicine like M2 tone. So it will correct fibroid, it will correct endometriosis, it will correct. So I am not a hard believer in adenomyoma, focal adenomyoma, 4 to 5 centimeter with pain, laparoscopic surgery. Diffuse adenomyosis, all said and done, the prognosis is bad. Fertility prognosis is still even bad. But I have done adenomyomectomy surgery in one of my sisters. Then we did a donor oocyte. Then I did cesarean. I do cesarean. My son and daughter-in-law also do cesarean. So when I removed the placenta, the anterior hole was smaller. The posterior hole was bigger because it was placenta pancreta increta. So basically you have to remember, and that's a good question, don't blanketly keep giving anything on adenomyosis. Thank you. No. See, because what happens is, the specific purpose, adenomyosis is not an estrogen dependent disease. It's not an estrogen dependent disease. Even that rectovaginal endometriosis is also thought to be adenomyosis. So their medicines will not work. So my take is very clear, it will not work. So if you have focal adenomyosis causing complaint, laparoscopic excision is the best. If you have diffuse, you will have to give, you can give this prior to IVF, 200 milligram twice a day for 2 months, 3 months, and then straight away take for IVF. Don't do anything else. Which endometriosis? No. See, I am fundamentally very clear. Again, that's a very good question. I always feel laparoscopic person, because the camera is good, they feel they have all the knowledge of endometriosis and they don't know E of endometriosis. Same way, IVF people can produce strong embryos, but that doesn't mean they know still E of endometriosis. So basically my point is, in teenagers, unmarried girl, endometriomas, avoid surgery. If the surgery is causing significant pain, then the first surgery should be done by the best surgeon, because endometriosis recurs 70 to 75%. Then infertility, one of the best study from Brussels, where Dones and that person who started ICSI. So in grade 3, grade 4, after laparoscopic surgery, immediately refer to a good IVF specialist. The pregnancy rate in grade 3, grade 4 was 64%. So you have to draw a balance. Now, how to use, for example, you are down regulating. You can start Algolix or whatever it is you can start. And once you have started, then you start the stimulation. So unexpected ovulation will not take place. Then you give HCG, then you do IUI, whatever it is. Even in IVF cycle with good AMH, you again can start with oral antagonists. So you can start on the day 5th day of the period. Then you give estrogen priming, androtas priming. Then you continue. Then you start your stimulation with respect to gonadotropin dose what you have calculated. That once you read HMG for first 6 days, then FSH for first 6 days, then you can add HMG, and then you can give your preferred trigger. So then after that, if there is hyperstimulation, you can continue oral antagonists. But in all these patients, day 5 onward, dydrogesterone 10 mg once a day, after ovulation twice a day, gives you the best result.
Thank you very much, sir, for that elaborate talk on Algolix. And since he has to catch a flight, we would like to, I would request Dr. Sirisha to present him a token of appreciation from Medsi Hospitals. Also, I would request,
so that I don't get trapped between two cosmetic talks. So I thought that preferably speak that, and then after that it is again male infertility. So thank you very much.
Thank you so much, sir. I would also request Dr. Sirisha to honor Kalyan, dietitian Kalyan, who has missed his memento earlier in the first session. We now continue with the session 2. I hand over the proceedings again to the chairpersons to invite the next speaker. Padmavati Madam.
I invite Dr. Navneet Megan onto the dais, please. As he has been introduced earlier, I invite him to start his lecture on postpartum pelvic floor rehabilitation. As we all know that childbirth causes a lot of damage to the pelvic floor and cause severe symptoms. So now we will know how to treat them by Dr. Navneet Megan.
Okay. So, now what I'm going to talk about is something which is actually closest to my heart. And I may say that I'm actually on a mission when it comes to this particular issue, what I'm going to be now talking about. You know, we are known across the world for various things, and if we say that, 2 decades back or maybe a decade and a half back, India was promoted as a poor country, we were promoted as we are living in filth, we don't know anything, and we have to see upon some white colored people who were pounced upon us as a superior race, from where all the fountain of knowledge emanates, and we drink that nectar. And today, we have totally changed. Now we tell the world that this is what we are. You want to work with us, it is on our terms and conditions. Now, very fortunately, I happened to be in Paris when the Mahakumbh was happening in India. And I was talking at a World Congress there, and I told them that, look here, the population of Paris just happens to be around 68 million. And exactly on the day when I was lecturing, a day before that, 68 million people took bath in one day in my country in a holy river. So I told them that, look here, your whole population can take bath in India in a river in one day. So please start learning from where the knowledge emanates. So, and there's something else which is very, very important. As Dr. Trivedi was telling, that in the West, there are people who just write up publications. They just make guidelines. No knowledge, no practice, no patients. They're just on the payroll of various colleges which are made there, and they just have to issue guidelines. They will see 20 patients in a year, and they will create a guideline by which they expect us to treat 20,000 patients. And we have been following that. I don't know why. So what brings importance is that if in a country in 45 odd days 667 million people can go to a one city and take bath, which is almost the population of whole of Europe, including the Great Britain, then it brings on us a greater responsibility, because this is exactly the number of women in India to whom we provide health care. So when we talk of women's health care, when we conceptualize women's health care, when we think of affordable, sustainable health care, my mind always goes towards the last woman of the last village in my country, that how will she get this health care? Coincidentally, when I was traveling yesterday, I happened to sit alongside a member of the Legislative Assembly of your state, and I was telling Dr. Sirisha, we had a very hearty talk for 2 hours. And, I told him, so he got to know that what I do. And I told him that we are doing this kind of work, and we are in talks with the Government of India for last almost 3-4 years to start a national postpartum pelvic floor rehabilitation program. So he immediately exchanged with me numbers. He also shared with me the number of the health minister of your state, who was previously working in Delhi in the party headquarters. And he said he's such a visionary that, I think we can become the first state. And he said, we will talk to the chief minister and probably we will get this program initiated in the state of Andhra Pradesh. I don't leave a single opportunity if I get to talk across someone who can make a change. Because if it comes to women's health care, this is in my heart. So this is why I say it's important that how we will make it, because, as private healthcare players, we have limitations, because the private healthcare normally comes at a cost, because someone has invested into it and you need to have return of investment. But although it is the government's responsibility to ensure that every citizen of the country must get affordable, sustainable healthcare, but we as doctors and we as someone who's been blessed by God to have a little more, than what we actually need to eat and put on our tables, we have a responsibility to contribute back to the nation, which has given us the opportunity to be what we are today. So I once again, bring greetings from Electile, which is now proudly in Visakhapatnam also. We just launched some time back, and the college where I very passionately end up creating tons of people who will end up treating millions of women in next 1 century. What I feel is the impact which we are creating is going to impact women's healthcare for at least 1 century to go. We are leading the way forward today, but we are totally grounded and rooted to our cultures, and we are proudly Indians. Now, talking about the postpartum pelvic floor rehabilitation. In my understanding, every woman who undergoes pregnancy, I'm not even talking of vaginal delivery yet, who has a pregnancy has to have a pelvic floor rehabilitation. And in this era of IVF, you may like to believe or you may not like to believe, but my friends in IVF believe that this population blast in our country is only because of their contributions. Had there been no IVF, we would have not existed. So, so in this era of IVF where progesterone is given from all orifices of the body, and I'm sure there will be very soon a progesteronic orifice also. So progesterone, we know that relaxes the ligaments. It actually is the hormone of pregnancy which prepares pelvis for childbirth. So with so much of progesterone given, 1-2 tons of progesterone given, so every woman all the more needs pelvic floor rehabilitation. Now the question would arise, why she needs pelvic floor rehabilitation? Now I will take your attention to an editorial which was written by none else than John Delancey. Now anyone who does gynecology definitely cannot understand pelvic floor without knowing this man's contribution. And he published in the American Journal more than 2 decades back that when they gave their biomechanical engineering students to create or simulate a model of vaginal birth, they said it's biomechanically impossible. But most of the mankind is born vaginally. That means that something which was impossible is happening. but it definitely then requires that some improvements have to be done, and science supports us for that. Before we get into it, let us understand the pelvic floor. Now, it is very important to understand that when we are talking of pelvic floor rehabilitation, that means that there must be some problem which must be happening in pelvic floor. And we call this, the broad terminology which comes is the pelvic floor dysfunction. Now, to understand the pelvic floor dysfunction, first let us understand the pelvic floor function and what all can become dysfunctional. Now, pelvic floor has got 4 organs. And although I am sure many of you may be knowing it, but many of you may get surprised that when I will tell that uterus is not a pelvic floor organ. Because, I keep hearing, whenever I ask people which are the pelvic floor organs, so, most of the times, uterus to zarur aata hai, because we are so fond of uterus. As gynecologists, obstetricians, 99% of us revolve our lives around uteruses. So, either we take the baby out of uterus or we take the uterus out. So, the uterus is the epicenter of gynecology. And these days we put babies also in uterus. Previously, this job was done by husbands, but these days it is done by, the doctors. So, now, but uterus is still not a pelvic floor organ, so, I have nothing to do with the uterus. I leave uterus to all my other friends. The 4 pelvic floor organs are vagina, urethra, urinary bladder, and rectum. These are the only 4 pelvic floor organs. And the best part is, all of them do not have a form automatically. They do not have any inherent shape or strength, and all of them are supported either by muscles, ligaments, or fascia, right? They're all supported by them, and that is what gives them the form. Now, form is very, very important because it is the form which gives them function. If the form is proper, the function will be proper, and dysfunction follows deformity. If any of the pelvic floor organs, all 4 of them, if any one of them loses its form, that means the support provided, because they don't have a form, so they provided support either by fascia or by ligaments or by muscles. So if any one of them would stop providing them the support, they will lose the form. And the moment they will lose the form, they will lose the function, or they will become dysfunctional. They may not totally lose the function, but they will become dysfunctional. Now, what is the role of these, supporting organs? The fascia, it strengthens and supports the organs. Ligaments actually suspend them. Ligaments are nothing but they are thickened endings normally of the fascias, and muscles are what gives them a stretching force, either apposition or opposition, but muscles is what gives them a stretching force, and normal function is dependent upon the integrity of all these things. Now, connective tissue is something which has become very, very popular these days. There are collagen drinks, collagen capsules, collagen bath, like progesterone is very dear to gynecologists for various reasons. Similarly, collagen is very dear to dermatologists for various reasons, and those reasons may go beyond science. Now, if you go to a dermatologist these days, they will definitely prescribe you collagen. Either it can be marine collagen, it can be a collagen powder, it can be collagen capsules, it can be a collagen cream, it can be a collagen lotion, it can be collagen in any form. Because we are so obsessed with collagen that we have thought that human being is nothing but a mass of collagen. That is what has started happening. Now, collagen is one of the major components of connective tissue. Besides collagen, it is elastin and proteoglycans which constitute the connective tissue, and they are critical components of the connective tissue. Now, they get affected during pregnancy, childbirth, and aging. They get affected, and since they get affected, the weakness starts in, and it results in either a pelvic organ prolapse, which is the end result, and much before that, pelvic floor dysfunction. Now, what has happened is, women healthcare has got no importance in eyes of most of the men, because unfortunately the decisions for the budgetary allocations in healthcare normally has been in the hands of men, and men don't bother about women's health. I'm being very honest, because I always say the number of women who have got urinary incontinence, if the same number of men would be leaking urine when they cough, they would have stormed the parliament that there should be some kind of national policy on incontinence. But just because the women leak, it just doesn't matter. You know, as one of the old FIGO presidents, Fatala, once said, that women are not dying because of the diseases which we cannot cure. They're dying because we do not have a will to cure those diseases, because the will doesn't exist. So when the prolapse happens, because now the uterus is hanging out, there is a problem in walking, she cannot do household work, she cannot go to the office, a man will take her for surgery, you know, to a doctor. But if she has got vaginal laxity, he may go and find a new woman. If she is leaking urine, just doesn't matter, it's fine, you know. And I get patients who have actually been abandoned because they leak urine, they smell. Old women who are not able to give, do prayers because, they cannot do prayers when they are leaking urine. The grandchildren are not coming to their rooms because it stinks, and they live a life of depression and abandonment. Now, just because it is women's health. So we all have to join our hands together, and anyone who has a role to play in women's health becomes a stakeholder, ensuring that women get the finest of health. We, as I said, we're so obsessed with collagen that we have forgotten the muscles. And because of these companies which are, pushing, these laser companies pushing sale of these lasers, this, that, they have just forgotten the muscle. But fortunately, these magnetic companies have also just risen, and they are now trying to push that sale, but not focusing on science still. And I will tell you what kind of frauds are happening in our country today. Now, before we get into the treatment, just to recapitulate the 3 levels of muscles, we have the upper, the middle, and the lower level, and the puborectalis traverses all of these. In the upper one, there is levator prolate posteriorly and the pubococcygeus anteriorly. In the middle, there is a longitudinal muscle of anus which actually does not touch the rectum at any point in its whole traversety. And the posterior anal plate and the external anal sphincter with the perineal membrane interiorly constitute the lower, the lower layer. Now, this is very important because these muscles, till the time they're functioning and working intact, they're not lax, their fibers are not broken, they're not stretched beyond, a normal thing. So they work perfectly, and if the collagen and, the elastin are intact, so everything goes perfect. But let us say the woman has lost collagen and you have built up the collagen back. But if you have not worked on the muscle, the results will not come properly. So it becomes very important that when you treat this thing, you focus not only on the connective tissue, but you also focus on the muscles. With a normal strength and tone of pelvic flow, the pelvic of the muscles, the pelvic organs are well supported, but during childbirth, with aging and with stress, if a woman has got increased stress, she ends up having a hypertonic, pelvic floor stress disorder. With all these, the pelvic floor dysfunctions start. And what are pelvic floor dysfunctions? Any dysfunction of the 4 pelvic floor organs becomes a pelvic floor dysfunction. That is why I told you when I was talking in my previous talk that vaginal laxity is at the top of pelvic floor dysfunction. Now, what has happened is people do not understand the concept, as Dr. Trivedi was very rightly saying. Every Tom, Dick and Harry in this country has started claiming themselves to be cosmetic or aesthetic gynecologists, and I'm seeing this trend happening, because it's become popular. So, Me Too is the trend that I also, and worse than just claiming themselves falsely in front of patients, they started claiming themselves falsely in front of their colleagues also, and they claim to be training people. I come across, and sometimes we also feel very sorry. We have, people who go wrong. So although we ensure that the ICCG grads are trained and the mindset is made to practice the non-deceptive cosmetic gynecology, but I had, very surprisingly, I remember that there was a group of 3 gynecologists from the state of Maharashtra who came and trained with us, And after 1 month, they had no idea, no practice, nothing. After 1 month, they started giving courses. Amazing. You know, because the problem is they feel that if it is, they feel that it is either they find it to be glorifying, or they find it a place to make money, or I don't know what they find, some kind of self-gratification in this. But I would say that these are the people who rape gynecology every day. Because, you know, even to teach only gynecology, you know, leave apart anything else. For 3 years, when you're doing residency, you're teaching your juniors. Then you become a senior resident. 3 years, you are again involved in teaching. Then you become an assistant professor, 4 years, 10 years. After that, 11th year, you get a student for the first time to teach. And here, people would come for 3 days and see the audacity. I come across people who stand up on stage, and I know their truth. They may not have done 20 patients, and they stand up on stage and they say, I have done 10,000 vaginal rejuvenations. I will tell you something. I only do this. I have abandoned all other parts of gynecology. We are currently having, you know, 9 centers across the country. I don't do anything else. Yahi karta hu main. I have not done 10,000 vaginal rejuvenations. I have no shame in telling that. I have not done 10,000. And I keep hearing this, I have done 10,000, I have done 2,000, I have done 3,000, as if thousands are tens. Or they have failed in mathematics and they have not been taught, you know, they have to go back to their primary grades and learn mathematics. The 1,000 is a different number and tens are different numbers. There is a difference of 2 zeros. But there is no, and these people, when I talk one-to-one to them, they say, no, वो बोलना पड़ता है ना stage पे जाके, ये तो impact नहीं आता है. So this is what is the problem. So please understand, vaginal laxity is not a fancy term, it's a medical problem, and that is why we are also in touch with the insurance companies. I have called a meeting of all the CEOs of insurance companies to ensure that they start including the treatment of these diseases through insurance, so that majority of women can get advantages. And you know, some of the insurance companies have already started including it, and many of my patients have got claims for non-surgical treatments back, which is very, very heartening. Because when the insurance will come into play, so more women will be able to afford this treatment and it will become more inclusive, and you know, it's our responsibility to do that. So vaginal laxity, pelvic organ prolapse, stress urinary incontinence, detrusor oversensitivity, bladder oversensitivity, voiding dysfunction, recurrent UTIs, anal incontinence, dyspareunia, perineal and pelvic vein. Broadly, again, the dysfunctions of all those 4 organs, it's very easy to remember if you remember the 4 pelvic floor organs, that any dysfunction becomes a pelvic floor dysfunction. Now, there is enough data to say that if you give them, you know, if after postpartum they have pelvic floor dysfunction, and there is enough data to prove that almost 1 in 2 women post-delivery have got pelvic floor dysfunction. And also there is enough data to say that if they do pelvic floor training, supervised pelvic floor muscle training, these problems do, you know, either decrease or they are cured. There is data. But the problem is, still 1 in 2 women have it, despite the data that if the women will do pelvic floor muscle training, they will have decrease in this. The real problem is compliance. Because all this pelvic floor muscle training, in layman's term, would become Kegel's exercises. And we have done a survey. I do not want to, you know, embarrass anyone here, but all the lady gynecologists sitting here who have become mothers, you can answer yourself, how many of you yourself did Kegels for at least 1 year after you had a childbirth? Because, you know, this is not a course of instruction, and when I sit for a course of instruction, I am on an instructional position, and there I question, and there I do a, you know, hand raise, and I have got it that not more than 2% of female gynecologists in India have done Kegels themselves. Now think of it, when we are the ones who are prescribing women, and if we don't do it, do you think women will do it? They don't do it, and all over the world this is a problem. The problem is compliance. So among this hype of EBDs, we have to remember that the muscles do exist and they have the same importance and the same role. We're just going to finish in next 5 minutes because I have come to the solution. See, the solution is very easy. You have to understand the problem statement. And if you understand the problem statement, the solutions become very easy. There are two solutions, either functional electrical stimulation or functional magnetic stimulation. The functional electrical stimulation does not work because it is like giving small electric currents in the vagina, and women do not tolerate that. If you want to be kicked by a woman, try giving that and stand as an accoucher, putting her in lithotomy, put that keglometer in her vagina and she will kick you on your face, you will remember for the rest of your life. And the other way is, a decent way is magnetic stimulation. Even there is data to prove that magnetic stimulation is much, much better. So magnetic stimulation stimulates both the central and peripheral nerve pathways in pelvis, and it is like what it causes is hyperphysiological strength stimulations. So it can it can make a woman do Kegels almost around 12 to 15,000 times in 30 minutes without feeling tired. Now that is where it is important. And the women come, they sit and they can get the treatment. Now coming to what are the devices. When we were having coffee outside, Dr. Trivedi asked me that a lot of these companies are coming and pushing me, does it really work? Yes, it works, but which devices work and which do not work, you have to be very clear. This is the baseline device, the lowest. And even this is duplicated by at least 20 companies in India. So this is a BTL Emcella. BTL is a Czech company which makes Emcella. It is a chair. It is available now for around 25 lakhs. Previously they were selling it for around 42 lakhs. And we forced them that to the ICCG grads you will have to give at a cheaper price because we do not want anything out of it, but you have to bring the prices down. In the end, now because many of the people took it, so it is 25 lakhs and this is the lowest thing. इसके नीचे सारी Chinese chairs, there are at least 30 people selling such kind of chairs, and there is a company Audacity यहाँ इंडिया में इतनी है, एक ने तो नाम भी Emcella रख रखा है. You can't do anything to them probably. I don't know why the companies don't take copyright seriously, but then this is the baseline. Now after this, the problem with this is that two things. Number one, its power is limited than the better devices. Secondly, it does not have a magnet in the back. Now if you do not have a magnetic field in the lower back, please understand that the whole pelvic nerves, they originate from the sacral area. So the nerves pass through the pelvis. So if you just have a magnet beneath the bum, and if you do not have a magnetic field around the back, the effect is always suboptimal. Yes, it gives effect. It's not that it will not give effect, but you can have much better effect with other devices. But this is the baseline, and anything below this probably is a sham and it's not going to help you. Now this is a star former. Again, here the benefit is that this has got a magnet here and a magnet here. Okay. This is much more powerful and probably the highest standard of care what you can achieve. This has got more than 30 different programs, unlike Emcella which has just got 2 programs and all these Chinese chair which just are switch on, switch off kind of thing without any science. But it has 30 different programs in which you can treat all types of incontinence separately, backache separately, erectile dysfunction separately, and so many other things which you can do. The same company, the parent company remains same, and there is another device which is Tesla former. Now Tesla former again functionally is absolutely similar like a star former, but there is just a little difference in the feel. Like you are traveling by a S-class Mercedes or you are traveling by a C-class Mercedes. That is the only difference between these two. But primarily both of them end up giving the same functional results. So it is absolutely your choice what you want to take. I do not have a bias or prejudice because we have got all 3 at our centers. So it does not make a difference to us, but anything, there is no 4th device in this country which can be useful. I can tell you that. And if you are planning to invest 25 lakhs, it makes sense to invest another 10-15 lakhs and get a better device, because every woman after pregnancy has backache. So you can have unlimited number of people who you can treat. Again, with proper training and use. Secondly, this is not a panacea. A lot of companies and lot of their purchased doctors dance around the chairs, and as Dr. Trivedi was saying, on YouTube, Instagram and Facebook, they keep putting that you sit on this chair for 6 times and incontinence will go. No, it will not go. Even if you buy it and keep it as your chair, sit on it for the rest of your life, incontinence will not go. Right? This has to be tailor-made, a treatment along with energy-based devices, and at least 12 treatments and then a follow-up. Only then it is useful. It is the best thing for pelvic floor rehabilitation. Every pregnant woman after delivery must be offered this treatment. If they have mild to moderate incontinence, if they have vaginal laxity, along with energy-based devices, if you add this, definitely this will have a much better effect. Right? So that is where it works. But please remember, if you think or if anyone tries to tell you that you buy this chair and you will be, you will be the queen of treatment of incontinence, I'm sorry, you will not be. Right? So this is the wrong marketing which the companies at times do. So we all have to remember that. Again, sex and pelvic floor have the ultimate connection. A strengthened pelvic floor improves sexual performance of men as well as women. So these treatments do improve the performance of men also, sexually, and of course they help in having a tighter vagina and better squeezing capability of a female vagina. So that is what is important. As I said, you have to focus on form, because if you will focus on form, the function will follow, because function obviously follows form, and you can also help the posture if you are doing that. We have tried to integrate reconstructive and cosmetic gynecology with mainstream gynecology, because it's very important, as women end up with gynecologists for everything, in our country. And I have been an obstetrician gynecologist. I know that if I have delivered a patient, even after 2 years, if she will have a cough and cold also, she will prefer first coming to a gynecologist, then she will go anywhere else. If she has a problem in her skin, she will come to a gynecologist and then she will go anywhere else if you are a good obstetrician to her. I always feel you can build up a lifelong relation as an obstetrician with your patients. I really miss that now since I don't practice obstetrics. But as obstetrician gynecologists, you have a capability to increase your practice in various forms if you are offering them the right treatments. You can convince all your patients antepartum itself when they're coming for ANC that they must book a postpartum pelvic floor rehabilitation with them. You are doing them a favor and doing yourself also a favor. I believe every obstetrician gynecologist must have a FMS in their clinics. We have 75,000 doctors who practice obs and gynae. There may be 40, 50,000 gynecologists, but at least 75,000 practicing obstetrician gynecologists in India, the doctors who may not have got a DGO or a MD, but they're practicing obstetrics and gynecology. So they're traditionally not trained into use of these devices, and once they get trained, sky is the limit. Once again, we're trying to bridge these gaps, and hopefully, we would be able to get things done for them. As Dr. Sirisha said, although we will not be able to get a diploma, master's or a fellowship program to this because it needs a lot of infrastructure, but because she wants that we must, bring at least some kind of training programs to here. So we will get a 1-day, certificate course, just 1-day certificate course to this center. Probably the first of it, which we will be doing in July, and Dr. Sirisha will share the dates with you. So that would be a 1-day certificate course. It will not be a complete this program because that needs huge infrastructure, and we believe that would require a different kind of thing. But yes, to think about it, to listen about it, and to know it more, to start a bit of practice, at least a bit of practice, and to get the right patients, that would help you. So thank you very much. This is what is about postpartum pelvic floor rehabilitation, and we look forward to seeing many of you, if not all, at the Recogyne in 2026. Thank you very much.
Thank you very much, sir. It was really very much enlightening about the postnatal part or pelvic floor rehab. I would request the chairpersons to honor our guest speaker with a token of appreciation. Dr. Navneet Megan. Sir.
Thank you. Thank you. Thank you.
Thank you very much, sir. Yeah, we'll continue with the next topic. And I believe the lunch is served, so we can have a working lunch as we move on with the other topics also. We won't take a break since we are running short of time. We have a lucky dip by Arco Labs. Dr. Padmavati, her golden hand is going to take out and we'll see who is the winner for 2025-26 first winner. And that is Dr. Hajra Saleh. C.H. Sailaja. Is she here? So the baton moves on to the next person. Dr. Anju Shri. Hope she's not gone for lunch. Okay, the last one now. C.H. Sandhya. Is she here for the lucky dip prize? So the prize goes to the first contender, that is Dr. C.H. Sailaja. So we have a number. And I think the ARCO people will call her and give her the prize. Thank you so much. Over to the speaker, over to the chairpersons for the next speaker.
Dr. Fahim Rajivate, he is general surgeon and urologist. His research and scientific contributions are non-obstructive agespermia and transcriptions research. Publications are editor and author of Men's Health, contributed to principles and practice of ART, global involvement and leadership, committee member ISSM Global Outreach Committee, promoting education, policy development and awareness in sexual dysfunction, active member of ISSM and SASSM. Dr. Fahim, please continue.
Thank you for the nice introduction. So until now, I guess since early noon, we have optimized the oocyte, the uterus. We even rehabilitated the pelvic floor. But with I can't make curd rice without curd and rice. So we have prepared the curd in the best possible way. Now it's the time for the rice to be selected in the best possible way so that I make that amazing dish of curd rice. So, thanks for the nice introduction, madam. So, namaskaram and very good afternoon to one and all. I know it's lunch time and you guys will be in post lunch. It's a pleasure to be here, and I like to congratulate Dr. Shrisha and on her inauguration of Med City Hospital. And thanks to my brother Dr. Ashish Reddy, who has invited me for this beautiful ceremony. Moving forward, today I will be discussing about our OPD practice regarding the other half of infertility, the male infertility topic. Okay, so it's a desk to patient job for a gynecologist. How we'll be trying to understand a male factor in infertility, and we'll be moving forward stepwise fashion, so that we'll be knowing how to treat a couple as a whole rather than not as a female 50%. I know now Dr. Ashish is there in Med City and he will be helping you throughout. But yes, definitely you will be having your own challenges at your own clinic to treat male infertility. So yes, I'm Dr. Fahim. I'm a consultant urologist and andrologist and in Bangalore. So let's discuss why correct interpretation of semen analysis is the need of the hour. You might be receiving multiple semen analysis reports, let's say 35% motility and invariably reported as less than 4% normal forms, or 4 million counts and 70% of normal forms. The equation doesn't matches. So how we have to interpret this male infertility factor? So as we know, in the current era of rampant ART, that is IVF-ICSI, a male is considered as just a vessel of sperm, to be frank and honest, and semen analysis is just number. You have sperm, we can go for an ICSI and then we can try for a pregnancy. But with so much of rampant ICSI going on, long-term complications also have started growing. Recurrent ART failures, implantation failures, poor embryo quality. So semen analysis is just not longer a point of count or number basically, but it becomes an arsenal for optimization so that our spontaneous pregnancies, IUI pregnancies or ART pregnancies are successful. That's what we are looking for right now. The main aim is baby on table as a product. Okay, so here with correct interpretation of semen analysis, we have to achieve 3 goals. We have to diagnose, number 1, sperm dysfunction. Number 2, we have to optimize sperm. How you guys have optimized oocyte and the uterus for receptivity, and quality sperm selection for ART. As we know, best sperm, best egg will give best embryos, best pregnancy, continuation of pregnancy and delivery and baby on table in hand. Okay. So before interpretation and opening the envelope of the semen analysis report, we need to see few of the prerequisites. Okay. It should be of constant duration of abstinence. The entire ejaculate should be collected in a wide mouth plastic container which should be sterile, preferably within the laboratory via masturbation. There are other non-toxic condoms also available for them, and it has to be as soon as possible submitted to the lab and stored at 20 to 27 degrees centigrade during transport. Okay, so the next step is, after knowing how the semen sample is connected, okay, I'm just running through slides. Okay, we should answer some WH questions. How we write a report writing in a Times of India newspaper, we have to answer these questions. The first is, which laboratory, which edition of WHO manual is being reported. Number 3, what is the clinical history, most important. What is the physical examination, super important. And how many samples to be taken care. The reason I'm telling how many sample is because as per WHO 6 guidelines as well, men fluctuate in their parameters of semen analysis, especially the count and total counts and concentration. So it is necessary that if a first semen analysis is abnormal, we have to repeat the second semen analysis and then come to an average point that this person or male factor is evidently having a abnormal semen analysis, which is also supported by European Association of Urology as well. After reading the semen analysis report, again you have to answer few WH questions. What investigations we need to carry forward? What is the diagnosis? What treatment plan management should happen? Because male infertility is not about only on antioxidant therapy. Antioxidants, to be very frank and honest, will work only in 20 to 30% of patients, and that mechanics is absolutely a different talk. But antioxidants are not the treatment for male infertility. It is either helped into a some certain extent to a 30% of patients with infertility. Okay, how to prognosticate, and the most important, when and who to refer. So definitely the lab should be well standardized. It should have good quality lab control. It should have trained personnels and equipped with instruments according to WHO 6th criteria of semen analysis. I'll be rushing through. So let's start interpreting the semen analysis. Whenever you open the report, you have to divide a seminal fluid into two things. The seminal plasma, which is the liquid which is protecting the sperm, which is contributed by prostate and seminal vesicle, and the second is the sperm itself. So even if it is natural pregnancies, we have to take care of the whole system, so plasma as well as sperm, to overall optimize the sperm so that the sperm reaches on the top floor of the building where the oocyte is sitting over there. Okay. Is it moving? So yes. So let's start with semen plasma abnormalities or macroscopic analysis. Only 6 things we have to see in this: volume, pH, color, pus cells, viscosity, agglutination. Okay. So after the first thing, we'll check with the volume. How much is the normal volume? Anything less than 1.4 ml according to WHO 6 is considered to be abnormal, or I will interchange with the word called as pathological. You have to check for spillage, the low abstinence period, because the sperm concentration of 0.1 ml will always be the same, but the volume from the seminal vesicle and prostate will keep on changing depending upon the frequency of ejaculation. So we have to balance that equation and then interpret the report that it is a correct report or it is a fallacy. Already with a background of clinical history and physical examination, we have to rule out any lifestyle, environmental factors, life infection, inflammation, and endocrine and hormonal abnormalities. Okay. Also, we need to check for any kind of obstruction in the ejaculatory duct, congenital abnormalities, or any iatrogenic because of previous surgeries. Functional and neurological causes of retrograde ejaculation and neurogenic involvement in terms of spinal dysfunction. And lastly, because of any medications which we have prescribed for sexual dysfunction or psychiatric medications, which might affect the sperm quality. Especially in patients who are going radiotherapy and chemotherapy. On a short sidebar, radiotherapy is worse than chemotherapy, so we need to cryofreeze the sperms. If any of the couples who are going to come to you, it's better that we freeze the sperm and then they can plan whatever plan of action they want to have for their future. Okay, the next is the color. For color, it can be red, that is the blood in the sperm. It can be because of various reasons which I have mentioned. Yellow, it can be because of jaundice, infection, urethritis, STDs, dehydration as well. And brown, it can be because of spinal cord injury. The next is pus cells, very important. Now, if we see when a lab technician or an embryologist is seeing through a microscope for of a semen sample, the round cells can be either an immature germ cells or a pus cell. We can differentiate these two with a test called as N test or orthotolidine peroxidase test, which is positive for leukocyte. And if WBCs or pus cells are positive, we need to treat it first, because if we don't treat the pus cells, the overall optimization of sperm doesn't happen. It's like the Pakistan army is already ready to kill that sperms. Okay, And based on the culture report or the site of infection, we need to treat with appropriate antibiotics based on your local resistance panel, because none of the guidelines has specifically told anything about what antibiotics to give. Okay, but according to EAU, semen culture where WBC is more than 1 million is considered to be abnormal, and chlamydia is one of the most important bacteria or the microorganism associated with subfertility. Now, why leukocyte I am stressing upon is because WBCs produce lot of reactive oxygen species. Already sperm is, as compared to the oocyte, men sperms are very weak and they don't have their own antioxidant capacity, very less, 0.6 millimeter cube. So if there is lot of reactive oxygen species, it just destroys the DNA, which is it's going to contribute to that embryo. And if the embryo is not of good quality, abortion happens and failure of ARTs and no spontaneous pregnancy. So it has to be targeted first before stepping on into the next step. Okay, the next thing is the pH. Regarding pH, okay, the normal range is 7.2 to 8. If it is acidic, we have to correlate with either fructose and volume of this and the sperm concentration, which can show that there is any dysfunction in the seminal vesicle, or may indicate prostate hypersecretion as well, because the prostatic secretions are acidic, the seminal vesicle secretions are alkaline. We need to see and target organs accordingly. It's not that we have to just see sperm and just treat it. We have to target prostate, seminal vesicle, epididymis, testes, vas deferens, along with the kidney, genitourinary tract as well, because everything goes hand in hand to get the maximum outcomes. Okay. Now, in case of physical examination where vas is not palpable, we'll get azoospermia with low volume and fructose will be low. In case of EJD, that is ejaculatory duct obstruction, we'll give low volume fructose negative sperm, and where TRUS, that is transrectal ultrasound, will show that distended seminal vesicle of more than 1.5 centimeters. In case of alkaline pH, which everyone says that it is normal, but if it is super alkaline, it is because of infection. We have to empirically treat with antibiotics for at least 21 days and then repeat it. Okay. The next is the most common abnormality which you will be finding in your semen analysis report. Abnormal liquefaction time. It's abnormal, oh, he is infertile. No, it doesn't go like that. Yes, the semen, when it is ejaculated, it forms a coagulum because of the because of the seminal vesicle, and then it liquefies because of seminal vesicle secretions. Okay, abnormal liquefaction, it prevents sperm migration and impact fertility, because these fluids, as told, it will take the sperm from the ground floor to top floor of the building in the best form to knock the door of the egg and enter. So if we are not optimizing this fluid, we might not get our pregnancies. So the liquefaction time, 30 minutes is normal, more than 30 minutes is abnormal, and it is seen in hypofertile men, and it is associated with low motility and abnormal morphology and density as well. Okay. Now, clinical importance of liquefaction time. Do not interpret liquefaction time as an isolated parameter. It should, and it doesn't suggest infertility. Okay, it should be in hand with other parameters as well, by ruling out infection, inflammation, anti-sperm antibodies, and we can step up more in terms of reactive oxygen species and DFI, that is DNA fragmentation of the sperm as well, and helps in predicting future outcomes of fertility. The next is agglutinations. These reports, few of the centers will be stressing on a lot. Okay, so I'll just clear something about agglutination, not so important. It might be present in 10% of infertile men. Non-specific is the sperm is just adhered to the cell or the debris of the shedding epididymis or the vas deferens epithelium. and this is not clinically significant. The specific ones are which are attached to anti-sperm antibodies, which most of the labs they don't do it, and if they are present, they are either done by MAR test, latex bead or immunobead assays, where less than 50% is considered to be good and more than 50% is considered to be abnormal. So you will be getting this kind of reports of various degree of agglutination in terms of isolated, moderate, large, gross, no clinical importance. Now let's jump to microscopic sperm analysis. In seminal plasma abnormality, we looked at 6 parameters. In microscopic abnormalities, we are looking at 5 parameters. That is concentration, motility, vitality, morphology, and the WHO 6th has pushed slightly intracytoplasmic droplets. Okay. Now, before heading to the next slide, I would like to tell you that in the previous WHO 5th manual, they had defined semen analysis. If the patient is having a 5th percentile value, he is infertile from 5th percentile below down. And if he is having 95th percentile value or more than 50 percentile, he is highly fertile and requires no treatment. That's the reference threshold which they have given, and they have given like kind of black and white, normal versus abnormal. Where now what WHO 6th has done, they had collected more data from different continents and they did a statistical analysis and they added the WHO 5th prior data as well. And what they did is, they started addressing less than 5th percentile, there is likely male factor infertility is high and it is pathological, okay, and he requires detailed evaluation, detailed optimization, and he is a guy who is going to go for ART, okay. The more than 50th percentile, the green one, has strong fertility. The male is having a strong fertility potential for spontaneous pregnancy. So male factor is less likely. We need to concentrate more on the other 50%. That is the female factor. The 6th guidelines edition has now taken care of the 5th to 50th percentile, which is a gray zone, which can either fall into pathological or it can go to border, the normal factor, based on what kind of optimization we are doing. So this is the one where natural conception is slightly possible. We can push to ART depending upon how we are going to get outcomes. So here in this borderline percentage, only 30% or 1/3 patient will benefit from antioxidant. You write antioxidants as a placebo, no problem. But we need results on table, right? The sperm analysis, the patient will be asking also, doc, you have given me 6 months of antioxidant, I have spent 50,000 rupees. Where is the result? So this is the place where we can give some form of results, only 1/3 of the patients. Okay. The next thing we need to see on concentration. What is concentration? It is a sperm, okay, number of sperms per ml. Natural fluctuations maximum is possible in sperm concentration because we need and it has to be balanced in terms of correlated in terms of hormonal levels, genetic disorders, infections, varicocele if it is present, and lifestyle factors. Now, according to WHO 6th, you might be getting few reports in your clinics that less than 2 million, the rest of the parameters are just vanished. According to the WHO 6th, even if it is 1 million, few sperms present, they have to report it. Okay? And concentration alone should not define infertility. There has to be taken care with the 6 factors of macroscopic and 5 factors of the microscopic parameters. Because, for example, let's say high semen volume, sperm concentration can be falsely reported as low, or if there is low volume, the sperm concentration might be reported as high, which is wrong in both the case, fallacy. Okay? So, according to the WHO 6th, the normal is more than 66 million or more than 210.
Pathological is less than 16, less than 39 million. This is the one which we have to take care a lot because they are approaching zero. Naturally, for one sperm, we require more than 210 million, and if it is going to 39 million, it means our reserve banks are going down. It's like AMH 0.1 for us. Okay, so it's a red flag sign. Immediate optimize, freeze, and take a call. Don't wait. Borderline is one where we can play around and optimize sperm, push for natural pregnancy, or push for an IUI or an ICSI or an IVF. Regarding high concentration with low motility and abnormal form, it is poor fertility. You can push for ART directly. If it is going for less than 10 million, compulsorily do all the hormonal evaluation and then optimize and then start with any procedure. The reason is, if sperms are not optimized, the DNA contributing to that embryo for anything is not good, you will have ART failures, which you might be experiencing at this point of time. So we have to optimize the sperm. If DNA is not good, mitochondrial as well as the DNA, the chromosome which are going to get contributed for that embryo, pregnancies becomes difficult, as in continuation of pregnancy or baby on table as a product. Less than 5 million, fluctuating counts, don't look at it, cryofreeze 1 or 2 samples and then go for an ICSI or an IVF. The next is the motility. For motility, we have retracted back to the WHO 4th category, where total motility, where we have divided into progressive, non-progressive and immotile. Non-progressive and immotile doesn't matter to us, because if it is not traveling up the stream, there is no point of it. But yes, progressive motility, we have rapid and slow progressive motility parameters needs to be determined. Old studies have shown is important. The recent studies have not so much supported the rapid progressive motility. Okay, so pathological is less than 42, less than 30 for progressive motility. This is a red flag sign, and then I have to make sure that I'll be optimizing this sperm or saving this sperm. The borderline one, 42 to 64 and 30 to 55, is the time where I can optimize to a higher level so that I can push for spontaneous pregnancies, which I guess most of the people here will be wanting. The next is the vitality. When is the vitality checked? It has to be done when the total motility is less than 40%. So it refers what is the percentage of live sperm present in your sample. Because more than 54% is considered to be normal, and below this threshold it means that the DNA of the sperm is dying off and the sperm is not of sufficient good quality. Okay, so also it helps to differentiate an immotile sperm which is live and immotile sperm which is dead. Okay, and it helps to differentiate it is a motility dysfunction or it is a problem in the testicular epididymis. The factory itself is defective. That's why the product which is coming out of the testes and epididymis is not of sufficient quality. Okay, so we always, as an andrologist, we treat testes as a different organ and epididymis as different organ. We don't, even if there is high DFI, we don't do PISA. PISA should never be done, because from one room, like Amazon packaging, the sperm gets transported to the epididymis, stays there for 16 days to change its motility patterns, the charges on the sperm cell surface, and in that, if there is a lot of old sperm present, or there is a microcellular dysregulation happening, whatever new sperms which are getting processed over there will be defective. The DNA starts dying off. So we have to go one step ahead and do a testicular aspiration rather than epididymal. And epididymal aspiration has more detrimental value on the next sperm retrievals which we are going to do, because that inflammatory process goes back retrogradely into the testes as well. And it will cause more inflammation, more oxidative stress, and DNA fragmentation rises. These are the three methods which we do the vitality. I'm not rushing, going through that. Yes, a special mention for hypoosmotic swelling test. We used to read in MBBS as in the gynec textbook. But yes, during your IVF, when the sperms are immotile and you don't have theophylline and your embryologist is not that confident enough that which one is an alive or a dead sperm, especially testicular sperm, where everyone says it is immortal, it is dead. No, testicular sperm 99.9% are immortal unless it is obstructive azoospermia or high DFI patients. Okay, because the packaging happens in the epididymis, not in the testes. Okay, this is the basic concept which I guess no one says. And in such cases, if we want to know which is an alive sperm, if we don't have theophylline, we can use an HOS test, and these sperms can be used for ICSI. We don't need a staining pattern. If you stain, the sperms dies. So HOS can definitely be used. The last is morphology, which is like kind of overrated, or I should say super overrated, which assess the size, shape and structure of the sperm under a microscope based on Kruger criteria, and it is reported as percentage and by two methods of Shore or Papanicolaou. Okay, abnormal morphology, definitely a handicapped man cannot run a marathon with a person who is having everything in its proper place. Basically the same thing goes for the sperm as well, and it is associated with high DFI, which affects the fertility overall. Okay, and it has to be, it is crucial but not the standalone, and it has to be interpreted with the 6+5 parameters, and we have to take a call based on the what parameters which are seen. Now if it is less than 4%, more than 4% fertile, go ahead with spontaneous pregnancies. 1 to 4% he might require optimization, and you can just go here and there. Less than 1%, don't look at it. You will not be able to push it through unless there is super hormone abnormality, and we can go ahead, optimize, freeze, ART, and you can use an advanced sperm selection as well. Morphology indices, many people labs are reporting it. I never used as an indicator. I just remember one thing, that it helps, it might help me to push through, use advanced sperm selection technique. Okay, the only thing which I will remember here is 0.6 value. If the value is 0.6 and more, go ahead with an ART because the defects are very high. Large cytoplasmic vacuoles or droplets, it helps in decision making. Still the long term data is still yet to come into the clinical picture or scenarios. Let's address the elephant in the room, oats. He is mild oats, he is moderate oats, he is severe oats. In oats, oats is to eat. Oats is not for sperms. Okay, it's not a diagnosis. Okay, the WHO 6th has specifically mentioned all the zoo will go in zoo, not for sperms. Okay, because these reference threshold values are basically meaningless. Okay, multiple criteria is required, and I have my 50% shareholder with me. Both of us will decide what is our fertility scores. Okay, the only zoospermia which is important, which Dr. Ashish will tell you, is azoospermia. Rest nothing zoo. All zoos as in goes animals. So I told you, I am quoting the WHO 6th, reference range cannot be used as distinct limit. Semen analysis alone is not a prognostication for fertility. Fertility potential of me and my partner defines my fertility scores, okay, and prognostication as well. So what they have shown is the mild oat can become borderline and pathological. This is the one which we can treat and push for natural spontaneous pregnancies. Moderate and severe oats are pathological. So we are just trying to simplify more and more sperm analysis now. Okay, I'll be rushing through. Regarding borderline decision limits versus oats, WHO 5th, which I have already mentioned, the fixed WHO 5th, as I mentioned, has fixed cutoff values. Now WHO 6th has become more compliant in terms of stratifying, risk stratifying the patients into pathological, borderline and normal, and we might not be able to push wrong patients for wrong treatment, as in borderline can be pushed towards natural spontaneous pregnancies, max to max IUI, but pathological will be targeted towards ICSI or an IVF after optimization. So it gives us a clear picture how we have to do, and rather than not seeing the numbers and taking a decision. Okay, so WHO 6th has addressed the gray zone, and we need to have personalized approach, especially for the borderline category. Okay, and we need to encourage natural conceptions in such cases of borderline semen analysis. So I'll be concluding. Our curative intent should be towards natural conception, and treatment intent should be from natural to IUI to IVF, because I don't know where the sperm will reach at the end of the optimization. We have to come to a common ground between me as a sperm and my partner's oocyte, and then come to a common ground and take a decision. And I guess this is an important thing. Before analysis of sperm parameters, we need to do a clinical history, physical examination, plasma abnormalities, 5 sperm abnormalities, hormonal profile, which Dr. Ashish will discuss, imaging, risk stratify into normal, borderline and pathological. Do your sperm optimization, assess the female factor, because I don't know, I'll be referring to you, and then decide the plan coming on a common ground of TI, OI, IUI, ICSI, IVF with advanced sperm selection technique. And that's how I'm concluding my topic today.
Thank you very much, Dr. Fahim. And now I would request Dr. Padmavati Naidu Madam, and I would also request Dr. Sitaram Raju Sir to come over and honor the guest speaker with a memento. I would request Dr. Sirisha to join in. You want to come, Ashish? Come. Yes, that's your fitness. Thank you very much. Now, our co-group would like to give away the prize to the winner of the lucky dip. Since she has already come, it's Dr. C.S. Sandhya Rani. Yes. Clap, clap, everyone. Lucky dip is only for the lucky ones. Thank you, Arko.
Thank you for all delegates. Actually, we are participating. This is a very auspicious day. Because of this, Arco Labs is the very good company and tie-up with Acuum's company. This is a multinational company. In the future, we are coming with latest molecules like cardiac diabetic and specialty also. And thank you very much. Give the opportunity for especially Dr. Sirisha Madam. Thank you very much. And once again, best regards from Arco Labs. Thank you.
I think now we have the last topic on the session 2, and I would like again hand over the proceedings to Dr. Padmavati Naidu.
Dr. S. Ashish Reddy, Consultant Microsurgical Andrologist, Director Asian Andrology Hospitals. His education qualifications are Postdoctoral Fellowship in Andrology from Rajiv Gandhi University of Health Sciences. He is a member of International Society of Sexual Medicine, member of South Asian Society of Sexual Medicine, awarded Budding Andrologist of the Country by Economic Times 2025, published, author and contributed to many chapters on male infertility. Dr. Ashish Reddy, the floor is yours.
Thank you so much for the kind words, ma'am. So, till now we heard about the normal things. Now, let us speak about the azoospermia evaluation. So, I'll be talking more clinically, which is really useful for you people. So, the basic definition, so any complete absence of spermatozoa in 2 separate centrifuge semen, we should at least have two reports, and the centrifuge should happen at 3000 Gs for at least 15 minutes, and the pellet form must be examined
for the presence of any sperms under at least 40x magnification. Now coming to evaluation of azoospermia, what you need to basically see whether this patient is azoospermic or not. First thing, let us see about semen analysis. Next, about physical examination. Here we need to consider the testicular size and is there any absence of presence or absence of vas. Next, most important thing is hormonal evaluation. Again, next coming to scrotal Doppler, here we need to see the testicular sizes and testicular volumes and blood supply. And this is also one of the important factors where genetic evaluation plays a major role. We can start with karyotyping and Y chromosome microdeletions. So there are these are the two types of azoospermias which we commonly see every day. One is non-obstructive and second one is an obstructive azoospermia. So first, how do you manage a case of azoospermia? Primarily with medical management. So most important is hormone therapy. Again, here hormone profile, you need to check for FSH and total testosterone, luteinizing hormone, estradiol, and 17-hydroxyprogesterone. This is a new modality of hormone evaluation. 17-hydroxyprogesterone deals with intertesticular testosterone. So keep it in a regular practice. Checking 17-hydroxyprogesterone will definitely help you to understand your intertesticular testosterones. And the testosterone is more than 400 nanograms per deciliter. So that means testis is already stimulated. It's very good. And if it is below 300, that is when we need to check for estradiols because you can expect a conversion. If your testosterone is again is than 300 nanograms, so FSH and LH are already high, so there is no role of hormone therapy here. FSH and LH are normal, so here where we need to start is clomiphene citrate, 25 milligrams a day for at least 3 months, and you can add HCG or HMGs to improve the counts. And again, you need to check for T to E ratio. If it is below 1:10, that is when you need to start aromatase inhibitors. I generally prefer anastrozole over letrozole because letrozole reduces E2 to a very bad level, causing severe desire loss, causing erectile dysfunction. So if you are starting, if you think E2 is higher than the testosterones, better start anastrozole than letrozole because letrozole again hits the desire very bad. Whenever you tell them for a timed intercourse, letrozole will cause major problem creating erectile dysfunction. In summary, so hormone therapy prior to sperm retrieval in non-obstructive azoospermia is like whipping a tired horse to get one last burst of speed. So we do it out of desperation to improve chances to whatever extent possible, and we can use this testosterone levels as a guide for therapy. So is there any role for hormone therapy prior to testicular sperm extractions in non-obstructive azoospermia? So this rare is a testicular non-obstructive azoospermia. Again, we can understand it's a testicular failure. So gonadotropins, FSH, are already shot up. So what will we do? How will the further stimulation help? See, this is a proper study where they have given hormone therapy before retrieval. Out of 612 men with non-obstructive, 116 underwent microdissection TC without prior hormone therapy, and 496 men received clomiphene citrate and a combination sometimes with HCG, sometimes with HMGs also. So here the target is to increase FSH at least for more than 1.5 times, and our target testosterone should be more than 600 to 800 nanograms per deciliter. So here 10.9% of hormonally treated groups achieved sperm in the ejaculate. So this is very important for any kind of azoospermia patients also. We can expect sperm ejaculation where we can see sperms at least 2 to 3 millions. Again, TC sperms retrieval was higher in the treated groups. So always better if you are planning any patients for testicular aspirations, make sure you start them on these therapies before going for the procedure. So this is one more paper where they have used HCGs before micro dissection. So here again, so this is for the failed, my first micro TCS you have done and there is a failure. So what you can do here is You can start them on HCGs 5000 international units, 3 per week subcutaneously for 3 months. So FSH suboptimal, again HCG 5000 international units for 3 per week, again additional 1 to 2 months. And please do the second micro-TC. First micro-TC is not a compulsion to get a sperm. It's always better to repeat a micro-TC after at least 3 months. So FSH is again low here. Here we can add a recombinant FSH so that the chance of retrieval will increase. So this is the second group where they underwent without hormonal therapy. And this is the outcome of that. 48 men who have failed micro-TC, 28 of them received hormone therapy and 20 of them received no treatment. So here in treated people, we could retrieve 6 people we have retrieved sperms, and untreated patients there was 0 retrieval rate. So this clearly proves if you stimulate the testes enough before the procedure, there is a high chance that we might find a sperm. So another paper here which says gonadotropins after failed micro-TC. Again repeat micro-TC, again HCG is 5000 international units, and they have added FSH here. So sperm retrieval was seen in 2 out of 21 cases. Even in the histopathological report where late maturation arrest was there and hypospermatogenesis was there, still in that kind of cases also we can definitely find a sperm. Again, now here is a case of Klinefelter syndrome where mosaic pattern, baseline testosterone, again in 68 people, with treatment again they have added oral aromatase inhibitor anastrozole, they have added to improve the testosterone levels. Again, people who have responded, you can continue aromatase inhibitors. If they are not responded, you can add them on HCGs or clomiphene and see for the response. If your patient's having a low T, definitely you can start them on clomiphene citrates or HCGs. Definitely it will improve the testosterone levels significantly. Again, here initial testosterone 300 nanograms per deciliter. The surgical sperm retrieval rate is 86%. In a Klinefelter's mosaic pattern, there is high chance that we find a sperm. In non-mosaic pattern, again, there is not a possibility, but in the mosaic pattern, we will definitely find sperms. Initial low T, again, 100 nanograms, the surgical retrieval rate was 72%. Initial low T, again, more than 158% surgical retrieval rate was there. This again role of optimizing testosterone before micro-TC. Same here, 388 men with non-obstructive azoospermia, testosterone above 300 nanograms, 348 men below 300 nanograms. So 307 people underwent hormone therapy, 41 people have not been treated. The surgical retrieval rate, initial normal versus low testosterone treated or untreated, it changes significantly. So now this is the past scenario. Before how it was, a case of azoospermia, they used to do testicular biopsy, and if there was normal spermatogenesis, they used to do a vasoepidermal anastomosis. Most of the times this vasoepidermal anastomosis was a failure. Again they went for a donor insemination. Again here when there was no spermatogenesis, they directly went for donor insemination. The management was simple, but it was really depressing. But because we could not give them their biological children, this was really depressing then. So what are the dramatic changes which took place in the management of azoospermia? This is a surgical technique, vasoepidermal anastomosis. We do with a 10-0 nylon, and it's at least 25x magnification. This is a quite tough surgery. So this will be the better surgery. You can do an intussusception technique where you can use the 4-point modification. You can do double looped, and in between you can make an incision and do a anastomosis. Then came ICSI. With this, everything changed. Any kind of obstructive azoospermia, non-obstructive azoospermia, ICSI was the go-to. And what was its impact on azoospermia? So here, what meant where the reconstruction was not possible, when they failed vasoepidermal anastomosis or vaso-anastomy, who are not willing for surgery, and in some case of testicular failure also, ICSI was the only choice. So again, testicular biopsy, there are two types of interpretation. First, no sperm in this primary testicular failure. There was sperm in the obstructive causes. Now there is a new interpretation. There is always spermatogenesis happening, some focal spermatogenesis happening inside the testis. So one single biopsy will definitely not help you. We need to do multiple things so that we can get this focal spermatogenesis from where you can extract a sperm. Again, it's azoospermia due to primary testicular failure. What was the retrieval rate? In a non-obstructive azoospermia also, in the Sertoli-only syndrome also, we can get at least 20% we can get sperm retrieval rates. And 20% of men with atrophy also. And maturation arrest, again a common fear that if a patient is having maturation arrest, there is no way that we can give a biological child, but the complete literature says otherwise. We can retrieve sperms in 40% of cases of maturation arrest. Again here, never jump into one single biopsy. We need multiple biopsy to get that focal spermatogenesis to find a sperm. Biopsies against spermatogenesis may be present in men with a testicular failure. One biopsy may not be present even if the single sperm may have found multiple biopsies. Yes. So again, what are the genetic causes of azoospermia? 15% of causes chromosomal anomalies, and 15% with Y chromosome microdeletions, and cystic fibrosis, CFTR mutation testing, and this will help again if the patient is falling into any of these criteria, we can predict the sperm retrieval rates beforehand. So again, predict risk of offspring. Again, if the patient, if your patient is CFTR gene positive, and make sure that you test the same thing for the wife, because if it is not tested, the baby will 100% get it, and it is not recommended. That is when you need to go for a donor sperm. Definitely, this should be kept in mind. So how do you manage azoospermia? This is also very important, whether the report is right. Is it cryptozoospermia? Many of the times labs doesn't recognize cryptozoospermia. Cryptozoospermia is having very few sperms in the ejaculate, and temporary azoospermia. This is a case where any kind of severe infections, severe injuries might definitely cause this problem, and pseudo-ejaculate. Most of the men doesn't know this. Not every ejaculate is semen. Some men do not reach orgasm because of erectile dysfunction or some other factors. They might not have reached orgasm. They collect the urethral secretions instead. Again, azoospermia, fructose negative, low volume. So all ejaculates should be retested again to verify whether it is sperm or it's a pseudo thing. This is a vibratory therapy which we use in people who cannot ejaculate. This will definitely help them to reach orgasm, and where we can collect the sperm. So most important, most of the lab just blatantly give fructose positive. This is very important to see whether there is an obstructive from the path from seminal vesicles coming to your ejaculatory duct. So this is a diagram where to see whether fructose is positive or negative. If there is an obstruction at the level, once it crosses the seminal vesicles towards ejaculatory ducts, the duct will change. And this is the test for the fructose. Standard Selvinov method, where 5 ml of resorcinol solution with 0.5 ml semen is added, and there is other test called modified. Here 1 ml of resorcinol solution with 0.1 ml semen is there. So again, you see fructose positive. Don't get into the check which lab has given the report. This is also very important for you. Again, absence of VAS, bilateral or unilateral. There is no confirmatory exploration. You don't need to do the surgery to see. Sometimes transrectal ultrasound can also be misleading. Biopsy is definitely not required in this case. Again, if they have already done a cryopreservation, that's well and good. Again, you need to check for cystic fibrosis in both the couples. That's mandatory. So we can do a treatment again using an IUI from epididymis first, but still there's not much of success rate. It's only 3 to 5% of pregnancy rate. So here, directly proceeding to ICSI might definitely help your patient. So 30% again doing an ICSI might have got 30 to 40% pregnancy rate. These are the commonest epididymal sperm aspirations, which we don't do now. We generally go, because doing any injury to the epididymis will cause more injury than doing it from the testis. So always prefer testicular sperm over the epididymal sperm. So here is a simple thing where how do you do with that? Again, first check for the vas difference if it is there or not there. If it is not possible, it could be a CBAVD, and if it is palpable, it could be ejaculatory duct obstruction also. So if there it is CBAVD, again ICSI. If the patient is cannot afford, you can definitely go for donor insemination. If there is an ejaculatory duct obstruction, you can check for the truss. So that will tell us is there any cystic seminal vesicle or the cystic ejaculatory duct there. So this is a picture where you can definitely see the ejaculatory duct is completely bulged up. So there is a clear-cut case of obstruction at the level of ejaculatory ducts. And this is a truss report where you can see a big black patch that will indicate the obstruction here. In these cases, you can do a simple turret surgery and we can open the ejaculatory duct and give them natural conception again. So if the patient is azoospermia and the fructose is positive, he could be hypogonadotropic hypogonadism, and it could be primary testicular failure, or it could be an obstructive azoospermia. Azoospermia, primary testicle, is there a reversible cause? Is focal spermatogenesis preserved? Is it congenital or acquired? Here again, 20 to 40% of men with non-obstructive azoospermia, where large varicoceles are there, if treated, if the surgery is done, there was some sperm after varicocele ligation. But still, it will never improve the counts as such, but it will improve the quality. When you are proceeding for an ICSI, this will be a very good step. So again, obstructive azoospermia, we need to see where is the obstruction. So here, is there any possibility of reconstructive surgery, and what is the chance of success? These can be easily identified before proceeding for any procedures. So normal FSH does not necessarily mean normal spermatogenesis. Please keep this in mind always. If the patient is having normal FSH, the surgical sperm retrieval might be sometimes 0.2. So it is not a criteria that your FSH is normal, you can proceed for a TSA. So elevated FSH, testicular failure, as we all know, but in elevated FSH also we can get the sperm retrieval rates. So is there any role of inhibin? This is the most emerging criteria where inhibin is also, there is a very good paper on this, telling inhibin levels increased, normal inhibin levels might be telling you about normal spermatogenesis, and it could also be a good marker for you before proceeding for any kind of things. Again, biopsy generally we don't prefer, if you're doing a biopsy in an open center where we don't have an embryologist there, it is useless because you are causing more harm than taking please, if you are doing a biopsy, make sure you do it in an IVF center. Subject to condition, if you find a sperm, immediately we can freeze that sperms. Again, see, this is one of the important things where here the histopath report showed few degenerated sperms up to spermatozoa with few. Here we should never jump into conclusions. Here the problem here was the sample was mishandled. If you compress the seminiferous tubules before sending it to pathologist, this kind of reports are common. So any kind of histopathology reports, don't jump into any kind of conclusions, because most of the times all the histopathology reports are generally wrong. So is there any role of vasography? This is again age-old technique before going for surgery. If we do a repairs, vasovasal anastomosis or vasoepidermal anastomosis, to see the exact place of obstruction, we use a vasography. So where we indicate this is, patient had a previous history of hernia or any kind of pelvic surgeries, and the semen volume is really low, that is below 1 ml, and fructose is negative with a palpable vas. Here, see, obstructive case, you can see the epidermis, it is completely bulged up. In a primary testicular failure, it is absolutely normal. And this equivocal is still jumping from this into primary testicular failure. So this is also you need to keep in mind. Again, what we generally do with an obstructive azoospermia. So direct, you can start with a VEA or VVA, and no prior vasography. You can just check the vas patency. Again, we can discuss the options where we found primary testicular failure where there was no chance of getting a sperm. That is when we might ask for a donor insemination. Again, so when do you consider it to be obstructive? At least we need 3 to 4 biopsies. At least 1 to pathologist, rest to IVF. 1 to pathologist just to make sure everything is okay. And if it is normal, you can proceed with VEA. Or if it is primary testicular failure, micro TCs are a definite chance. In summary, again, confirm proper ejaculation. If cryptozoospermia also, there might be some labs who might tell it could be an azoospermia. Check for the fructose and properly tested fructose and FSH and physical examination. Testicular biopsies, again, at the embryologist. Again, you can counsel about the reconstructive surgery and or the ultimate option of assisted reproductive therapy with an ICSI or genetic studies. So management of azoospermia is complex, challenging, but absolutely rewarding. Giving their biological child makes everyone happy here. Every man wants his own biological child, and we at Asian Andrology, we strive to give them that. Thank you so much.
Thank you, Dr. Ashish Reddy, for the elaboration on azoospermia. It was very extensive.
Hello. Thank you very much, Dr. Ashish Reddy. I would like Dr. Padmavati Naidu Madam to felicitate the guest speaker, Dr. Ashish Reddy, with a. I also would request Dr. YLN Narsingh Rao sir to join in for the felicitation. I also request Dr. Padmaja Madam to come on to the dais and request Dr. Padmavati Naidu Madam to felicitate Dr. Padmaja also. Since we are running short of time and we have another program at Medicity Hospital also, I would request all the speakers to be brief in the next session. So coming to the last session of today, which comprises of the following topics: endometriosis and fertility by Dr. Padmaja, evaluation and advanced treatment options of erectile dysfunction, PRP, the magic option by Dr. GVK Jyotirmayi, the future of fat loss beyond diet and gym, exploring endoscopic balloons, cool sculpting and emerging innovations by Dr. Ramesh Baipalli, genital aesthetics, role of a plastic surgeon by Dr. M. Srinivas. And to chair this session, I would request Dr. D. Rekha to come and occupy the chair on the dais. She is an MBBS and MS from RNT Medical College, Udaipur. She was a topper in final MBBS and gold medalist in surgery and gynecology. She is presently consultant, Seven Hills Hospital, Visakhapatnam, and she was South Zone Coordinator for Food and Drug Committee of FOXY, Joint Secretary, Obstetrics and Gynecological Society of Visakhapatnam,
2021. She was the organizing joint secretary, Yuva Foxy, South Zone 2020. Member, Food, Drug and Medical Equipment Committee of Foxy 2021. And Member Guidelines Committee of Foxy on Personal Hygiene in Pregnancy in 2016. She has presented several papers in several conferences and participated in national conferences. I welcome you, Madam. Next. I'm so sorry. I would like Dr. Padmaja to honor our chairperson, Dr. Padmavati Naidu, with a memento. Request Dr. Rekha to join in. I apologize for this, Dr. Padmavati Naidu, as the time was ticking too fast. Actually, Dr. Padmavati Naidu, I have written a very nice quote for you as you are taking the chair of the President, that leadership is the capacity to translate vision into reality. And you have done this. Congratulations. I also request Dr. Madhuri, S. Madhuri, consultant gynecologist and fertility specialist at Medsi Hospital and IVF Center, Visakhapatnam, and Vizag IVF Center, Vijayanagaram branch, to chair the session. Join Dr. Rekha with this session 3. I hand over the proceedings of this session to the chairpersons.
Good afternoon. Dr. Padmaja V. She's an MBBS and MD from AIMS, Delhi. She has several awards to her credit. Dr. G.N. Mathur Prize, Dr. Rama Memorial Gold Medal, Silver Medal in FCGP exam, Prize in Free Paper Presentation at APCOG Kurnool, and she has received Foxy Dhira Prize, Times Icon of Healthcare 2023, Foxy UNICEF Appreciation Award for work in cervical cancer and HPV vaccination. She has held several positions of prestige. She is the president of Vijayawada Menopausal Society, patron of AP FS 2024 to 2026, advisory board member and financial committee member of Vijayawada Obstetrics Society, member of Endometriosis Committee Foxy, member HIV and AIDS Committee Foxy, executive council member IMA Vijayawada.
Thank you, madam.
You have lots more, but
no problem,
is...
madam. Let them enjoy the talk. We'll spend time there. For all of you, those who don't know me, I'm Dr. Padmaja Veermachineni. You might know my cousin as Veermachineni died, so you would have understood we are all talkers. In the morning you heard a very good talk by Dr. Prakash.
లక్ష్మీ మహాసరస్వతి త్రిశక్తి స్వరూపిణి అయినటువంటి భువనేశ్వరి దేవి యొక్క ఆరాధన పీఠంలో ప్రతి మండలం చేసినట్టుగా అధివాస పూజా కార్యక్రమం ఏ మండలం కూడా చేయడం జరుగుతుంది. ఈ రోజున ప్రాతకాలం నుండి కూడా ఉదయం నుంచి కూడా భక్తులందరూ కూడా అధిక సంఖ్యలో భక్తులందరూ కూడా విచ్చేసి ఈ యొక్క కార్యక్రమంలో ప్రతి ఒక్కరు కూడా పాల్గొని అమ్మవారి అనుగ్రహం పొందారు. చాలా విపరీతంగా అధిక సంఖ్యలో వాళ్ళ భక్తులు రావడం జరిగింది. పంచామృతాభిషేకాలు ఇవన్నీ కూడా పూర్తయ్యాయి. అలాగే హోమం కార్యక్రమం ఇవన్నీ కూడా పూర్తయిపోయాయి. ప్రదోష కాలంలో జరిగేటువంటి పూజా కార్యక్రమం ఒకటే మిగిలి ఉన్నది. ఈ రోజున మారేడుపత్రి
deciding to have a baby. So by the time they decide that, almost 50% are having infertility. So what does it matter to us? It matters to every single one of you because there are 4.2 crore women in India, and it is impossible for fertility experts to look after them. So it is the primary responsibility of all gynecologists to be aware about endometriosis. So what am I going to talk? I'm going to talk a little about the pathogenesis, infertility, and I'll give you a brief take-home message. Why does it occur? It basically, I feel any organ system is designed to work perfectly. The heart is designed to beat, the brain is designed to think. It is just that we are handing over our brains to the cell phones and not thinking, so they are undergoing atrophy. Like that, our reproductive system is supposed to give babies, and women are supposed to breastfeed their babies. It is because that function is not being done to the extent it was done that we are having an increasing rise in endometriosis. So how do we explain endometriosis? All of you know endometriosis means there is glands and stroma, endometrial tissue outside the uterine cavity where it should not be. So endometrium is supposed to be in the uterus. So when it is not in the uterus, it is anywhere else, you call it endometriosis. So how did it get out from the uterus? Uterus has 3 pathways. A pathway out, which is the menstruation, that is normal. It has 2 tubal openings. So when the uterus squeezes, there is always some amount of reflux in the blood that comes into the peritoneal cavity. But when that endometrial tissue is given environment in which it can flourish, where the immune system is not capable of clearing it up totally, where we have an altered genetics and the implantation potential of that tissue is high, that's where endometriosis comes. So we have various theories, you know, the retrograde menstruation, and we believe that if there is an abnormal peritoneal environment, even the coelomic cells that are resting around will turn into endometrial tissue, because there is always an adaptability of tissues. That is how stem cells from the bone marrow go and repair injury occurring so many places. So if there is a peritoneal inflammation, there is peritoneal injury occurring, so the stem cells get modified and stick there. Unfortunately, the program goes wrong and they turn into endometriosis. We have theory of hematogenous and lymphatic spread, which explains endometriosis in the pleural cavity, in the eye and every other location. And there is a lot of study going on in epigenetics that say why this tissue is behaving so abnormally. So remember, the genetics of every cell is the same. We all start as a single cell organism. There is a half the genetic material in the sperm, half in the oocyte. Total, it is a life. So all cells in our body have the same genetic material. But whichever place that cell is there, depending upon its location, depending upon its friends, if it is in the hair, it turns into a hair cell. It will not be expressing the genes that are necessary, the function of a heart. So like that. So this, how does this happen? It is because of the expression of genes. You have a textbook, you don't need to read all chapters. You can skip the preface, you can skip the chapter of endometriosis. So what you read, it depends upon what you understand. So like that, when the abnormal epigenetics is there, the genes that are not supposed to be expressed are expressed, the genes that are supposed to be expressed are not, and that's how endometriosis occurs. And invariably everything has an element of genetics, because if a woman has endometriosis, her siblings and her daughters will have a 6 times higher chance of having endometriosis compared to a person in a family who does not have. So let's walk through with a couple of us. She is 28 years, walked in telling that they've been planning for 2 years. She has regular menstrual cycles, occasional heavy menstrual period. They were using rhythm contraception, a little on the overweight side, and the husband is also on the overweight side. So nothing really significant. They just walked in for a consultation, and as soon as I did a scan, this is what I found. So you can see that she was absolutely asymptomatic. And what you can see, typically, there is a thick wall, uniform ground glass appearance with occasional hypoechoic specks, and with a very poor plane of cleavage between the uterus and the ovaries, and you can see some amount of normal ovarian function. So in a scan, when you're doing a scan, your scan starts by talking to the woman and telling her that as I'm putting in the probe, please tell me if anything hurts. Your scan starts at the vulva, and as you gently insert, what should be happening is you should be seeing the submucosal hypoechoic line of the rectum falling away, of the urethra falling away, the organ systems giving way, and you moving gently closer towards the cervix. At the cervix, you can see echogenic free fluid if you are doing a scan on the day 2-3. That is what is a reflux of the endometrium. Then you can see the moment you move down, if she winces, you know that it can be a uterosacral thickening. So as you're moving, if at any point it hurts, there can be a rectovaginal nodule. You look at the cervix, you look at the direction of the uterine cavity of the cervix. You have a hockey stick appearance of the endometrial cavity, you have a uterus that is bending down, you have a poor plane of cleavage between the uterus and the ovaries. You see that they don't move as you exert a little pressure, and you know you have an endometriosis. You don't need anything else to diagnose. So doing your own scan well, gently, systematically will help you diagnose endometriosis in almost 90% of cases. Okay, so as I said, so when you are reporting on your ultrasound, you need to write everything. Write on what is the probe you are using, what is the day of the period you are doing, what are the volumes that are there, how do you think the endometrial echo texture is, do you see anything in the uterine pathology, how do you look at the cervix, what do you look at the size, what are you seeing the follicles, what are you having, and what is the accessibility of the ovaries, what is the mobility, and do they have probe tenderness, do you think there are any bowel adhesions. So this much information you should be having, and is there a splitting sign, are there kissing ovaries, and draw visual picture if you, because not everything can be on the pictures that you're giving you have. So if you draw it, it becomes very clear. Whoever is reading your report should understand what you have seen. So the first thing they'll ask is, why me? I never had any problem. The thing is that, as I was telling you, each one of us is made in a different way. So our ability to metabolize depends upon the enzymes that we have. So if we have a perfectly functioning 17-beta hydroxysteroid dehydrogenase 2, the estradiol, which is the most active form of estrogen, after it does its work, is converted into estrone, which is a weaker form. But in endometriosis, there is an abnormal expression of both the aromatase and this 17-beta hydroxysteroid dehydrogenase. So aromatase makes sure that there is a lot of estrogen, and deficiency of dehydrogenase makes sure that the estrogen stays in its active form of estradiol for a much longer time, and normally body has a beautiful balance. We have estrone in the menopausal, estradiol which is necessary for during the reproductive phase, estriol that is present by the placenta. So but here when we have an abnormal level of estrogen, and not only that, with the presence of progesterone resistance because of the gene polymorphism that is there, the yeast normally as soon as progesterone comes, it inhibits the estrogen. That is what each one is supposed to do their work and get away. So estrogen is supposed to express the progesterone receptor, and the estrogen level is supposed to come down, and the progesterone is supposed to lead to a secretory change. But when this progesterone does not do the work it has to, the estrogen levels are much higher. So all high estrogen will lead to increased prostaglandin synthesis. Prostaglandin is what expresses all the peritoneal fluid inflammatory markers, and that leads to neoangiogenesis, inflammation, proliferation. Whenever there are blood vessels growing, there is nerve coming along with that. There is neoangiogenesis, there is abnormal phagocytosis, and all this is what lands up women in endometriosis. But then they will ask, you say endometriosis, what we've seen on the YouTube and Google, doctor, is that endometriosis hurts? It never hurt me. Pain is very variable. That is because the peritoneal fluid, what are the macrophages and neutrophils that are coming, how much iron is there, how much reactive oxidative species is there, how much acidosis is there, what are the cytokines coming, chemokines coming, and what is the neuronal inflammation that is happening is what is going to decide how much pain sensitivity is going to be there. But for a woman who has pain, the pain is going to be unrelenting because it is a recurring condition, and every month there is an avalanche of all these molecules coming and irritating someone who is already injured. So when a thing is a repeated one, like I've been talking about reproductive physiology so long, so if I'm suddenly woken in sleep, I will tell ovulation, estrogen, progesterone, resistance, that's what I will be talking. So nerves also, the same thing happens. So when they are constantly stimulated, they lay a pathway that is like a highway. So they know, you start here, you end up there. No tolls, no obstruction. So the touch sensation will also end up causing stimulation of the brain because of the sensitization, and everything hurts. So that is the suffering that people with endometriosis happen. So classically it was told that laparoscopy was needed to diagnose endometriosis, because how can you just say every woman with pain has? But the problem with that statement was that no one wants to put in a laparoscope to give bad news. So everyone will hesitate to do a laparoscopy. So the time from the time a client complains to diagnosis of endometriosis was almost 9 years to 11 years. So it took us 11 years and continuous suffering, and by then that pain sensitization would already have occurred. If we are able to stop the cycle in the early phase, that lifelong suffering of the woman will not be there. So it is the responsibility of every single person to be endometriosis aware. So as I was saying, idea consensus. So you look at the uterus adnexa, you look at the soft markers, you see the POD, you look for deep infiltrating, look at every organ system that is there. Don't miss out the entire pelvis. So you need to look at everything. And now we have beautiful classification systems, which if we try to keep marking, we will be seeing everything. So in this, as I said, and as everyone, even Dr. Prakash has said, that if a surgery is necessary for endometriosis, it should be done in a center with full equipment, with an experienced surgeon, and that should be the only surgery of her lifetime. If we are going to repeat surgeries, that means we are not doing a good job. And so in laparoscopy, we need to look at all the things that we saw on an ultrasound, and it's a good thing under anesthesia also to put in a speculum and palpate, because we will be feeling other small nodules also. And in the small peritoneal nodules will not be seen on laparoscopy. Endometriomas we can, deep infiltrating we can pick up. So when we are looking at do we need to do a surgery, basically it depends upon the symptoms, the age, what the woman prefers, whether any previous surgery was done, whether there are any other fertility factors including the ovarian reserve and the male factor. So for this lady we went ahead and did a laparoscopy. You see it was a pretty, not so bad, but it must have been one of these early things where you just had an endometriotic cyst. Here
Hello.
we did...
Excuse me, madam.
Yes.
Sorry to interrupt you. There's an emergency, AP39EA0143 I-10 is in the way, and there is a traffic jam over there. So whosoever is the owner of this vehicle, please kindly go and see. Thank you, madam. Sorry for the interruption. Yeah, Dr. G.V.N. Rao has lost his car keys. So if anyone finds it, you can take it home, and along with Dr. G.V.N. Rao, you can take him also along.
So in this, she had patent tubes and a cystectomy was done. It is most important to document your findings. How well you document your ultrasound, please document your findings on the American Fertility Society, and also go for the endometriotic fertility index, where it says how well do you think this tube will function? Good, very bad. How much do you think this ovary will function? Good, very bad. So if everything is very bad, then you can automatically tell, I don't think any of these will do the job they're supposed to do, go for ART. If you think they will work very well, then you say, take some time to have a pregnancy. So, as I said, if we were to treat all the minimum endometriosis, we would need to treat 25 cases to get one extra pregnancy. So don't imagine that when we cauterize the minimum endometriosis, they're going to become pregnant on their own. So, as we said, here they've come for a fertility. So you inhibit ovulation, how on earth are they going to become pregnant? So ovarian suppression should never ever be done. And so rather than expected treatment, going in for a gonadotrophin IUI will give a higher pregnancy rate. So we did IUI, we did IUI, it did not work out. Then she asked, why now it doesn't work out? You've taken out the endometriotic cyst. We need to remember that the endometriotic implants sends a lot of all these chemokines in the ovary. There are all these abnormalities that are going on, and all these factors are going to be released into the tube. So, and the implantation is also going to be affected. So when there is active endometriosis, pregnancy rates are comparatively higher. So therefore, whenever there is a severe disease, whenever the age is high, whenever there is a male factor, it is better to go in for an IVF program. And in this, any protocol will do. So she had an antag cycle, she conceived in the very first cycle. And in pregnancy also, we need to remember that because there is a progesterone resistance, there is abnormal decidualization, so pregnancies are more fragile. So in women with endometriosis, they need extra luteal phase support. And fertility preservation is something we really need to talk about because we are diagnosing endometriosis in a lot of unmarried people. And if possible, freeze embryos, if not at least the ovarian tissue. So can we prevent it? Primary prevention is not possible, but what is necessary is to educate all the schoolgirls, mothers, family groups that what amount of dysmenorrhea is acceptable. If the dysmenorrhea is severe enough, getting aggravated, for her to be absent in school, having GI side effects, get investigated. And now we have beautiful drugs where we can use continuous progesterone even up to 7 years to keep the fertility preserved and prevent aggravation. So in conclusion, in the perspective of fertility, if a surgery is needed, use the best surgical technique and avoid unnecessary surgeries. Don't be very aggressive in trying to pull out everything, all the small cysts, cauterize everything, buzz everything. And get an ovarian reserve before and after. In a lifestyle, avoid childhood obesity and caffeine, smoking, alcohol, because these are also increasing in our population. In endometriosis is infertility. Age less than 35 years, no other fertility factors, with a good reserve, but with unbearable pain, do a surgery. If there is no pain, go for active management. Get her on gonadotrophin IUI cycle, she will conceive within 3 months if she has the ability to conceive on her own. If not, early referral for an IVF. If there are tubal factors, if there are surgeries, if there is meiosis, low reserve, we need to go in for an ART program. And I take this opportunity to say that Andhra, all of us, we are the hosts of the South Zone ISAR conference that is happening in Vijayawada in August. So all people who are interested, you'll be having wonderful sessions. We have everyone coming down to teach us. We don't have to rush around to Ishre and things like that to learn. We have people coming down. And whoever is interested in taking part, please let Dr. Sirisha Rani know. I'm sure we will accommodate you, and let's all do a good job and show the rest of the country how good Andhra people can present us. Thank you. Thank you very much.
What is the role of Marina in endometriosis?
Yeah. The thing about intrauterine device Mirena is that it releases very low progesterone and makes the endometrium atrophic inside the endometrial cavity. So in women who are having severe dysmenorrhea and heavy menstrual bleeding, with nothing else, it might help. And if you, because an ovarian endometrioma is not going to be suppressed by Mirena. Mirena is going to be there, but you're going to need something else to suppress it there. But if the primary problem is dysmenorrhea, heavy menstrual bleeding because of endometriosis, nothing else is the problem, then it will work. Only thing you have to tell them is when there is heavy menstrual bleeding and there is adenomyosis and endometriosis are sisters, so there will be an element. If there is a tramp, the spontaneous displacement of the intrauterine device is comparatively higher. For people like this girl who complete their family, putting in a Mirena is a very good option. So once they finish their family, tell them aggressively. They have to, because endometriosis in 70% is going to recur within 2 years. It is something you have to plan their entire lifetime till menopause and beyond, because there is increased association of malignancies. So annual checkups is what is absolutely essential. Yeah, you see in that, because diet lifestyles definitely help. Exercise, yoga definitely helps. Okay, they have dysmenorrhea, but the problem is most of them are going to school in the morning at 7 o'clock and coming at 10 o'clock and sitting in the bed. So their body endorphins and all are not there, because naturally also there will be so many pain things going to our brain, but because of the endorphins that are there in our body, it is able to suppress that pain. So look for it, and if you have a strong suspicion that she could be having endometriosis, then you can make her anovulatory by giving her 3 cycles OCs, give 5 days pill-free interval, let her have a scanty period and continue. You can use that for a year and see. Or you can use them on continuous dynogest. Because if it is because of endometriosis, a 6 months course of dynogest should give her 70% relief.
6 months continuous?
Yeah, continuous. There's no point, because how do you think it will change? Endometriosis is for life. So that's why we need to get them to do it. Not really. I'm a more conservative person, because if you're thinking of oocyte cryopreservation in an adolescent, even with endometriosis, you don't know for how long you have to cryopreserve those oocytes. And those oocytes you have to stimulate and get them out. So you're going to give her gonadotrophins, and you're going to do an oocyte pickup, which is done transvaginally. And in endometriosis, where you're thinking the iron is one of the molecules that makes the highest amount of reactive oxidative species. So all around that inflammation, they already have a potential for low reserve. So you're going to do multiple stimulations, and you need, practically speaking, you need at least 15 to 20 oocytes to have a 75% chance of a live birth later on in life. So you will need to do 3. And suppose you're doing it for a 16-year-old girl. When is she going to get married? Is her partner going to be okay with a frozen egg program? Is she going to come back and utilize it? So in the oocyte cryopreservation programs that have been around, the utilization rate is 5 to 7%. That means that many number of people come back. And this is not a cheap procedure. And here the consent of the parent should be there. So all this you need to do. So on a theoretical basis, it's a good option, but on a practical basis, it's how good it is. You need to really think about it.
Thank you very much, Dr. Padmaja, for the very elaborative talk, and the interaction with the audience was really very good. Thank you once again.
Now I welcome Dr. Jyotimai JGVK. She is a consultant obstetrician and gynecologist and laparoscopic surgeon, reconstructive and cosmetic gynecologist at Medsi Hospitals, Vizag. She is trained in minimally invasive surgery under Dr. Manjula Anugani, and she pursued diploma in cosmetic gynecology from ICCG under Dr. Navneet Meghon. She cleared her MICCC exam, and she is a member of Indian Menopause Society and an executive committee member of Vijayawada MS Society. Over to you, ma'am.
Thank you very much, ma'am. Okay. I know it is very sleepy and hyperglycemic session, and we are running really very late, so I will try my level best to keep my presentation very crisp, very brief, as much as possible. Okay, and I am sure that I will not bore you, at least. Okay. So so what is PRP? I know everyone here knows what is PRP, right? Platelet rich plasma. We use it day in, day out, and when I say we, most of the dermatologists and orthopedicians, they are using this since almost 30 years, I can say. So what is this PRP? So PRP is nothing but an autologous plasma preparation enriched with increased concentration of platelets when compared to the whole blood. Okay. So what concentration of platelets in that plasma must be there to call it a platelet rich? So when we come to the working definition, so see, the ideal concentration is not known till now, but if 1 ml contains 1 million of platelets, then we call it as platelet rich plasma. Okay. Even if the concentration is more, we might not get this. Even if the concentration is more, we don't get an additive effect. So minimum we need is 1 million per ml, and it can be put in other way that the minimum of 5-fold than the normal platelet count. If it is there, then yes, it is platelet rich plasma. Okay. So why are we behind this PRP? Why? Because of its n number of because it contains n number of growth factors, plasma proteins. Growth factors like cytokines, lysosomes, they initiate the hemostatic cascade, and they help to create new connective tissue, revascularization, and there are n number of plasma proteins, for example fibrinogen, prothrombin, fibronectin, which will kickstart the healing process if there is a chronic illness, or in case of acute illness, they will accelerate the process. So this is why we give PRP. But the biology of PRP is little complex, but the outcomes depend on the intrinsic, versatile, and adaptive characteristics of the patient blood when they come to the microenvironment. Okay. And the classification of PRP, there are many classifications of PRP. One is DEPA classification, depending on the concentration of PRP, and this classification, we as a gynecologist, we prefer, see, it is relatively very easy, so we prefer to use it. So it is pure PRP, leukocyte PRP, PRP is platelet rich, and pure platelet rich fibrin and leukocyte and platelet rich fibrin. We use PPRP in gynecology. So how do we prepare? Preparation of PRP is not a rocket science. Anyone can prepare. So these are the things we need. We hardly need we need a syringe, an alcohol swab, a lignocaine, 2 sterile tubes, and 2 vacutainers with ACDA, and a pipette and insulin syringes. That's it. This is the tray that you need for to make a PRP. So this is the machine we use for PRP. We use Remy centrifuge, and those are the slots for the vacutainers. And the preparation of PRP, there are 4 steps, very easy. Collect the patient's blood, separate the PRP, processing the separated autologous platelets, and inject into the patient. So these are the steps. So first we do the venipuncture, collect the blood into the 4 tubes, and then we keep the tube for a spin. So the tubes will get the first spin. So in the first spin, we will keep it around 2500 RPM for 15 minutes, and then we can get the RBCs which are collected down there, and the second layer is a buffy coat, and the third layer is plasma. So with the help of a pipette that we have seen in the kit, so we will take it really very slow, and then transfer into the sterile tubes that you can see sterile tubes, and then these sterile tubes will go into the second spin. So when they go into the second spin, you will get the platelet pellets settling down, and the first 2/3 it is platelet poor, and the remaining 1/3, the last 1/3, we use it for the treatment. So in the last, you can see the ready to use 5 ml of PRP over there. This is that easy. Why do we call it a magic potion then? See, nowadays PRP is really creating a buzz, definitely not in dermatologists or definitely not in orthopedicians, but in gynecology, yes, we are calling it as a magic potion. And some say as a golden liquid maybe. Some people actually say that. So why do we call it? Because of its huge potential to revolutionize the management of various gynecological conditions. And now here we discuss some of the widely promising and practically applicable aspects of gynecological manifestations which can be treated with PRP. So here are the proven cases where we can use PRP. There are many other conditions, but these 4 conditions we can say yes, they are evidence based, they are proven, we are doing day in day out, and patients are really very happy. So the first and foremost thing is female sexual dysfunction, vaginal dryness, lichen sclerosis, and vaginal atrophy. PRP in sexual dysfunction. Yes, this slide will create a really very create enthusiasm. That is Kama Sutra shot, O shot, G shot. Yes, whenever you hear about these shots, what is this shot? अरे इसमें क्या डालते हैं यार? इंदुलो ఏం చేస్తారు? ఎందుకు అందరూ G shot, G shot, G shot, G shot? There is nothing special or nothing to hide in it. It is just PRP that we inject into the vaginal mucosa. But yes, there are specific sites where we have to inject, how much we have to inject, and how we have to inject. Okay, so these shots are Kama Sutra shot, O shot, or G shot. O shot and G shot, they are trademarked, but Kama Sutra shot. We do in our center, we do Kama Sutra shot. So after these shots, what will the patient feel? So they have improved aerosol, stronger orgasm, decreased dyspareunia, and increased natural lubrication. Usually, females with sexual dysfunction, they don't come to you as such. When a patient comes to you after maybe after a normal delivery, you will examine her with some other cause. Maybe you will examine her. You will see a lax vagina. You will ask her, do you really have that? Do you feel sex really that interesting after childbirth? I can bet you on this, 90% of them say, no ma'am. Or you can ask their husbands, so how is your intimate life? Most of the people, they say, not in the first encounter, not in the second encounter, but yes, in third or fourth encounters, female will come to you with this. No female will come to you that madam, I'm not, my orgasm is not proper, my intimate life is not proper. No female will come to you like this, but any gynecologist, after all I can say, all gynecologists, go back, question your patients. Out of 10, 8 to 7 patients will have this orgasmic dysfunctions. So in these patients, the mainstay of treatment is these Kama Sutra shots. And especially in our center, like most of the patients, they get it done before Valentine's Day, or they get it done before their marriage days, etc. And the next is PRP in lichen sclerosis. Lichen sclerosis is a very debilitating disease in that there is a lot of scarring, there is epidermal flattening, hyperkeratinization, etc. So after when we use PRP along with lasers, then the outcomes are really very good. I am not telling PRP is the only treatment, but PRP when used as an adjuvant with laser, as you have seen in the morning session, jet plasma. So the energy device that we are using is jet plasma. So when we are giving it along with jet plasma plus PRP therapies, yes, the patients are having really very promising results. And the third and foremost thing is vaginal atrophy and dryness. Vaginal atrophy is very common in peri and postmenopausal ladies. Symptoms are vaginal dryness, pruritus or irritation, loss of subcutaneous fat, sparse pubic hair, dyspareunia. So how do we treat them usually? Whenever a menopausal lady comes, we give a estrogen cream or estrogens, right, mainly. But do you think they really help? Yes, they do. They do, but if you give it for, let's say, 100 patients, maybe 20 or 30 will have very, very good results, but rest of the people, they don't even like to come back again. Elina kuda malli same. So they get fed up sometimes. So in that cases, when you try PRP in them, yes, let me tell you, it gives a very, very positive result. So PRP therapies will help in vaginal dryness by increasing blood flow, collagen production in the vaginal tissue. This can help to regenerate and rejuvenate the tissue, leading to increased lubrication and reduction in discomfort. The growth factors in plasma can also stimulate the production of new cells, which can further improve the vaginal health. So what are the other gynecological causes? So thin endometrium, premature ovarian failure, genitourinary syndrome of menopause and vaginal rejuvenation. There are many pilot studies in this, but yes, many RCTs are going on. So yes, but still we do use these things now in our practice. So endometrium is really very necessary to get a good pregnancy, right? So if they have a thin endometrium, so they don't have a positive pregnancy rate. In such cases, if we give PRP as an intrauterine infusion, then it will improve the endometrial growth and increase the clinical rates of pregnancy. PRP will also increase the receptivity of endometrium. In case of thin endometrium, it restores the structure of endometrium, and the PRP's role in Asherman syndrome is really very phenomenal, and it has emerged as a golden ray of hope in these patients. And what about poor ovarian reserve or premature ovarian failure? So autologous intra-ovarian PRP therapies, it has increased the anti-Mullerian hormone levels and decreased FSH concentration with a trend towards increasing clinical and live birth rates. So PRPs in ovaries, it will improve the microenvironment of the ovaries along with the provision of the growth factors that we have already seen. There are n number of growth factors in plasma in PRP. So it will improve the microenvironment, and the intra-ovarian calcium gluconate activated PRP, when we give this to our patients, after 2 months, 78% have improved ovarian function. Sorry. Conditions where PRP is promising is the autologous transplantation of ovaries, or in case of torsion-related ischemia or oxidative stress-induced injury, because in these conditions the VEGF helps. And the recurrent vesicovaginal fistulas, all the genitourinary syndromes, not only recurrent vesicovaginal fistulas, it acts as a supportive treatment. The PRP acts as a supportive treatment, not the mainstay of treatment. After the treatment, when you do a surgery, after the treatment you give PRP. When they come back, you can't even notice where is the scar. So it heals really, really very well. And after PRP treatment, if you give PRP after that, so no further urinary difficulties are found in those patients. And stress urinary incontinence, PRP contains several growth factors, as we have already seen, help in reconstruction of damaged ligaments, that is pubocervical ligaments, which will help in stress urinary incontinence, and painful bladder syndrome or interstitial cystitis. PRP has a potential to act as a modulator for urothelial repair, so it is used in painful bladder syndrome. Intravesical PRP reduces the chronic inflammation in bladder pain or interstitial cystitis, as they could improve the regeneration of urothelium. Let me tell you about one of my clients. She is 48-year-old. She almost, I can say, she has visited all the possible urologists here, and she has recurrent this dysuria and itching in her itching near the urethra. Okay. So she attained menopause 3 years ago. She used all the possible medications, and now she came to us almost in like, okay, I have tried everything. Okay, I'll try this also. So we have given her 2 PRP sessions till now. She, I can tell you, like, she is very happy. 50 to 60% reduction is there in her symptoms. She is yet to come for 2 more follow-ups for PRP sessions. So this is how like PRP really it does wonders. And PRP in vaginal rejuvenation, after PRP as an adjuvant to the laser, when we use laser and PRP together, then it will have a very, very good results in vaginal rejuvenation. So vaginal vascularity is increased, and subsequent there is dramatic increase in the sensitivity. In addition, the skin becomes thicker and firmer, making vagina look more youthful, and moreover the ligaments and muscles supporting the urethra become stronger, which will alleviate the urinary incontinence symptoms, if any, if she has. So these are some of the research articles showing the effectiveness of PRP in endometriosis also. And yeah, conclusion, after a careful review of various research works, PRP is published in various internationally recognized scientific platforms. Various valuable insights have been obtained. It has potential to bring a great revolution in the department of gynecology, and wide spectrum of its usage has made various gynecological issues such as thin endometrium, recurrent genital fistulas, ovarian abnormalities, Asherman syndromes, urinary incontinence, etc. So no doubt more research would aid discovering in hidden potentials of PRP in gynecology. Thank you very much. Please do visit our El Sante at Medsi hospitals, which is going to get like inaugurated maybe in half an hour to 45 minutes. Thank you so much.
Thank you for the interesting session, ma'am.
Hello. Yeah, due to paucity of time, we would like to give mementos to 2 of us speakers of this session. I would request Dr. D. Radha and Dr. Madhuri to honor these 2 speakers with a memento. Sorry, Rekha. जब से तुम्हें देखा. Come. You can join in. The 2 speakers in the center. Thank you very much. I again hand over the proceedings of this session, further proceedings to the chairpersons.
So the next speaker for this session is Dr. S. Ashish Reddy. He is well known to the audience, and he has given expert talk just an hour or so earlier, which was very elaborative about azoospermia. I welcome you once again.
Thank you so much.
He is a postdoctoral fellow in andrology from Rajiv Gandhi University of Health Sciences, fellowship in andrology from the University of Miami, Miller School of Medicine, member of International Society of Sexual Medicine, member South Asian Society of Sexual Medicine, and he's been awarded the budding andrologist of the country by Economic Times 2025. Published author and contributed many chapters on male infertility. I welcome you, Dr. Ashish Reddy, to render your talk.
So, this is evaluation and treatment options for erectile dysfunction. These are the cases which you see on a regular basis in your day-to-day practice, where most of the men have this problem, but they don't open up with you, but they tend to come to us for the same problem. So basic definitions, it's just an inability to achieve an erection, or they couldn't do a vaginal penetrative activity. So most of the times it is associated with distress.
So what are the criteria for the ED? First, most important, before any diagnosis of erectile dysfunction is made, these things must be kept in mind. Is there any partner factor here? That means partner sexual problems or health issues. Relationship factors, again, is there any communication issues between them? Again, the differing levels of desire or partners, violence. Individual vulnerability factors like history of sexual or emotional abuse. Any abuse in the childhood might trigger again this problem here. And some conditions we see religious factors here and medical factors, existing medical conditions like diabetes. So what is the incidence? So the incidence is, it is common after age 50, but in our day-to-day practice, we see 20 years guys also coming to our office with this problem. So this is an old saying that it is more common after age 50, but the scenario, the dynamics have changed. We could see erectile dysfunction in 20 years guys also. So this is the general story of a man where when he is in age 20 to 30, he does once in the morning and once in the night. Once he crosses age 31 to 40, so he puts off the morning thing and only does at night. Once his age 41 to 50, it is now and then and whenever it is able. And once it crosses 51 to 60, he does it God knows when. And once he's 61 to 70, if he says he's still capable, he must be definitely out of his mind. So this is a common thing which we see every day. And the basic simple causes of erectile dysfunction: cardiovascular disease, diabetes, medicines, surgery, neurological disease, endocrinopathies, psychological factors and unknown causes. So again, is there any problem with oxidative stress, endothelial injury? This is the link of ED and cardiovascular disease. Hypogonadism, diabetes, everything causes oxidative stress, that which causes endothelial cell injury. So always you need to keep in mind your patients with cardiovascular problems might end up in erectile dysfunction. So what are the risk factors of ED? So most important, age, yes, chronic diseases, heart disease, hypertension, diabetes, peripheral vascular disease, smoking, yes, smoking will definitely cause erectile dysfunction. Alcohol use, obesity, lack of physical activity, depression, elevated lipid profile. Most important, psychogenic ED. Here again, most of the young guys might be having the psychogenic ED where there will be performance anxiety, relationship problems, intimacy problems, depression, guilt of failing, psychological trauma, previous sexual abuse. This all will contribute to psychogenic erectile dysfunction. So this is a common thing which we see in a day-to-day practice. It's vasculogenic ED where atherosclerosis, hypertension and trauma might definitely cause vasculogenic problems. Neurogenic, as you all know, stroke might cause this problem, spinal cord injuries, radical pelvic surgeries, diabetic neuropathies and pelvic injuries, and like radical post prostate complete clearance. Hormonal case of hypogonadism or hyperprolactinemia, if the normal prolactin levels should be below 15, anything above 15 or generally we consider double the normal times, we consider it as hyperprolactinemia. So if your patient is having around 20-25 prolactin, you can still wait and watch. Don't start them on cabergolins at the earliest. We can still wait and watch till it doubles. So is there any drug-induced changes? Yes, antihypertensives, antidepressants. Here again, young chaps with any depression history, the psychiatrist or their physician might have started them on antidepressant drugs. That might also cause erectile dysfunction. Anti-androgens, alcohol abuse, cigarette smoking. Yes, there are lots of literature, lots of studies which says smoking will cause erectile dysfunction. So how do you diagnose and evaluate? So most important is the proper history. What is their original problem and proper examination. If the penis is normal in size, is there any phimosis, how is the phallus, and basic investigations. Most of the times this is a major problem for any kind of erectile dysfunction, marital problems. So basic history, again, is there any medical history, surgical history? You need to evaluate these things before you do. And these are the normal things which we need to see. Again here just to see hypogonadic, just see the testicular size and consistency and secondary sexual characters. and general examination of the penis, we can understand if there is any Peyronie's block. So these are the investigations. If any patients come to you with erectile dysfunction, so serum testosterone. See, testosterone again, generally we check for free testosterone and 17-hydroxyprogesterone, because 17-hydroxyprogesterone will give more knowledge about intertesticular testosterone. So here again prolactin to see whether his desire is okay or not. Again, basic things is HbA1c, his lipid profile and thyroid functions. So this again is an advanced test where we do a penile Doppler study to see whether if there is any vascular insufficiency. Most of the cases men have vascular insufficiency. Here we measure the peak systolic velocities and end diastolic velocities. If the peak systolic velocities are more than 30, that means it's normal. If it is anything below 30, but the expert opinion says the peak systolic velocities inside the penis when erected should be above 40. So this, how do you treat erectile dysfunction? So general measures, psychosexual therapy, drug therapy, vacuum devices and surgical. We are going to get into each one of it. Again, algorithm. First line, lifestyle changes. It will change the hormones. Second line, oral medications. Third, penile injections and vacuum devices. Fourth is penile implants, vascular surgeries and low intensity shock wave therapies. Basically, you can tell them to stop smoking, tell them to reduce their weight, alcohol, exercise. So what are the nutritional supplements which might improve their erection status? There are only few papers on most. L-arginine and L-citrulline are only established data. Rest everything is hit and run. So there are some papers on ginkgo biloba and ginseng. Rest everything is, again, you can try those. But L-arginine and citrulline has established papers. So psychosexual therapy, again, we need to evaluate properly. Is there any performance anxiety, or is there any sensate focus exercise, relationship counseling? These are all basic things. And coming to the drugs for ED, best line is phosphodiesterase 5, PDE5 inhibitors. Yohimbine, yes, now it's an older drug, but we are still using it. It helps in psychogenic ED. Intracavernosal, alprostadil and papaverine, which is very common. Intraurethral, again I'll show you. So these are the commonest PDE5 inhibitors which we use in day-to-day practice. First came Viagra, which revolutionized erectile dysfunction of any patient. Before we used to think it's everything psychogenic. After the proper research, Viagra was an amazing drug which changed the complete perception of erectile dysfunction. So any patient who comes to you, you can start on 25, 50 or 100. 100 is still okay dose, there is nothing to worry. Some people might have headaches, other than that there is no much of contraindications to not use. And if you ask us, tadalafil will be best choice. And anytime when you tell your patients for timed intercourse, make sure you start them on tadalafil 5 mg, so that men won't have this erection problem during that intercourse. Because lots of patients, whenever I take the history, they might be telling my gynec has told to try on today, but they couldn't achieve the erection. So that cases, you can definitely start. If the patient is cardiac patient, I even start PDE5 inhibitors in post bypass, post stenting. So don't even think it will not affect. The patient will be very happy. These are the two drugs of choice. You can start either sildenafil or tadalafil. Sildenafil, some people might have headaches. Tadalafil is absolutely safe. These are the newer drugs which have come. In India, we only have avanafil now. Some people while taking tadalafil, they might have myalgia. For those patients, the avanafil will be the next drug of choice. The other three drugs are not yet in India. So general side effects: facial flushing, headache, nasal congestion, dizziness, dyspepsia, visual disturbances, priapism. Priapism, unless and until patient takes 5 to 6 doses on a single day, he might go into that. Again, contraindications: recent cardiac event. Other than that, no problem. You can start for anyone. These are the basic things. Again, for sickle cell disease, here it is a contraindicated, and multiple myelomas and leukemias, it is contraindicated. So, when will your PDE5 inhibitors fail? It is only when it is improperly used, the proper timing, dose or lack of sexual. Again, most of the people have this in mind: we take PDE5 inhibitors, I should get proper erection. No, it should be post stimulation only. erection doesn't happen spontaneously. It will take time, needs proper stimulation, proper desire factor. So, and most second again, inadequate patient education. So, unidentified hypogonadism, anxiety of performance, comorbidities, again, non-responders, patient education. I'll be going fast. So, testosterone, when should we start testosterone? See, testosterone replacement should only be done if the patient is not planning for pregnancy. If you see a patient where the testosterone levels are low, please don't ever give them testosterone replacement therapy, because that will affect the hypogonadal HPG axis, causing azoospermia. So, if you start doing testosterone replacement therapy, make sure there is no pregnancy planned in next 5 years. That is when you can give them testosterone replacement therapy. So, and again, intracavernosal injections, not much in India, but very common in foreign countries. Alprostadil, again prostaglandins. We very commonly see this might be coming into the country where piperacillin, phentolamine, and one aviptadil, and this could be the new one. This is an intraurethral alprostadil. In India, men are not that educated to use this. This will really help them. This is also still evolving. Vacuum devices, not much in India, but definitely helps in erections. This is again new things which we see on every day. External penile process, that means men use other things, penile sleeves onto the penis and they are having intercourse. Again, there is not much of studies on this, but these are there in the market. So now coming to the advanced management of erectile dysfunction, is there any role of stem cell therapy or platelet regenerative therapy? We tried on a couple of patients. We have taken the mesenchymal stem cells from the pelvis. We grown them in the market. We grown them in the lab, and then we gave it back in the penis. But there was not much of change. And this is the best therapy which we are seeing today is low intensity shockwave therapy. Low intensity shockwave therapy. Here we are giving the pulsations into this. So this will cause implosions inside. It will release nitric oxide, again vasodilatation, helps in vascular endothelial growth factors. This is how, very simply, without any medications, patients with any kind of erectile dysfunction will have an excellent outcome. Any kind of shockwave therapy will definitely do. I'll show you the protocol. This is how we do it. We take multiple sessions. In each, we divide the penis into 6 zones. In each zone, we give them 300 shots, and overall around complete 3000 shots. Depends on each. Mild ED, we give them 8 sessions. Moderate ED, 10 sessions. Severe ED, we might go for 12 sessions. Yes, this definitely worked. We have so much of data which has established data which says shockwave therapy for erectile dysfunction will definitely work. So coming to my expertise, surgical management, there are different types of penile process. This is a small slide on the evolution. How did it start? What are the commonest things? So there are again 3 types of implants which we everyday market. One is rigid, semi-rigid, and inflatable. These are the 3 commonest things which you need to keep in mind. And this is a very commonly used implant. This is called Shaw's penile prosthesis, where it has soft distal tip and soft zone that can hinge. See, we put this in any patient who is having erectile dysfunction. If it is psychogenic also, if they are married, they are not able to consummate their marriage also, we will directly proceed for penile implants without any hesitation. And you can there are multiple penile implants which are there here. So these are the commonest. These ones are very commonly used. Semi-rigid. I use Promedon. It's an Argentina company. It will works very well in the patients. This is one of the oldest and the best penile implant which was there. It's called 2-piece implant. Here the cylinders, the pump is in the daughter's pouch in the scrotum, where a patient, whenever he wants erection, he can press that pump there and patient will get erection. If he doesn't want, he can just press that bulb there and erection goes down. And there is no timeline for this. Once the men can have sex without timeline stoppage, because once the ejaculation happens also, erection doesn't go down. this is the one now, it has been modified. They have modified 2-piece into 3-piece, where they have put an reservoir here where the fluid will be kept, and we put the reservoir in the pelvic space, and with that patient can have a proper erection. This is the most advanced implant in the world, and these are very, very commonly used. I have done more than last year alone, I have done 104 surgeries. That common, we don't even hear about this because again word of mouth is not there in penile implants. So this again how it works, the 3-piece implant. Whenever we press the pump here, the fluid from the reservoir comes into the cylinders here and causing erection. Whenever the sexual intercourse is completed, they can press that pump back again, the erection will go down. Again, this is different things. So what are the approaches which we use for surgeries? The penoscrotal, infrapubic and subcoronal. See, most of the andrologists prefer penoscrotal because it is simple. We do an incision between the penis and the mid scrotum, and we open the cylinders, we dilate it and put the implant there. So it's a simple procedure and very efficient. So now what is the take home message from here? Lifestyle changes, curable cause for ED is found, the cause must be treated, inadequate prescription. Penile implant is a final line of therapy, but it's one of the best therapies. Shockwave therapy, yes, you can definitely tell any of your patients, you can definitely proceed to that. If you don't ask your patient may be too embarrassed to tell you. Thank you so much.
Thank you very much, Dr. Ashish Reddy.
I was fast.
Yes. You were fast, but you were very clear and concise.
Thank you so much.
Thank you.
So just in between the session again, I am coming in. I am barging in every time. Because Dr. Padmaja wants to leave, I would request Dr. Padmaja to come over and honor our chairpersons with mementos. Dr. Rekha and Dr. Madhuri. Dr. Ashish Reddy, you can join in. Thank you very much. We again continue with this session. We have 2 more topics to go, and hopefully we'll be doing it as fast as possible.
Dr. Baipalli Ramesh sir, he's a surgical gastroenterologist, bariatric surgeon, bariatric endoscopist, robotics and laparoscopic surgeon. He is a leading and eminent surgical gastroenterologist in Visakhapatnam, renowned for his expertise in advanced laparoscopic and bariatric procedures. He had obtained his MBBS from Andhra Medical College and MS from Guntur Medical College in 2006. He did his surgical gastroenterology training in Sri Venkateshwara Institute of Medical Sciences, Tirupati. He was awarded the postdoctoral certificate course from SWIMS, and he holds a membership in ICS, International College of Surgeons, and he's a member of the International College of Surgeons and the Association of Surgeons of India, and he is a member of the Advanced Laparoscopy Association and also a member of Indian Association of Gastroendosurgery, and he holds a fellowship in the Minimal Access Surgeons at JIPMA, Pondicherry. Over to you, sir.
I request everyone to sign the register so that you get the APMC credit points and credit hours. And somebody has given me this key. It's a car keys. So whoever is the owner of this key can come and take the keys from here, otherwise you have to take the car from me.
Respected Chair, my dear seniors, friends, colleagues, I know this is the post-lunch session and pre-leaving session. Thank you, first of all, organizers for organizing this much very grand session, and thank you audience also for staying for this much time for my lecture. Thank you. I am here not to give some lecture on cardio or calories. It is something beyond that. I hope that most of you are gynecologists. You might have completed a decade-long practice. I want to start with a question. Have you ever come across someone who reduced their weight with diet and exercise, and after some time did they bounce back? Or somebody is trying to reduce their weight with diet and exercise but unable to do so? Then you are not alone. Globally, there are more than 1 billion people who are struggling to reduce their weight in spite of their countless diets, workouts, and willingness to decrease. So today, I want to challenge a long-held belief that for weight loss, diet and exercise are enough. They are actually not. As we age, body tries to resist weight loss by various factors. Those are deeply biological, hormonal, psychological, and even neurological. But here is the good news. We are entering into a new era of fresh tools, which are technology, endoscopy, new generation bariatric surgery, and good medications, etc. In next 15 to 20 minutes, I will take you on a journey into the future weight loss tools. I will explore cutting-edge endoscopic techniques, new generation bariatric surgery, nutrigenomics, smart body contouring technology, and next generation bariatric surgery. Coming to obesity definition, according to WHO, excessive accumulation of fat in the body which impacts our health. BMI greater than 30 is commonly considered as obese. BMI is greater than 40 is considered as a morbid obese. Coming to prevalence, globally more than 1 billion people are suffering from obesity. In our India, more than 8 crore people are suffering from obesity. Out of these, 24% are females and roughly 23% are male. A small revelation. See, in developed countries like America or Europe, poor people are obese, but in India, rich people are obese. Do rich are buying obesity? Hope so. Coming to economic burden on our healthcare system, there is a huge economic burden on our healthcare system. Roughly, it is calculated as $28.3 billion in 2019 itself. Can anybody guess what is our Andhra Pradesh state budget this year? Anybody guess? Any wild guess? It's $3.2 lakh. Obesity burden is $2.8 lakh. That is 73% of Andhra Pradesh state budget. You can understand how burdened that it is. So, why diet and exercise are not alone? There are different theories in this. See, when we start reducing weight with the diet alone, what happens, resting metabolic rate decreases. Once resting metabolic rate decreases, body tries to burn less fat. It tries to preserve the fat. This is nothing but starvation response. So weight loss becomes even more harder. Coming to hormonal shifts, see, leptin is satiety hormone and ghrelin is a hunger hormone. Once we try to reduce our weight by dieting, what happens, hunger hormone increases, ghrelin increases, leptin decreases. So this increased hunger will makes us even harder to maintain diet for longer time. Muscle mass. See, after 35 or 40 years, every year 1% of muscle loss occurs. This is age-related change. This is nothing but sarcopenia. So when muscle mass decreases, metabolism decreases. Metabolism decreases, weight loss becomes even harder. So muscle mass is directly proportionate to metabolism. So higher muscle, higher metabolism, more efficient in managing the weight. So a lot of YouTube videos and everything, after you cross 40, you don't go gym, just you do pranayama, yoga, extra. But very important thing is, once the person crosses 40, they have to hit the gym. Very important thing. Muscle must be built up. It is very, very important thing. Next, gut microbiome shifts. See, gut microbiome means intestinal flora, bacteria, viruses. Some of these things will stay in our intestine. These gut microbiome shifts causes changes in metabolism and changes in inflammation. See, this inflammation causes even weight loss becomes even more harder. So what to do? There are a lot of innovative, newer modalities of weight loss other than diet and exercise. I think everybody might have played with these balloons since childhood, right? But these balloons are incorporated in the medical technology. Our cardiologists use balloons, urologists use balloons, medical gastroenterologists use balloons. Now, these balloons in our bellies. This is nothing but intragastric balloon for obesity. So, these balloons are made up of silicon. Usually, stomach contains 1 to 1.5 liters of the capacity. These balloons will occupy some of the space in our stomach, roughly 40 to 50%. So, it will cause filling effect. So, patient will not take more diet. So, obviously, calorie deficit occurs, weight loss occurs. See, it is a very simple procedure. It hardly takes 10 minutes. It's a OP procedure. There is no hospitalization is required. Patient can be discharged on that day. But it is a balloon. Coming to limitations, patient balloon retention rate is less. 60% of people will ask their doctor to remove their balloon in 3 weeks itself. Coming to weight loss, hardly 5 to 10 kgs will be lost in 3 months. It is not that much cost effective in India especially. There are 3 kinds of balloons. One is single balloon system and double balloon system, adjustable balloon system, and even swallowable balloon system. See, the swallowable balloon system is like a tablet. If we take tablet, it will go into the stomach and it will become a ball-like thing. It will occupy our stomach space. Next, another landmark innovation in endoscopic bariatric procedures is ESG, that is endoscopic sleeve gastroplasty. Before discussing this, let me speak about laparoscopic sleeve gastrectomy, LSG. This is a commonly known bariatric surgery. The most performed bariatric surgery in this world since 30 years is laparoscopic sleeve gastrectomy, LSG, what we simply call. But crores of obese people might have benefited by this LSG. But it is a surgery. It needs anesthesia. It needs hospitalization. We have to cut the stomach and we have to remove part of the stomach. Recovery, it takes minimum 5 to 6 days. Patient can't eat food in next 48 hours. But LSG will give minimum 30 to 40% of weight loss. So, all benefits of this LSG is delivered without surgery. These benefits are delivered without hospitalization. If these benefits are delivered without cutting the stomach and removing part of stomach, is it welcomeable, right? That is nothing but ESG. That is nothing but endoscopic sleeve gastroplasty. In this procedure with double channel endoscope, we will make stomach as a sleeve with opposing anterior and posterior walls of the stomach. Here the weight loss will be roughly 20 to 30%. We will use the instruments like Apollo Power Stick. This is the landmark innovation in this ESG. So I am playing a small video how this is done. Video play. Okay, fine. So what are the other options available? Since centuries, human mankind is in search of weight loss pills. There are many proven weight loss pills. You can read it there, you can see it. But I will speak about two molecules, semaglutide and tirzepatide. Coming to semaglutide, this is incretin mimetic, GLP-1 agonist. It acts by reducing appetite and delaying gastric emptying. So whenever appetite decreases, gastric emptying is delayed. By mere seeing of the food, patient is allergic to food. It works more on brain. So weight loss obviously decreases. Any side effects of this? No side effects. Is good for heart and CKD patients also happily they can take it. But nausea, vomiting, retching will be there. Sometimes rarely pancreatitis may occur. How much weight that may decrease from this semaglutide? Roughly 3 to 10 kgs in 2 to 3 months of the course. So next one is tirzepatide. This is recently introduced in the Indian market. This is dual agonist, GLP-1 and GAP and GLP-1 agonist. It's a weekly injectable form. I don't have much experience with this because it's recently introduced. For whom these medications are needed? Those people who needs bariatric surgery but they are not prepared for bariatric surgery. Those are good candidates for these medications. Okay, fine. We have lost weight with medications, bariatric surgery or endoscopic sleeve gastroplasty, but there are some stubborn pockets of the fat which might be hanging around the body, which are very awkward to see. Then the role of these body contouring mechanisms comes. These are cryptolipolysis and ultrasound cavitation. Coming to cryolipolysis. Cryolipolysis is a freezing of the fat. See, fat cells are more sensitive to cold than muscle, skin and nerves. Whenever fat cells are exposed to the cold, targeted controlled cooling at -5 to 10 degrees centigrade, fat cell apoptosis occurs. These dead cells are cleared by our lymphatic system. It takes minimum 8 to 12 weeks. So this is very ideal for those stubborn fat areas like love handles, lower abdomen, thighs, underarms and neck. Another innovation is ultrasound cavitation. Simply it shakes the fat cells with sound waves. Whenever low frequency ultrasound wave is exposed to the targeted fat area, microbubbles will occur in between the fat cells. This is nothing but cavitation, ultrasound cavitation. These bubbles will enlarge and collapse and disrupt the fat cells. So fatty acids will come intracellularly to extracellularly. These fatty acids are cleared by our lymphatic system. These ultrasound cavitation, these multiple sessions are needed. So radiofrequency ablation. After weight loss, skin sagging also occurs. This radiofrequency application will cause collagen stimulation and it will cause skin tightening. Coming to nutrigenomics. It's not another diet plan. It is a genetically guided diet plan. See, it's a science that studies how our DNA interacts with food. Suppose some people will take coffee at night 10 p.m. and they will sleep like a baby. But some people, even though they take a sip of coffee at 2 o'clock, they will have continuous palpitations and dyspepsia throughout their night. This is just because of the gene, CYP1A2 gene. This gene metabolizes caffeine. And all of us thrive well on the milk in our neonate days up to our childhood. But right now we are not, because of lactose dehydrogenase enzyme. This is regulated by LCT gene. So this LCT gene decides whether dairy, milk products is our friend or foe. There are other 3 genes which are very important in causing obesity. Those are FTO gene, that is a fat gene, APOAT gene, fat sensitivity gene, and MTHFR gene. If we screen these genes in early childhood, we can prevent future obesity. We can plan DNA based diet according to that, and we can prevent future obesity. As all you are gynecologists, you know, a minimum fat loss, a minimum weight loss improves ovulation, fertility, and it reduces gestational diabetes, preeclampsia, and improves postpartum recovery. So here the protocol what we follow in our center, Dr. Shapex. See, if the BMI is 27 to 32.5, first we will make a subject to medications and DNA based diet. Next, we will contour his body with body shaping devices like cool sculpting. If the BMI is more than 32.5 and below 40, we will kickstart weight loss with medications. We will target roughly 6 to 10 kgs. After that, we will subject him for bariatric surgery or endoscopic sleeve gastroplasty. Those people who are not really ready for bariatric surgery, best one is endoscopic sleeve gastroplasty. Then after shedding a few calories, kilograms, then we will contour the body with the ultrasound cavitation or cool sculpting. If the BMI is greater than 40, first before surgery, 10 kgs of weight loss should be there with the medication. Then bariatric surgery, then body contouring. So fat is not a just waste organ. This is an active endocrine organ. So treat it like one. There are newer futuristic modalities there in the research. Due to shortage of time, I am not going deep into it. So fat loss no longer one size fits all. It's tailored to personally. So diet and gym are definitely essential, but not always enough. We have safe, effective, and non-surgical tools like ESG, endoscopic sleeve gastroplasty. So traditionally there are diet and gym, everybody knows. From granny to side hustle, everybody knows that gym and diet are essential. But for them they can't reduce their weight with both two, till now bariatric surgery is the option. So bariatric surgery is the surgery. There is a huge gap in between. I hope this gap is bridged by ESG, that is endoscopic sleeve gastroplasty. Thank you one and all.
Thank you, sir. Thank you for the enlightening session.
With this, we come to the last topic of the day, and it is also a very interesting topic to be delivered by Dr. M. Srinivas Rao. Dr. M. Srinivas Rao is a founder and consultant plastic surgeon of Dr. Jaya's Exalt Aesthetic Clinic. He specialized in hair transplantation, breast surgeries, rhinoplasties, liposuction, tummy tuck, genital aesthetics, aesthetic surgeries, and aesthetic medicine. He is Assistant Professor at KGH, Diploma in American Academy of Aesthetic Medicine. He is a member of Association of Hair Restoration Surgeons, member of Association of Hair Restoration Surgeons India, member Association of Breast Surgeons, and member of Indian Association of Aesthetic Plastic Surgeons. I welcome you, Dr. M. Srinivas Rao, to give your deliberation.
Thank you, Chair, for introducing me. Hello. Good evening, everyone. Thank you for the warm welcome. Hi, Dr. M. Srinivas Rao, plastic surgeon specializing in aesthetic procedures. And today I will be discussing a topic that intersects our field. So, this is definitely a evolving field of genital aesthetics, and it has gained significant attention in the recent years, and it is most probably a multi-modality approach involving a plastic surgeon, gynecologist, and a psychologist or a psychiatrist to achieve the best possible outcomes with the comprehensive care. So going back to the fundamentals, so differentiating between an aesthetic procedure and a reconstructive procedure. So reconstructive procedures are meant for restoring the form or function which are lost either due to trauma, resections, or any congenital deformities. So, but aesthetic procedures, they are designed to improve your existing beauty. So that's how it is defined as to improve the or enhance the existing beauty of the part or the person. For example, if you take a face, a hair transplant or a facelift or a simple dimple creation can enhance the beauty of the person. Same breast implants or breast reduction or liposuction, and even it comes to genitalia, the genital aesthetics, they play a crucial role. So here the difference is, for aesthetics we call them as a client. Now we don't call them as a patient. And if you want to become beautiful, as Dr. Navneet already mentioned, you need to pay 18% GST along with the surgeon fee. So we'll call them as a client, not as a patient. So how come a plastic surgeon is involved into this genital aesthetics and into this field? So going back to the basics, the word plasticos means to mold. So it has no specific organ or system related, unlike other specialties. Suppose gynecology treats with the gynecological or a neurosurgeon or a cardiac surgeon. They have specific defined roles. But here plastic surgery is called as a problem solving surgery. If there is a tissue problem, plastic surgeon will come into that role. So the origin of plastic surgery is the complex three-dimensional loss of tissues. For example, even after the Second World War, the ghastly injuries involving the face, the eyes, the nose, complex of the bone, alveoli, dentine, etc., etc. So they created a problem, and from there the solutions were searched upon, and a tissue from one place to another place was moved into to create the form and function of the patient. So Sushruta is commonly known as the father of Indian plastic surgery, but the Lord Shiva is the first plastic surgeon who did that xenotransplantation to Lord Ganesha. So it is already mentioned, today is Sri Ram Navami, so and we have to pray Rama, but that Lakshmana is a naughty one, so he chopped off the nose of Surpanaka. From there the Ramayana started, and the plastic surgery role also started from there. Even some parts of the country in the ancient era, it is a common practice to chop off the noses of the prisoners and the captives. There was one city or one place in South India where all the people were chopped off noses when the king conquered that place. So then started the necessity, the mother of invention. Then they started the procedure of covering the defect. So various tissues are moved from the cheek, from the forehead, from the arm, like that. So the rhinoplasty was affiliated to the plastic surgeon. So there are so many intricate problems, like you need to bring the outer layer, you need to line with mucosa, and you have to create a mold for this and like that. So there are so many things. That's how the evaluation of reconstructive surgery and evaluation of aesthetics was started. So there are then advancements are made slowly with the better understanding of the blood supply, with the better understanding of the angiosome concept of the tissue blocks. So we are able to provide much better reconstructions and much more better aesthetics. So this is called as a battle between beauty and blood supply. So later we try to provide a more sensate flaps, and then we try to improve the color and contour, and even crevices also we try to improve along with the technology and the procedures. So even including sphincters and the dynamism also we want to reconstruct. So reconstructions are the fundamental procedures or fundamental procedures. So we have to understand, and that is the basic foundation for the upcoming aesthetic procedures. So vaginal reconstruction. So that is the main keystone surgery, and we used to do a lot of surgeries during our post-graduation days. I was a product from Usmania, so we used to carry all the instruments and staff to the maternity hospital there in the Koti. This is around 24-25 years back, the story, and almost every 15 years we used to go there and do that procedure. So that's how we gain some knowledge on the vaginal reconstructions. See, the McIndoe procedure is the commonly procedure described, and still it is the most of the people will do that. So it's a simple graft was taken, neovagina was created between urethra and anal canal and rectum, and lining with a skin graft, and with using a dental stent compound or a condom with a sponge. We use it to inlay the graft. So creation is okay, but maintenance is difficult. So usually it shrinks. So maintenance, the compliance is affected. So maintaining that is a difficult thing. Then it started because of the graft contracture. Then we moved on to a little bit more things like labia minora flaps, with or without skin grafts, or with or without buccal mucosa grafts, to prevent that thing. Like that, so slowly we are evolving into a better and better reconstructive options. Then local pedicular flaps, perineal flaps, pudendal flaps, like that there are so many things are designed. And going into complex perineal reconstructions with mostly with neglected childbirth, or with this trauma or avulsions injuries or electrical burns, they leave gastric injuries. So we need to reconstruct all those things. So we need to understand the tissue behavior, the scar formation, and the future of the scar. Everything we need to assess. So this is the baseline, and this is the background. Then we are qualified to become an aesthetic surgeon. And this is another thing like elephantiasis or lymphedema of the vulva, where the reductions were done to achieve a best cosmetic results. Other things are like that. So this is the key slide. I want to emphasize the aesthetic procedures that are done in this segment, like hymen reconstruction. See, the intact hymen is a sign of virginity. Maybe it is a taboo, I don't know, but still most of the people will follow that. So creation or reconstructing the hymen is what we call a rejuvenation procedure. That is the first one. And second one is the labia minoroplasty. So whether there is asymmetries, or if it is much larger, we can reduce it. And the clitoroplasty, or a female counterpart of male circumcision, what we call the clitoral hood, can be reduced for better exposure of the clitoris. and the key is vaginal tightening that I will explain later. And this G-spot rejuvenation, this is a recent trend, and this PRP or GFC or fat transfer, whatever thing we will do, we will improve we will inject around the G-spot to have a better erogenous feel. And other things are the perineoplasty, whether there are any scars or any injuries, and labia majora and mons pubis, that can be rejuvenated. Either we can do fat transfer or we can do a reduction. And the last thing is the pubic hair transplantation. Most of us heard about these bikini lasers, like laser hair reduction. That is a common procedure we follow. But in some parts of the country, the people will prefer pubic hair transplant of different designs, straight line, furry appearance, like that, depending on their choice. And because I am mostly into the hair transplant, I have once had the opportunity to see this pubic hair transplant. And people are fond of getting hair transplants for the body also, body hair transplants, and some people, they want axillary hair also. And this is the male counterpart, penile lengthening or increasing the penile girth with fat transfer, and testicular implants, scrotal lift. And the more recently is the revision circumcision. The more people are not happy with the previous circumcision scars, and people are coming for revisions to have a better aesthetic appearance. So this is the key one, what we call the nanofat grafting or the liposculpture. So we don't want to waste the fat. We will remove the fat from the unnecessary, unwanted area, and we will keep the fat into the required area. So like suppose breast augmentation, unwanted fat can be moved from abdomen to the breast. Likewise, mons pubis or this labia majora can be augmented with this nanofat. So this is a key slide depicting the vaginal rejuvenation procedure. So you can see the see, the key step here is the double breasting of the fascia, and reducing the lumen with fat graft, and excising the excess mucosa in the posterior vaginal wall, and double breasting the fascia. That is the crucial step in the vaginal rejuvenation. So this is one interesting muscle, the bulbospongiosus muscle. We will try to address this muscle during vaginal tightening. So this arises from the perineal body and inserts into the clitoris. So its main function is stabilization of the perineal body and erection of clitoris. So this is a animation of how we plan the surgical incisions for labia minoroplasty as well as the clitorid reduction. So we need to maintain that smooth texture and smooth outlines for the labia minora and removing the excess unnecessary part. This is another one showing the animation of the vaginal tightening, removing the excess mucosa from the posterior vaginal wall and tightening the bulbospongiosus muscle and closing the perineum. So just this was 10 years back. I was going to demonstrate the vaginal tightening procedure to a postgraduate. So that is the labia majora, and it should be like that, and it is looking a little more patulous, and even that mons is also a little bit hypoplastic, loss of fat is there, and so that is the labia minora, and the clitoris, the clitoral hood. I didn't do clitoral hood detection in this case. That is the urethra, and that is the torn hymen, and lax vaginal wall. That I want to make an incision in that posterior vaginal wall, excising that portion of vagina. So that was the preoperative assessment and planning for vaginal tightening procedure. So so labia minora was reduced in this case. So this is the post-op. So that was reduced labia minora. And that is the inlet, and the hymen was reconstructed, and that is the inlet, and it allows only one finger. Previously it allowed 3 fingers, and I made it 1 finger, and you can see the tightness of the bulbous spongiosum and the muscle and the perineal body. That is essential for the effect of the tightening. So that is the pre and post picture. So these are the indications I did vaginal tightening. So usually before second marriage, and as a part of mommy makeover, addressing the breast, body, and genitalia. And in one case, the asymmetry of labia minora, and in another case, it is a partner factor. See, this body image and sexual health are interconnected, and often they are associated with low self-esteem and the lack of confidence, and they impact relationships, and historically it was a taboo subject, but now it is gaining medical attention. So why it is gaining popularity? That is because of this social media, this fitness culture, lingerie fashion, and sexual wellness awareness, and celebrity influence, and body positivity and media exposure. So people are becoming more and more conscious of their genitalia and genital appearance and function. So, and what we are doing is that we have minimal downtime, and they have safer outpatient procedures and with minimal scars, and there are evidence-based results, and even there are studies in aesthetic plastic journals, surgery journals, and gynecological forums. So these are the references. Thank you.
Thank you very much, Dr. Srinivas Rao, for your very detailed talk and demonstration. I am sure it has cleared a lot of doubts in people's minds about genital aesthetics. Thank you very much.
Thank you. Sure.
I would request Dr. C.H. Shamla Madam to come on the dais and honor our speakers with mementos. I would like the chairpersons also to join them. Dr. Ramesh Baipalli, laparoscopic and bariatric surgeon. Dr. M. Srinivas, plastic surgeon. Thank you.
I request the chairpersons. I request the chairpersons to please hand over the memento to Hazra Ma'am for conducting the CME so beautifully.
Just a moment, please. Gratitude can transform common days into thanksgiving, turn routine jobs into joy, and change ordinary opportunities into blessings. As very well quoted by William Arthur Ward, I would like to invite Dr. Monica, Consultant Fertility Specialist at Vizag IVF Center, Visakhapatnam, to propose a vote of thanks.
Good evening, everyone. It's my honor and privilege to deliver the vote of thanks on behalf of the organizing CME committee for today's enriching session. First and foremost, I would like to thank our distinguished speakers and senior professors from OGSV and teachers, delegates, and our friends who have attended and brought an immense value to this program. We hope this knowledge shared today helps in elevating the patient care, and I would like to extend our deepest gratitude to esteemed sponsors Organon, Zydus, MSN, Mindray, Technomed, and Sanofi. Your generous support and unwavering commitment to advancing medical education and continued collaboration make events like these possible. Your contributions are not just financial but truly instrumental in strengthening the bridge between the industry and clinical practice. I would also extend the thanks to the 4 Points administration for the excellent ambience and food. And last but not the least, I would also thank the Done Pharma Company. I would also extend the warm gratitude to the technical team and also audiovisual team for your excellent cooperation, and I look forward to work with you all in many more and educational ventures. Wishing everyone continued success and good health. Thank you.
So every ending is a beginning, and ends are not bad things. They just mean that something else is about to begin. With this, I conclude today's CME with the hope that you all have lots of carry-home messages to improve your day-to-day practice. Thank you, one and all. Thank you for the last runners who are here. Thank you.
Thank you.
This meeting as a successful with the help of Azra madam.
ఎక్కాలంటే కష్టంగా లాగాలని ఫాలో అవుతుంది మా లాగం ఇదంటే ఎక్కాలంటే కష్టం సేఫ్గా మనకి సెకండ్స్లో కార్డ్ వేసిన ఆపేయాలండి థ్యాంక్స్ ఫర్ వాచింగ్ అండి